us a sense of what NCD is from the eyes of AstraZeneca. What is this thing called non-communicable diseases? Welcome.
Thank you very much. And thank you once again for the invitation. And it is great to be part of this panel. So I'm Barbara. I'm based in South Africa. I'm responsible for South Africa, Sub-Sahara Africa, and French-speaking Africa for AstraZeneca. And yes, the non-communicable diseases is a huge, huge challenge. It's really this next big wave of a pandemic, in a way, that we will see in Africa. The non-communicable diseases such as diabetes, such as asthma, such as cancer is really a huge, big challenge for us. And I think it's very interesting also the sessions that was had yesterday around the public-private partnership. I think this is probably the area where it is so important that we hold hands for us as a private company, but then also with the ministries of health and with the NGOs and with other groups within our countries in Africa. And as AstraZeneca, we've done quite a lot in that area. I don't know if you want me to elaborate a little bit on that. But yeah, the non-communicable diseases, this is really the challenge of the future. And the issue is very often, I think that they sometimes can get sidelined a bit because the communicable diseases such as HIV/AIDS, such as Ebola, such as what we've just recently seen with COVID and are still seeing with COVID, sometimes takes over and it becomes the immediate crisis that we need to deal with, where the non-communicable diseases builds over time. And I think this is the key where we really need to get proactive in terms of how we manage that and how we collaborate to manage that for our patients in Africa.
Thank you, Barbara. Let me ask you something very specific. For most people, when we read the name AstraZeneca, we see manufacturing and we see somebody who wants to sell the products to us. Is that the only thing that AstraZeneca does, sell the products? Or are there things that are more than that, that could help in the overall management and mitigation of communicable diseases?
So thank you for that question. And yes, I think, well, it's very often with the manufacturing, and I think at the same time in Africa as well, the association with the vaccine, that has really taken the forefront in the last, I would say, 2.5 years. So my view is always that treatment, like medication, actually comes very late in a patient's journey. And there are many other things, such as awareness, such as diagnosis, that I think are absolutely critical areas, especially non-communicable diseases that we should focus on. And this is where AstraZeneca have also built strong public-private partnerships over the last, we've been in Africa for 3 decades, but especially over the last couple of years. So for instance, something like the AMREF, the AstraZeneca, the solar-powered mobile clinics that we're currently rolling out in Kenya, at the moment, very much focused on taking the vaccine to the last mile into the rural communities, into the areas where people sometimes need to make that choice between, do I queue at a clinic or do I actually work today? Because maybe I'm selling fruit or I'm working in a market. So what are we able to do there? The longer term view would then be to use these solar-powered mobile clinics, also looking at non-communicable diseases, taking it into the community, raising awareness, spreading the word in terms of the symptoms that people need to look for things such as diabetes, for certain cancer types, and then using those mobile clinics to actually be able to screen people there on site. Another program that we have is, for instance, the Young Health Program, where we say that very often with communicable diseases, it's the lifestyle changes that we can make early on in this category of 16 to 24-year-olds, where we can have a really significant impact. And the Young Health Program has reached about 1.1 million young people across the globe. But specifically, if we look in Africa, in Kenya, the program has actually delivered remarkable results. So how it works is it's about finding the community individuals that is almost like a community educator, 16 to 24-year-old, that then goes into their community with specific messages around healthy lifestyle, cessation of smoking, exercise, what we should do in terms of what we eat, etc. And just to give you some of the statistics in what we've seen in the first wave of this program that we did in Kenya, we saw a 40% decrease in tobacco use in the community in Kibera. We saw a 55% improvement in diet and a 5 times improvement in terms of physical activity. And the indications are that the second phase that we've kicked off together with our partner, Plan International, is actually showing the same results. Then another program that obviously in East Africa actually spans most of the countries is our Healthy Heart Africa program, which is about early detection of hypertension. Still one of the biggest killers for us in Africa. And here, once again, we are working with our partners. We've trained more than nearly 150,000 healthcare workers, and we've activated around 3,500 health facilities. And more than 25 million screenings of hypertension has happened. And as you can hear, many of these programs have nothing to do with medicine. It has everything to do with the awareness, the building capacity in terms of educating our health care providers, and then doing active work specifically around screening and identifying patients. And the Healthy Heart Africa program is now active in countries like Uganda, Rwanda, Kenya, Ethiopia, and Tanzania. And then we're doing similar things also in the asthma space. So this for me is something that I feel very passionate about, is we need to find the local partners on the ground and that can really help us. So it's not just about the medicine. As I say, the medicine happens very late. It's actually the earlier stages of the awareness that the patient goes through, the diagnosis of the patient, and in the process, then also supporting through public-private partnerships, the ministries of health, the governments, the NGOs, to build the capability and the capacity in the country to do that.
Thank you very much. And I think for the audience here, mark the important things that Barbara has put on the table. The public-private partnerships that can address the issues of diet, tobacco and alcohol consumption, physical exercises. 3 things that we often don't put at the forefront, which allows me now to ask Betty. Betty, you're from PATH. What does PATH see in NCD in Africa? Why would you be interested in NCD in Africa?
Thank you so much for the question. And we are really happy to be here as PATH. And the NCD space is an area where PATH has been working for a long, long time. And particularly to your question, we see a number of issues, and I'll just highlight about 3 issues that are really pertinent and that keep us and compel us to continue doing programs in the NCD space. One of them is really the diagnosis. I think we know, and we have found in many instances, people find out that they have a condition accidentally. Maybe there is something that's happening that's out of the routine, and then they happen to find out, or when there are complications, or when they have reached a very critical stage and unable to do certain things. And so I think we feel that the diagnosis, the lack of it, the untimeliness, the opportunity to be able to find out as soon as you have an issue for the general population, I think is a big problem. And that's one of the things that keeps us interested in this space. The second one is the access to treatment, and probably the continued access to treatment. It's one thing to have access to a few doses for about a month or a quarter, but for a chronic illness, for you to be able to access lifelong treatment or to get you to a point of being fully controlled, I think is a challenge that we see in this NCD area. And I think it varies from so many places. And I know many of us who've been through facilities, who've gone to the public sector, but who've also gone to the private sector, we find that the access and the continued access struggles quite a bit in many instances. And I think we saw a big issue during COVID. During COVID, I think that was a category or a group of people that were really, really challenged around being able to seek for ongoing treatment, being even considered among those that should be allowed to visit hospitals or facilities, or even being provided with some unique way of being able to access ongoing treatment during that period. So that the access to treatment and probably continued access. And I could bring in a bit about cost as well, especially for those that have to access it from the private sector. I think we have varying situations where people are not able to keep up with treatment because they cannot be able to pay up, especially when they access this through the private sector. And the last one is something around routine monitoring. We know that for NCDs, it's important for patients to continually be monitored, to continually be checked and supported. And we find that that may not be very accessible in many places. I think for those of us who are probably in the urban settings, it's something that we can easily access. But when you go to areas which are really in the rural settings, areas in the lower level facilities, areas, if you talk about islands or specific places of that kind, it becomes a completely different story. And so we see these as areas that are a big challenge within the NCD space. And I think we all have a challenge within the health worker space to be able to increase the access not only to diagnosis, but to treatment and to routine monitoring. I keep looking at things that have penetrated our market in the recent past in a very, very fast-paced process, if I may call it. I know we all have mobile phones and we access airtime or we buy it. And previously you had to go to specific places to find airtime. But currently you almost can get airtime anywhere. I know we also buy it in sort of a digital way now, but it's sort of improved and penetrated all the spaces in this country, and people from every geographical place could access it. Maybe we need to think with an open mind within this space and see how we can make everyone that needs the treatment and the ongoing routine monitoring able to access it.
Thank you very much, Betty. You brought in an angle that's extremely important here of diagnosis, continuous treatment with continuity and monitoring. Challenges all around. Eric, over to you. USAID logistics. What are the logistical challenges that you see sitting between what Barbara has talked about, the lifestyle, the prevention side, to the treatment, diagnostic side that's here? And what would private sector be doing in that space?
Thank you. My name's Dr. Eric Lugada. I'm an epidemiologist, specialized in epidemics, managing epidemics. And I work for USAID-funded strengthening supply chain activity. Now, ironically, when we are speaking about chronic non-communicable diseases, we have the big four. That's the cardiovascular disease, we have cancer, we have type 2 diabetic, and then chronic respiratory distress syndromes. The ease of access to commodities and development, which simplifies logistics, does actually sometimes culminate into acquisition of these non-communicable diseases, which is the irony of it all. With development and eradication of poverty, we're seeing that our lifestyles are changing because we have easy access to processed foods. We end up eating more sugar, eating more salt, eating more fatty foods, and probably living sedentary lifestyles, not exercising, which ironically is access to easy things. Now, that there and then we begin to have logistical challenges that by the lifestyles, by development itself coming into our space, we begin to predispose ourselves to acquiring chronic non-communicable diseases. And so critically for the private sector, I think the private sector has a responsibility at the community, at an individual level. One, the private sector is the biggest employer, is the biggest provider of jobs the world over. Government normally handles 20 to 30%. So they provide employment, they provide gainful resources for families, they provide products which are used in the community, and they provide taxes which sustain governments and keep them, which sustain governments and keep the governments, they augment the resources that the government have. So at that point in time, since the private sector is a critical player in terms of development and in terms of improving health, right there and then they have a role to play. One, in helping to create awareness of the lifestyle in spite of easing the lives of people. But also some of the products which are sold, some of them are processed with too much sugar, too much salt, too much fat. By labeling the commodities and warning us that this product contains this, or even producing products which are not harmful. That's one. The other way, because they employ a majority of job earners and people who look after families, we have the mandatory requirement for workplaces which are safe and conditions which are safe. That's one way. But beyond that, provision of health insurance, provision of access to care. The beautiful thing about chronic non-infectious diseases is that they are non-infectious and can be found early. Unfortunately, by the time you're discovered to have the disease, it's too late. If you have symptoms, it means it's too late, almost too late to manage you. Now, when it comes to that level, the logistics challenges are immense. They are chronic in nature, as the word says, they are not infectious, and their management is long-term. Now, they cause two things. One, they are debilitating. They reduce the ability of the individuals to perform. And we are seeing increasingly that in the developing world, the chronic non-infectious diseases are coming in the underage, below age 70. In the past, they used to associate it with old age, but this is coming down because of improved lifestyles, improved good living. And so it's critical at that point in time that we avail the screening services. So the logistics of providing screening when somebody is not sick. By nature, we do not go to hospital and nobody finds it useful to screen us for any disease, especially if you have no complaints, you have no pain, you are well. We all think we are well. By the time you come down with a symptom or a sign, that's late. So the logistics of ensuring that the population has access to screening services, whether they are sick or not, in whichever environment they are, that's a very critical point. And I think the private sector has a role to play. Some of these screening services are very simple. They're not very expensive. We have point of care diagnostics. We have health insurance. If we integrate these in caring for the employees and their families, that could help in terms of providing the logistics to screen people. And it's critical because a safe employee, an employee who is active, benefits the business. The business makes more profit. You have less people not showing up to work, so you increase your productivity and then you produce more products and you make more profits. So if we multiply the ability for the private sector to provide screening services for their employees and families, we can be able to overcome the hurdle of logistics. Now, the final stage is if you're sick and you've come down with a chronic non-infectious disease. Now, the management is normally chronic, as the name implies. Not only is it chronic, but it is difficult. For those, unfortunately, who suffer from cancer or hypertension, you are on long-term medication. And sometimes the medication fails. You have to keep going to the hospital all the time. And that's a cost to the individual and their families. It's a cost to the society, but it's also an expense to the community, the country. If we spend resources and non-communicable chronic diseases, treatment is very expensive. So if you're going to spend resources to care for 40% of the population and you're faced with infectious epidemics, it's a difficult thing to play. So that process of getting the medication and maintaining on medication for long, which is expensive, drains the individual their families, the community, and puts a big burden onto society. So the logistics of availing medication, logistics of accessing long-term medication with the chronic is critical. And what can the private sector play in that role? As I mentioned earlier on, the preventive approach could help, but also to keep a chronically infected person active and alive is also important because it improves productivity and keeps the person working. So if the private sector can provide insurance, and since we know 60% of the population is employed by the private sector, that could help. And then the final aspect of it is the research, which goes into monitoring and developing new products that can safely and efficiently manage chronic infections. These drugs and commodities for managing chronic infections are difficult to come by. They are not at all 100% efficient. And so investment has to be made into research and development, producing new products. There's a pill, I think in India, the Polycarp or Polypill, which is thought to be preventive. And such investment is required in the sense that if you take it early, you prevent the onset of chronic infection. It has generic components which can prevent chronic hypertension, I think it's also laced with aspirin and does many things. So this research is expensive. And for businesses, because they look for the longer term, they are not dependent on political endpoints. You invest in business. I think there's a popular saying that when you start a business, the first 3 years, you're making losses. So businesses private sector goes into business for the long haul. So if the long haul would involve also investing into products, new technologies to monitor, to prevent, to manage, and be able to keep the population safe, I think that would be something that could also help not only the businesses improve their productivity, improve the range of products they are providing, improve the profits they make, and at the same time be able to contribute to the development of the national economy through increased taxes and keeping the population healthy and growing. The more people you have, the more you sell. If the people are healthy, the more you have an active working group. And so everybody wins. It's a win-win, but requires some level of investment, not in the short run, but for the long term. Thank you.
Thank you very much, Eric. Barbara, are you still there? Barbara, are you
Yes,
still there?
I am here. I've been listening. Very interesting discussion.
I am sitting here with a hall full of African entrepreneurs, East African entrepreneurs who want to do more effectively and sustainably. Give me 3 examples from AstraZeneca of things that you have supported, support, or think of supporting that they could join you in, and we could consider to be best practice in making NCD diagnosis and management possible. They are looking at you right now and they're writing, and whatever you say, they're going to take you up on it. Over to you.
Good. And I think it's exactly forums like this where I think this piece around bringing all the different role players together into one forum is so important. So I think the first thing, for example, that we're doing is we've worked with companies like a company called Futurize, where in the last, specifically thinking from the entrepreneurial perspective, where in the last 6 months, we've ran projects where we've connected universities across 11 sites in Africa, and we've given the young students, so there's sort of really the millennials, a challenge to say, okay, from a digital perspective, come up with an idea around specifically looking at the diabetes patient and then also the cancer patient, something in the patient journey that you could address with a digital solution. And then in that week, there was several engagements. I participated as well. Our medical team participated to, in a way, educate them as they went through the thinking. They had mentors that worked with them. So that's, for instance, things where people in the audience are maybe linked to universities, where if we were to run a project like that again, and they are keen that their university maybe joins, that we can then look at it. And then obviously we take these ideas and we say, okay, it's in this week, it's been worked up as a concept, but let's now actually see whether we can, bring this to fruition. And this is the thing within AstraZeneca, we have this network called the A-Catalyst Network, where we then specifically look at the innovation and what we can do there. I think at the same time, and it's great to have somebody from PATH there. For instance, PATH is actually our partner for Healthy Heart Africa in some of the countries, and especially also in French-speaking Africa when I was there last. So I think there is also the continued work around exactly what all the speakers have said, the importance around the screening. So whatever we can do to work with individuals that either work in NGOs, work in groups, where we can say, if we don't have a program like Healthy Heart Africa live in a country yet, what more can we do? Or if there is a different region, etc., that we need to look at, that we can work on. And then I think, yes, at the moment we're doing it in Kenya around the mobile clinics, but if the concept really works well in Kenya, it's then also the expansion. So where could we potentially look at partnerships around that also in the future in other countries? We're very keen often to say, let's start in one country, let's learn. If something fails, it fails fast. But then from there, we're then able to move on. And I think maybe the fourth area, if you allow me, is probably then also around the asthma care and cancer care. Both of those, I think if there are ideas that hospitals have where they say, hey, we have a problem or a challenge here, let's sit together and let's see how, not just for that hospital, but where we can maybe look at something that's a bit more systemic that we can do in a country. Let's sit down and talk about that. We have the Africa Pumua initiative running specifically at asthma, looking at asthma. We focused on Kenya and Ghana initially. We're also expanding into Ethiopia, some of the French-speaking African countries, where we're really looking at capacity building, screening. So for instance, spirometry, etc., what more needs to be done there. So I think if there are some ideas that get sparked off from people, those are all areas where we would very much want to sit down with partners and look at what we can do. I
Very
hope
much.
that's food for thought.
Yeah, thank you. I'm glad you mentioned PATH, and PATH is sitting right next to me. Betty, they're Ugandans entrepreneurs here. And you are in this elevated position where you are innovating and so on. What would you invite them to join you in their clinics as individual clinic owners, in their societies as people who lead medical and health associations, and in their businesses as people who are investing in health? Mention has been made here of point of care diagnostics and so on. What would you want them to know now so that when they walk out of here and they go back to where they are, they're going to act differently?
Thank you very much for the question. And it's I think, a great opportunity that we have the wide team in here. And I think you rightly said they have a pen and a book to write and take things away. So we will share a few innovations, and I'll basically start from one of our pieces of work around diabetes. We are working on a diabetes care pack, which allows a patient to have everything around routine monitoring, the strips, and whatever it is that they need, and then the medication package together. And what we've done is to make those designed as per the country's needs involving patients. And there is an ongoing piece of work happening in Uganda that will be developing that care pack for patients who have diabetes. I see this group as one that can actually take that further once we've concluded the process of building what that care pack should look like. And the building or the process of putting it together involves both health workers, but it also involves patients. So we have a chance to hear from everyone that's involved in that piece of work to be able to tell us, this is how I would want the pack to be made. This is how often I want to pick it up. I would want the medicines and the, everything that I need for the next 3 months packaged in one box. For the pieces of work that have happened in other countries, they've gone to the extent of even saying the box shouldn't be so big. I need to go to the market with it and things of that nature. So all that allows us to get the patient perspective, but also the health worker perspective. And once we have a care pack that is fully developed, then I see this team as one that can actually take it and use it as far as they can take it with their clinics. But the other part that I would want them to sort of come on board is the exploration of other areas of service provision. I think Dr. Eric pointed out that we routinely don't go to hospital. It's sort of built into our culture that you go when you must. Even for a woman in labor, they will keep telling her, just wait a bit until the pains are serious, and then you will go. So we have that tendency to postpone until we must go. And I think that sort of precipitates a lot of what we see. And so there's been quite a bit of thinking that has gone into some of the programs that we are doing. And one of the areas we are thinking about is the work health within the workplace. I know many of us have different workplaces and we spend quite a lot of time there. If we compute the hours we spend at work, sometimes we spend more time at work than we spend at home. So we probably have a chance within the workspace to be able to bring a lot of this routine monitoring, diagnosis, identification in place. And I believe that with how overwhelmed our public sector setting is, the private players within the health space have a big chance, or they have a big opportunity to get into the workplaces, to get into, I'll start from the markets. When you go to the market, you see ladies that go there at 5. We see gentlemen that go there at 5 and leave at 8 or 9. So they've spent over 12 hours of their time there, and they will do it from Sunday to Saturday. And so we have an opportunity to establish some kind of care plan or health program within the space where they spend most of their time. If we sit back and wait for them to come to us, I think we are still going to wait for a little longer than we have waited before. But if we try to attempt to go to them, I think that's a piece of, that's a part of the care program that we can bring in. So we would want to just, we are still thinking about how some of those programs would run. They will be different, I think, in different places. The way you do a market-based program is probably different from how you do a school-based program. I know that the Ministry of Health and the Ministry of Education have really tried to bring up and to strengthen the school health programs. And in addition to them focusing on children, on the students, there is also a part of the other teachers, the non-teaching staff that are within those spaces that we can work through and also provide services to. So that's a part that I would invite the different players. It's much easier for them to think through and see how services could be able to grow into those areas, because already our public sector settings, our facilities, our hospitals are really, really overwhelmed. But this team has an opportunity to get into that space.
Thank you. 3 questions with a gender bias. 1 from this side, 1 from the middle, 1 from this side. And I can see a hand, my goodness, I can see 6 already. I start with the lady in red. And then I'll go to the other end. Please pass the mic quickly. Make it brief. Make it clear. And introduce yourself.
Thank you, Professor. Mosimenta Unique. I work as a community engagement officer with the Uganda Sickle Cell Rescue Foundation. It is a civil society. It is an NGO that was started basically take the gospel of sickle cell across the world, Uganda in particular. I would want to ask Dr. Eric Uganda, according to the Ugandan statistics of sickle cell, which is regarded as a non-communicable disease. I thank all the speakers for what you've said, but I've not had any person talking about sickle cell. We are the fifth. We hold the fifth position in the whole of Africa. Uganda in particular, we are the fifth country in sickle cell disease. Every year, this is by the research that was conducted in 2015. Every year, we lose 20,000 children to sickle cell disease. They don't make it to their fifth year. I call upon Path. I would like to see how you said as a logistical partner in this. How do we curb sickle cell disease in Uganda as a non-communicable disease?
Thank you very, very much. I couldn't agree with you more. And even if it means we do 5 more minutes on this area, we will do it because I know they will not remove me from the stage. Sickle cell is a big, big problem in this area, and we're going to answer that. Eric is preparing. The next question at the back.
Thank you very much, moderator. My name is Patrick Edet, the ED for Uganda Cancer Society, but doubling also as Executive Director of National Cancer Awareness Organization. Now, a quick one. We are all very much aware that health is made at home. It is only repaired in the hospital when it breaks down. And it is everyone's primary responsibility to make this health at home. But how much are we doing? Now, why am I saying this? Both the private sector and then government have not put more emphasis on NCDs management as a continent, as East Africa. But I'm going to speak on the perspective because I'm in Uganda for Uganda. I don't know whether there's a representative from the Ministry of Health here in the House. Now, prevention is better than cure. The President of the Republic of Uganda has been an icon to champion issues of prevention is better than cure because you say we may not manage to contain these cases of NCDs when it escalates. But how much emphasis are we putting on prevention? Yes, we're talking about diagnosis, we're talking about management and ABCD, but how much have we done on prevention? In 2020, Uganda Cancer Institute, I'm speaking because I deal with cancer patients, recorded 7,800 advanced cases of cancer. If I'm not mistaken, all of them perished. They were all brought to the hospital or they came at an advanced stage. Now, but the government keeps on pumping more money to Uganda Cancer Institute to treat people who are already being taken to palliative care. The other day, we had a visiting professor from America, senior oncologist. He was perplexed and confused about our health programs here as East Africa. When you go to the wards, STC ward at Uganda Cancer Institute, you will realize that only advanced cases are admitted. Now, patients who are at stage 1 and 2, they are languishing outside verandas. He was confused that for us in America, advanced cases, already those ones, we push them to palliative care. Then we bring people who are stage 1 and 2 in the wards for management, because there's something to be done to them. But unless we change this trend, we focus on prevention is better than cure, we're losing the battle. Thank you very much.
Thank you very much. And the final question, please, if I don't ask, is that South Sudan? There's there, and then we'll allow South Sudan. And it's not because I don't want you to ask, it's just because Ian doesn't give me enough time to give you.
My name is Robert Twaswa, and I'm working with Hand to Hand Mad Purpose Initiative
Yes.
in the capacity of program coordinator. Non-communicable diseases such as cardiovascular disease, cancer, diabetes, and chronic respiratory disease are a major source of preventable illnesses, disability, and mortality. They place a significant burden on health systems, presenting a challenge to universal coverage, health coverage, and other development aims in our communities, and force many people to face the worst of conditions. What can we do to promote effective and inclusive governance for health amidst non-communicable diseases?
Thank you. South Sudan, sir.
Thank you, Prof. I'm Dr. Oromo Francis from South Sudan. I think I would just like to summarize the whole problem into 5 points. That these challenges of this lifestyle disease, which are very, very disturbing, are as follows. One is the infrastructure. 2, the economy. 3, the demography. 4, management. 5, politics. I am directing these questions to Dr. Barbara and Prof. yourself. Dr. Barbara, you are a manufacturer. You are leading a manufacturing institution. What will be your role in the intervention to help in the prevention of these NCDs? And Prof, the other points are for you. What can you really guide us, both in the private sector and the public sector, in fighting these challenging conditions? Thank you.
Very, very much. I think that let us start with the epidemiologist here, and please do address the sickle cell menace as well in your response.
Thank you for your questions, most appreciated. I think I want to mention
Can you hear him at the back?
I need to mention one thing, that one, there are many conditions which affect our community, and the breadth and size of them ranges. And one of the challenges we've had in the past, that because we do not have a lot of resources, we tend to prioritize what seems to be urgent at that point in time. And then it appears like it's the buzzword, or it's the biggest thing. I mean, look at, for instance, infectious diseases, HIV, TB, malaria became big. So to everyone else, it may appear that that's where we are laying emphasis only, but no. Now, for sickle cell disease, yes, it's one of the chronic non-infectious diseases, but the other 3 are the bigger ones. Now, that doesn't mean we don't pay attention to it. What do we need to do? Luckily, as I mentioned before, this sickle cell disease can be controlled at source. If you did a blood test of intending partners to be married, you can make a determination at that point in time that the outcome may be debilitating. And so you would advise the couples not at that point in time. So what is lacking there is awareness and availability of information, but also availability of the ability to test simply. Say if you're in the village, how can 2 partners intending to marry test and see that their blood are not going to result in an offspring who is potentially sickler? Now, that availability, how does the private sector come in? The private sector can by embracing new technologies, moving towards the Industrial Revolution 4, probably 5. We are now going into super smart Industrial Revolution 5, where we use artificial intelligence, and we also use a big data and Internet of Things to detect, for instance, cameras, thermal sensors. They can tell who has fever, and they can even determine the distance with the advent of COVID. How far apart are you to be less infectious? So could the private sector help to generate simple diagnostics which can be applied quite easily to prevent the unfortunate or the unlikely event that a child born out of a union can have sickle cell? That's a critical endpoint. Given that, the second one would be, how do we manage this in case people choose? Because you can still go ahead and decide to marry, because there's a 50% chance that the child will be sickler or not. And if you take that risk and you get a sickler, then how do we manage that sickler? And yes, it's a concern. It needs to be managed, but that should be managed amidst all the other concerns. You heard about the Cancer Institute. Many people, before we used to think cancer was a disease of the developing world. No, lo and behold, it's here. We are seeing people aged less than 70, as young as 40, developing all sorts of cancers at the moment. And managing cancer is quite difficult. Yes, we can prevent again, but screening is very, very critical so that we don't end up with people who are beyond end stage, stage 4, where you can do nothing. And that's critical again. It also helps to advance the technology to be able, and we can make that technology simple by embracing artificial intelligence, use of robotics, and even nanotechnologies at atomic level, where you can easily do gene mapping. If somebody has cancer, to diagnose cancer takes a long time. You have to pull a piece of tissue, you have to identify which tissue to pull. But with nanotechnology, you could probably get these markers. So can the private sector invest in simpler ways for the long term? That could help. And should the governments embrace and be able to invest as well in prevention? So the critical thing for us, prevention and health promotion, is definitely better than cure. Now, there's no one entity. When you talk about good health and improved economic situation, the three big players must be in play. That's the public sector, the private sector, and civil society. We have not reached a time where that intersection is happening. And this is probably the time, because many of these NCDs can be prevented if the three entities are working together and synergistically promoting health, preventing health, supporting use of diagnostics, and availability of commodities. I think since the private sector is starting, we could advocate to government and the civil society. Those three actors need to be the Millennium Development Goals of 2000. Number 8 emphasized the partnership for development and good health. And in that, they emphasize the private sector. And ironically, they also say the pharmaceuticals and new technologies are critical. And we've seen this happening. So there has to be an intersection. And I think it's time for us, whether we push it from the private sector, to advocate not for single diseases, but for an integrated approach, which brings together the public, private sector, and civil society. There's another disease, which currently now I think is the highest cause of mortality, especially in Uganda. It's not a disease, but it's a condition, and that's the chronic road traffic condition. The wards are full of border people with broken bones, and there are more patients, in fact, from that chronic condition than the disease. So how do we hope to address that?
Thank you very much, Eric. Barbara, I'm trying my best, but I'm failing in my effort to convince the audience here that AstraZeneca is not just about selling medicines. Can you, within the context of the questions being asked, please place yourself at the center of the problem?
No, and I absolutely understand where the audience is coming from, because that's in a way what you see. But maybe what is not that visible is also the question around solving the NCD challenges starts with us as a research and development organization. The science that we are bringing, that eventually then translates into the medication that we bring into countries. The commitment that AstraZeneca has across cutting-edge research that continues in areas such as diabetes, such as respiratory care, such as cancer and oncology. And then I think the examples of the programs that I've given, I think really speaks to how we go very much beyond just the medication, where we know that if we are just going to focus on the diabetic patient that gets an AstraZeneca molecule for treatment, we're completely not playing in the right place and in the right field. It is really about the programs that we have, the screening programs, for instance, such as what we're doing in hypertension, what we're doing around capacity building for diagnosis around respiratory care. We are equipping hospitals, for instance, with nebulizing machines, where in the future we will be equipping them with spirometry so that they can correctly identify the patients. And I have to say, though, I think the PATH example of the box for the diabetes patients, I would love to have a continued conversation after this about that, to see what more can be done there. And I think that is the key thing. But at the same time, we as AstraZeneca, we can't do that on our own, because we are not the experts in terms of how do you on the ground in that community center or in that community, how do you set up that hypertension screening, what needs to happen there. And that is where the partnership, for instance, with organizations such as PATH, such as, our Plan International, for instance, some of our partners remain absolutely critical. And we as a company look far beyond just the financial year in, January to December, but we are looking at these programs around prevention of non-communicable diseases as well. And we will continue to do that. Maybe what I'm also taking away from the comments today, maybe we should also create forums such as this where we can talk about these things more frequently, so that there is almost not this branding that happens around, well, this is the partner, this is what they do, this is the only thing that they do. I would say 70% of my time as the country president for AstraZeneca is actually spent with teams working on this piece around the integration of the patient journey, the earlier treatment, the diagnosis, what more we need to do there. And for us to hold the mirror up to say, we can't just be a commercial organization that is involved in, in the medication that we sell. One of our core values is around putting patients first. And I think that is the one thing that we all have in common. So let's work together. If there are any people that want to reach out with some great ideas, innovative ways of how we can approach things, we are all ready to listen.
Thank you very much, Barbara. And Beatty has gracefully accepted to step in for the Ministry of Health and answer the questions that are raised from the Cancer Society intervention.
Thank you so much. And I think there were particularly two questions, one from Patrick from the Cancer Society, and I think we had one from Robert as well, asking how governance could actually help, and then wondering what the Ministry of Health is doing. With our work on diabetes, we actually engage quite closely with the Ministry of Health, and the Ministry of Health is part of a global coalition that works on NCDs, and they have a couple of members from here that sit on that global body that sort of sets in place and puts in place new innovations, but also advances in medicine that are really focusing on NCDs globally. So yes, they sit on that committee and there is a focal point person. I'm not here really to speak about him, but I just wanted to bring that information here and probably relay back to them around the interest that everyone here has about hearing and getting to know more about what's happening at the center. I think one of the issues that we probably see from time to time is because of the expanse of activities, we may not routinely have chances of hearing what the Ministry of Health has and is out doing within the different places in the country. But finally, from the question from Robert around what needs to be done on governance for NCDs, I think there's a lot that we can all do around awareness and advocacy. Being able to bring out the data that we have, the statistics that we have about what's happening in the country so that everyone is aware. I think we sort of in a space or in a situation where we don't routinely look at our data frequently or even be able to take it beyond just the collection, but also do a bit of analytics and understanding what the data is telling us. So I think we all have, there's a bit of work around there, increasing the advocacy fronts from the different areas where we sit, but also increasing our awareness and being able to utilize the stats as they come in. And I think the players here from the private sector could also do a very big role in being able to transmit data from the private sector into the public sector data system so that we have a full picture around the country.
My summary, and it's provoked by South Sudan, and the question on sickle cell disease. I'd like us to adopt a new term, neglected non-communicable diseases. Because sickle cell fits within that. Road traffic accident fits within that. Because we seem to describe non-communicable disease in the way Europe and America defines it. And we leave it to the big three: cardiovascular, cancer, and diabetes. But anybody who has grown up in this part of the world knows the challenges of sickle cell disease. Huge, huge. And of course, the road traffic accidents and border, it's just a pandemic on its own. So I think we need to refocus on things that are relevant to our areas too, apart from everything else. To the question of the 5 issues that were brought from South Sudan: infrastructure, economy, demography, management, and politics. I've only one comment. Every East African politician of note that I know of suffers from an uncommunicable disease. If you know one who doesn't have an uncommunicable disease, please let me know by the end of this meeting. And they all go for care either in the private clinics that we run, very few of them go to the public facilities, or we arrange for them to go abroad. That means that we have an audience there. What do we tell them when we recommend for them to go to India? Do we remind them that there are some people who cannot afford to go to India? What do we tell them when we give them a prescription to get insulin from a private pharmacy? Do you remind them that there are people who cannot afford to buy insulin from a private pharmacy? So the advocacy work that we can play in various roles go beyond treatment and programs. And I think that this is where Eric was coming in to say that the combination between public, private sector, and civil society, with a focus on some of the communicable diseases that are common to us but are not global, is the way to go. Time is not on our side. Join me in clapping heartily for this group. Thank you very, very much.
I'm just asking Kama here what the average life expectancy in Kenya is. He doesn't know, actually. He's probably gone, you probably exceeded it, Kama. But I have a friend who's in his 60s, and he told me, he's younger than me, and he told me that, he said, you know, I'm actually older than you if you take your life expectancy, because the average life expectancy in Uganda is what? It's 63. A lot of that is contributed to by non-communicable diseases. Of course, many, many other things like these non-communicable, the neglected road traffic accidents and so on. But, and one thing I don't know if it was said but not picked up very strongly, was the role of exercise It's becoming better. I see more people taking exercise, but I think that's a very proven point in terms of prevention, that if we exercise. So I'm going to give Janaya, please, from the East Africa Health Platform. We have a platform in the East Africa community in Arusha, and Janaya runs the office, and sometimes it's not well understood. So she's going to just take 5 minutes and tell us about what she does to the benefit of us all in the federations. Thank you, Janaya.
Thank you very much. Hello. 5 minutes. Someone told me opportunity finds you in the dancing hall, but if you're in the dancing hall without the right shoes, it becomes difficult to enjoy the music. So I'm going to use the 5 minutes to talk about the opportunity that we all have to bring all these beautiful minds' conclusion into places that matter. We can talk among ourselves days and days. If it doesn't go to people who make decisions, if they don't translate into practice and ultimately make it into decision rooms, then it becomes we talk here and here. So the East African Health Platform was established in 2011 as part of the regional dialogue to find out how to bring into practice the EAC Article 118, cooperation around health, but also the famous phrases of people-centered economic integration and private sector-driven integration. So the platform brings together profits, non-profit, everyone is about value, but then interest groups and professional associations. Literally, everybody who is not government is part of the platform. Why do we need it? Business prior was about presidents and technical officials sitting in one place, making decisions. And then I remember back then I was part of some of the civil society engagement where we sat in corridors waiting for a certain minister during tea breaks to come out so that we can talk to someone who can hear our voice and go in and talk for us. Now that ended when 2013, the Business Council, IACSO for civil society, the Apex body for health, non-state actors were put in place. The way the EAC works, there are technical working groups, there are ministers in their councils. That way goes all the way to the official, the presidents. You've heard about the summits. They go by delegation, but today I want to ask you, among us in this room, how many of you do go to the EAC meetings with a national delegation? Can I see a show of hands? Is there any, if you're not government? National delegations, are you part of it? Okay, so governments have delegations, 5, 6 ministries going to the discussion room, and us through the health platform, we have space already acknowledged, is there by the CD, the Community Strategic Dialogue Framework space for us also to engage. What we do as EHP, we bring together everybody who is not government to be able to do what I call the 4 Ps. One is about the public, private, and the other one is the private. Here we are dialoguing mainly among ourselves. So we do interest representation, which is about advocacy through the structured systematic processes to input into policies and legal reforms within the EAC as a secretariat in its institutions, but also the East Africa Legislative Assembly. We also do constituency development, which is supporting among each other to be able to improve, to grow, to put structures and systems to place so that we can harmoniously engage, present our interest. And finally, the institutional growth and learning for our institutions to be able to grow. Our entry point or our key messages should be rallied around access to health services, which is about the right to health. The second piece is about marketplace, which is looking at the common market of the EAC and how we engage. So I will end it at this. East Africa Health Platform is in Arusha for proximity reasons. We have an office. All the healthcare federations are part of us. They are part of the board, and all of you are invited to engage. Let us dialogue, but then take it home to where decisions are made. Thank you very much and good day.
Thank you, Junaya. I want to invite Jeff Blanders and the team to come up. Timothy Masila. Sam, I assume Oguila will be online from Tanzania. Dr. Gakombe, Dr. Garoma Kena, and Amanda Kabgambe, and Jeff Blander. Jeff. So this session is on innovative financing and sustainable investment, sponsored by USAID and Uganda Strategic Investment Activity, SIA. And it's going to be coordinated by Jeff Blander, who is from the US State Department, and his title is Chief Investment and Innovation Officer. Jeff, please come up. And I find that that's a great title. Investment and innovation. He can invest in innovations, and he's there looking for, and he'll tell you about it himself, but we met him last night, a very exciting guy to meet. He knows Africa very well. So Jeff, over to you.
Caribou. It's a real honor and privilege to be here. And as we're coordinating our speakers, I just wanted to open up with a few thoughts. First of all, having had the opportunity of being engaged with the East Africa Health Federation since the beginning, it's been over 10 years that I have been involved, and it's really just to appreciate where the association and the body has been to where it is today is quite remarkable. But I think we recognize that we still have much that we can do together. And as I see my dear colleague and friend, Professor Rongo, I know that he will hold myself and others to task if we just talk about the same old, same old. And what we've heard yesterday, last evening at a closed board session, and this morning is all the promise, but also the continued challenges that we have. This discussion is about how we look forward. What is the health system of the future by working together in public and private partnership? But as importantly, what is the future of how we make investments? How, as private capital, and also from a hat that I wear from the public perspective of where we've had siloed investments, going forward, how we really work together to untap and unlock what the quote is, if I have ever seen magic, it has been in Africa. And I think we recognize that there is tremendous possibility. And just again, as a prelude to handing over to this very distinguished body of speakers, just last week, where I had a few days in Dar es Salaam, and this was not something that was pre-planned. It just happened to occur when my time was there. You had the launch of the Lancet report for the Cancer Initiative on Africa, with all heads of state launching the importance of how we are going to tackle cancer going forward on the continent. And then simultaneously, literally, as I had coffee in that discussion, I took a short, practically walk. I jumped in a taxi. Not far down the road from where that was happening, there was the Africa Union, Africa CDC high-level training that represented over 30 countries of considering the rollout of the new NCD strategy. And part of that process was understanding the integration going forward of how we look at NCD, classic infectious disease such as HIV, but also bringing into context, I heard at the time there was, someone did bring up sickle cell, but they also brought up mental health, behavioral health, traffic accidents. So again, there is a groundswell. But we all know the challenges. But here for this panel, we are here to talk about the future and also to put our minds together, not only just as a panel, but with you all, of how do we do and structure investments differently so we can unlock the potential, but also move forward aggressively to take on the challenges in new ways and new thinking. And I'll just, before I transition, let me just share the excitement I have. So I talked a little personally about myself, but now professionally. Let's put titles aside. I've been very grateful to have this opportunity with our U.S. State Department. I've been there for unbelievably now almost 10 years. I've had a series of titles. In fact, so many so over the years, I don't even get cards anymore. I just kind of, whatever the title is. But currently, I have the great honor of serving as Chief Innovation Officer with a focus on blended financing and sustainable investments. Why is that so exciting? Well, some of you may know, but for the first time ever, our president, President Biden, nominated and was confirmed in the last couple of months, the first ever African-born national to lead our team, Dr. and now Ambassador John Nkengasong. And last week in New York at the UN meetings, launched an incredible reimagination strategy for PEPFAR, which has been around for almost 20 years and has invested over 100 billion US dollars. And in this reimagination strategy, there are a couple things, and it's available online. I'm sure it will be distributed, but innovation as a platform, working with the private health sector authentically within the context of an integration approach. So recognizing while we have still a focus to end HIV by 2030, how do we also work together in ways responsibly where local partners that are considering these broader contextual issues, how do we work together so we're not siloed, how we integrate, and how do we focus at the community health or primary care level so that this flows all the way up to the tertiary and specialty in integrated ways between public and private. So for me, not only is this personal where I get to be here and invoke the great spirit of my dear friend who I know is here with us, Dr. Mohammed Hashim, but also in the context of my day job of wanting to be able to leave this setting and say, how do we do business together? How do we do business not only at the global level, but at the regional level, but also at the country and subnational unit level as public and private to think about a reimagination and a transformation strategy to tackle these big problems in new ways, and importantly, how we invest together, blended public and private, concessionary and traditional commercial that has yield and risk involved, and how do we move forward? So with that said, I am absolutely thrilled and honored and delighted to turn over this big, loud Mzungu voice to truly why you are here, to listen to these exceptional folks on the panel. And I'm going to, because if it's okay, I know that we've had a chance to meet and greet most of you, but maybe perhaps we just raise the hand so people know exactly who is sitting. So perhaps first let's start with Dr. Timothy from the Ministry of Health in Uganda. Dr. Timothy is our Assistant Commissioner for the Private Sector Coordination. I know everyone here is going to introduce themselves. Dr. Kagombe from the Kenya Health Federation. Dr. Sam Ogilo, you are virtual. Can you hear us?
Yes, I can hear you very well. Thank you. Good morning.
Yes, and we have our running joke. I was told that to try and tell jokes, but I am a terribly, horribly bad joke teller. But as I shared last evening, Sam will certainly need to share with others how with Tanzania, the delegation here is the Mzungu while the Tanzanians are there. So he'll have to do that in a coffee session sometime. Miss Amanda from TLG Capital. Now, Miss Amanda, I just want to say it's really wonderful and amazing to have you here. Yesterday, I heard at the end, folks were talking about we need more perspectives from the investment side. Now, we are here both as potential investors, so I know there's going to be a lot of questions and discussion about how we look at traditional ways of yield and risk, and we'll work together on that. And then finally, Dr. Kenna from USAID, and this critically important area around health system strengthening and resilience. Dr. Kenna. Wonderful. This is our panel. So let's open this up. Each person maybe take a few minutes of their time, and then we'll go into more targeted interactive. And I'm also aware of the time, so we will be concise and efficient and do our best to remain on track. So as we shared, again, I think it bears repeating this quote of, I have never seen the magic. If I've ever seen the magic, it has been in Africa. So I want you to kind of take that moment of the future of what we can do together in using the power of new types of blended financing, public-private, concessionary, private capital, of where we could go in the context of your perspective, of your experience. And if you could each take a moment of, we'll leave it up to you. You can introduce your organization. You can talk about the challenges. We'd like you to talk about the successes, and then also truly where you would like to see us go in terms of using blended financing to untap and unlock the potential. And so what I'll do is, if we could start and perhaps start first with Dr. Kenna from USAID, and perhaps talk a little bit about your work in health system strengthening, and again, how we can reimagine together going forward.
Thank you very much, Jeff. My name again is Garoma Kenna. I work for USAID here in Uganda as a senior health systems advisor. A lot of what I do involves health financing, supporting government, working with MOH, and Ministry of Finance as well on budgeting and public financial management, but also helping the Ministry of Health to look for alternative financing options. As you know, the budget that the governments in this part of the world are putting in for health is not enough to meet the growing need and demand. And so one of the things that USAID is supporting through our implementing partners is to really look at, other alternative means of financing. And yesterday we were talking about National Health Insurance Scheme, which has been in the works for more than a decade now. And it's actually, I think, going back to the Parliament. Dr. Musila will speak more about that later on. But some of the things we help the government with is, apart from utilizing the available health budget effectively and efficiently, it's really also about looking for alternative financing options. That's the public sector. So on the private side, blended financing is one of those things we really want to do. And I think some missions have tried. And we have a loan guarantee program that we've worked with a few banks here in Uganda to, give access to finance to smaller health organizations and, clinics and pharmacies that want to build and improve their services. That's one way. But I think coming back to your question, Jeff, when we think of private sector engagement in health, oftentimes we talk about service delivery. And yesterday, and most of you here, I believe, are from service delivery. You are here from the service delivery facilities, whether it is pharmacy or clinic or hospital in some form or shape. Mostly we talk about service delivery. I think the issue related to blended financing and we need to broaden our understanding of what the role of the private sector is in health, which is investment into health. How can we make the health sector more attractive for private investors. And I'm really glad to see a colleague of mine here, from from that angle, from a capital management. So I think it is important to go beyond service delivery. Think about health is a very big industry. How can we make it more attractive for private investors here in Africa, in East Africa, but generally really in Africa? So that's a fundamental question that we all need to ask ourselves. In terms of how can we creatively move forward, and I'm talking from, coming from donor, I see challenges oftentimes of working with the private sector. We try, sometimes we've come a long way to understand each other. In the development sector, you are serving the poorest of the poor. Okay, in classical private for-profit sector, you are actually serving people who can pay. So that is a challenge already in front of us. How can we go beyond those kinds of boundaries to really meet each other, where we all can serve the people? Okay, so if you look at the classical donor investment, it is at a primary healthcare level. Those are generally, in most part of Africa, here in Uganda, I think up to 75% of the people live in the rural. That may not be conducive for a private sector who want to be in the cities, and serve the middle class people. But donor investment, significant resource, is actually going to the primary healthcare level where most of the people live and they need those services. So that's one thing. So how can you make private sector more amenable to addressing social needs? I think that's really the fundamental question, because that's where we meet as private sector players, as donors, and government, by the way. Big investor as well is the host government. And we can all meet there. So I think we need to think beyond the cities, go to where the people belong. So donors are pumping in a lot of money there. Governments are putting in a lot of money there. Private sector can be leveraged if you are also there. Create your clinics, create your networks. In the era of information technology, you can even support your smaller clinics from here, from Kampala, from Nairobi. So that's one thing to really think about. So I see that as an opportunity moving forward. Primary healthcare is a place to really be. And we've talked about non-communicable diseases and neglected non-communicable diseases, those chronic diseases. Those are, prevention kind of, and health promotion is a way to move forward on that. We don't have to wait until we have patients come to our health clinics to serve them, to treat them, but really address preventive aspect of things. Immunization is one. And so I want you to really creatively think about primary healthcare insurance. Okay, one of the things we are doing here in Uganda is to try and understand the micro health insurance schemes that existed for ages, but they never thrived. So what's the problem? The bigger insurance companies, it might be in your interest to look into those and what are their challenges. They are there, they survive, but they go bankrupt if there is malaria epidemic because the risk pool is very limited. They have very few families joining those. How can you make a network of those so that they can have a bigger resource pool, as well as now very few people are also subscribing to that. How can we also educate the population about insurance in general? Because even the well-established insurance companies, I think the penetration is very low, around 1%. It has to remain there forever. So what is wrong there as well? So one of the things we are doing as USAID here in Uganda is to really try to understand them. We are doing analysis to understand what is their issue, what's their problem. Is it, the way they manage finances? Is it the way they, we're just trying to understand their IT systems, the way they deal with their patients. There are a number of them that are being studied, and we're happy when that's ready to share with all of you. Look at those, understand them. You might want to make them part of your bigger insurance pool. The other, in terms of capital, because that's the biggest thing for me, really, is private capital into health. That's the only sustainable way we can move forward on non-communicable diseases, and even the rest of the health services that we provide here. So sometimes there's money sitting somewhere. I know, for example, Uganda has been talking about investing the NSSF, which is the National Social Security Fund. Some other countries probably have a similar kind of fund sitting there. As health sector, private sector investors and entrepreneurs, I think we need to reach out to those people who have the funds but don't know or are still exploring where to put that money. That's the money sitting somewhere. Reach out to them, give them ideas, educate them on what is feasible in the health sector, because you are the resources there to really make that happen. Reach out to the banks, talk to them. Access to finance is an issue in many parts of here in Uganda. I think the interest rate is so high. That's why USAID sometimes does this long guarantee to facilitate that. But really, talking to the people with money is, I think, what I should say at the end. Thank you very much, Jeff.
Thank you for those very provocative and opening remarks. And as I go to our next panelist, what we're going to do here is use this as a provocation as well as a challenge. So as we hear each one speak, how we can respond. And I just also want to say a couple things. This is the type of panel that we're going to leave here feeling that we needed much more time than less. And I think that's a good thing, and we'll carry it up. And also, I just want to share, Professor Rongo, you're not going to be off the spot in this. We know that you will have things that you want to share and speak out. So at some point, we will invite that. So please. So as a response to that, and I think that there are perhaps some stereotypes of how the private health sector engages in public health areas. I think it would be really great to perhaps also hear a bit from the other side, the side of the associations and some of the things that they've done in collaboration with Ministry of Health, some of the things they've done through service agreements on things such as HIV, but then also how they use the private clinics as an access point to deliver public health services, and how that draws folks into other parts focusing on NCD and the like. And I'm going to put someone on the spot, Dr. Samuel. I think you can hear us well. And perhaps you could share with us a bit, not only of the exciting opportunities that you see specific to public and private engagement in traditional public health services, but the excitement and engagement and the future of using blended financing to scale the private sector to do more of these integrated service delivery programs for NCD, infectious disease, and the like. So with that said, Dr. Sam, please, the floor is yours.
Thank you very much, Jeff and the team. Let me just say something a bit about innovative financing and scalability. And what we're really used to seeing the financing of healthcare in Africa and also in Asian countries. We know that many donors say they're investing in healthcare. And we see projects are being set up, multi-million-dollar projects, and they're usually tagged with donor names. So we see like CDC, HIV program, USAID, maternal child health program, and on and on and on, So we talk about a project linked to a donor. And as soon as the donor funding is cut, is the end of the story. That's very unfortunate. But you see this again and again and again. And in every proposal, we write about sustainability plan. But then starting about sustainability when the project comes to an end. And therefore, we never see these projects that cost millions of dollars being sustainable. Now, that's very unfortunate. And that's where the whole idea about innovative financing and sustainable investment come in today. We're talking about the social impact, we're talking about the environmental impact, and also talking about the developmental as well as the governance of these projects. All this coming together, we put them together and also look at the social impact, looking what the impact and how long that impact will be to the communities that we serve who need the services, then it makes sense. Then just tagging it to a donor one, as it was said by the previous speaker, that we are looking at serving the poor of the poorest, then how long are we going to serve them? And when the donor pulls out, how's it going to be? I've seen in my country this happening. At one time, donors insisted that people should get free healthcare treatment. And somehow my government agreed to that. Donor money came in, medicines were given for free, and everything was okay. When we are not in good terms with some of the countries, they pulled out their funding, and suddenly our healthcare was in shambles. Then we said, no, we must have now co-payment. We must have now what's called subsidized services. We'll go to pay. Nothing for free, someone's going to pay for it. And we have seen this coming in our recent years where we said we must have public-private partnerships, whereby we are all going to put in money, the public and the private, to ensure that when some of these projects, even when the donor pulls out, we can still sustain them. And the government has found it that they save a lot of money when they have the private investor who puts in, who does not depend on government tax money, deliver the services, and we see this in public health goods, it cuts down the cost. Just imagine the cost of running a maternal child health clinic, cost of running a infectious disease clinic, TB, HIV clinic, and the cost of maybe non-communicable disease clinic. It's very expensive. If you look at the human resources and you look at the space that you want to pay for, utilities, but when you sign service level agreements, then the private provider covers all that. In exchange that the government will provide the medicines, the technical support, but also he will keep in touch with these clients who will not have to move to get these services out of where they're working. And this model has actually served government, in Tanzania. We did some work and found it saved the government millions and millions of dollars. And it makes also these services more sustainable. Tanzania private sector, we have had several projects over the years, which are still today running without any donors funding, even long after the donor pulled out. And we've seen this happening when we said, okay, we need to get financing for the private sector, nothing for free. They mentioned there about the support given by USAID by providing guarantees. Not a problem. But what we need is we need to get at least somewhere where we can get financing, and by which mechanism we can have this financing through venture capitals, through loan syndication, through angel investments, but in a way that we are so sure that when we put these investments together, we shall have an outcome of a continuity of services to people who need it. Now, we should not worry about the poor of the poorest if you've got a good universal health coverage system, whereby everyone shall be included. In Tanzania today, when we talk about national health insurance, everyone is included, public and private. There is no, the costs are the same for when you go to one of these facilities. And as I'm talking now, we know very well that over 90% of financing for level 3 and level 4 facilities and level 5 facilities in this country, that means regional level, zonal level, and national level in Tanzania, over 90% is financed by insurance companies, and mainly by national health insurance, be it public, be it private. And that really brings sustainability. After we tried something a few years back, about 10 years ago, We said banks don't give loans that are affordable. Let's start something. And we did something through a small microfinance company called Afia Microfinance Company. All we had was only seed money. Seed money was enough. Until today, we keep getting more money through loans to keep financing facilities, and they're happy about that. With a small interest charge, we can sustain it. And therefore, the best way we can do it today is have this blended financing, whereby we talk about, we need to see outcome of what we need. We need to see something done, but the person implementing it should have a plan from day one, how it's going to be sustainable. And let's stop tagging projects to donors. Let's be something that from day one, we've got a plan on how it's going to continue even when the donor gets out. This is what we call real innovation, and it needs to be sustainable. I know this is a long topic that can take a long time working on it. I'm in a group in WHO, advisory group, advising on private sector participation in universal health coverage. And we're just seeing the link. We can never attain universal health coverage without ensuring that we have got a sustainable financing mechanism. And this must come with innovation, something that's out of the box. We need to think out of the box to be there. Thank you.
Dr. Ogila, we've known each other for almost 20 years, so I think if I address you as Sam, that's okay. And I just want to share, thank you. You heard the claps and the applause, and also that you really present a remarkable vision of some of the things we can do. And I think it's only appropriate that, as folks know, the formal transition of the East Africa Health Federation Secretariat, I think will be going to Tanzania next year. So again, this is a conversation that is not beginning and ending today. This is really the beginning of the things that we could do together. So thanks for the challenge, and I'm going to introduce Dr. Timothy, Dr. Timothy, I just want to share, we have some common things, right? I work within our government, and I think there are some really extraordinary things that I have had the great privilege of participating in. You know, the PEPFAR program is historic, and it's been the largest investment in eradicating a disease-specific area. At the same time, amongst my dear friends in a safe space working in government, there's probably 2 or 3 times a day I want to go up to the roof and scream because it's government. So I share, the thoughts of, the things that as government officials, what are the enabling policies or environments that you perhaps are doing or would like to share, or maybe again in this safe space among friends? What are the things we could do together perhaps to strengthen our engagement with the private sector, strategically? For example, we know that public health services and goods, whether it's HIV, TB, malaria, those are very specific things that also occur through large medical stores. But now we see the opportunity for NCD, which aren't traditional public health goods. And there are new mechanisms, new types of supply chains and other things that need to be developed. And so just pushing and now tossing over to you, how do you see the idea of us working together, public-private, ways that we could work on joint planning of financing, and perhaps some of those structures, enabling policies that really allow us to achieve that vision of integrated service delivery of the future? And not just that, let's put out there, we know local manufacturing is so critical. So I know we're talking about service delivery, but the idea of the disruptions we saw in COVID around vaccines and how perhaps in the future, as part of this ecosystem, the enabling policy, tax environments, so that we can actually see a more vibrant private sector, not just in delivery, but perhaps local manufacturing in other areas. With that, Caribou.
Thank you very much. Good morning, colleagues. I think speaking on behalf of government is one of the most difficult things that I've had to do in my life. And there are reasons for that, and a number of controversial statements that I always make. all politicians and the so-called public servants consume health services from the private sector, all of them. But they claim to be offering public health services to other citizens. It's ironic, but that's what it is. Even when they go to public facilities, they expect to be treated like private clients because they are government bureaucrats and politicians. So they actually take a lion's share of the health services that are publicly provided because they feel they have an entitlement to use those services. So government is one big private sector operation. And where we always tend not to think about it. And the other big problem that I've had with the public sector, and I've worked with them now for at least 10 years, I know, is that price consciousness is something that is not very explicit within the public space. Why? It's because much of the consumption of health services, both internally within the country and outside the country, whether it is consumed in the public sector or in the private sector, the public sector, the person consuming the health services does not actually get a direct effect of the price. So the price he has to pay for consuming whatever he's consuming is not felt by him. Either he's gone to a public facility where he's being treated as a privileged client, or he's gone to a private facility where government is going to pay for him, or he's going to a private facility where some insurer is going to pay for him. So it becomes a very serious issue. And that's why we've had a lot of problems when we are discussing within government about issues of transition in financing from the traditional overseas development assistance, tax financing, and of recent, since these terms were introduced by the World Bank, innovative financing. That the World Bank thought that innovative financing is something that is not traditional financing. But it is a very difficult conversation within the public space to talk about innovative financing. Why? Is that if you look at Uganda's health financing strategy that we've had over the last 10 years, and it's being revised now, we talk about tax financing, some other innovations around hypothecated taxation, which has not taken off the ground. And we also talk about particular, which is not popular with me, about creating funds for immunization, for HIV, for malaria. That segmented financing, which people think is innovative, but actually it is probably not innovative at all. It's actually just destructive of the whole health financing terrain. Now, the reason why these have not taken off really is that the decision to make them work was taken before the enabling laws and regulations were in place to make them function. And that became a problem for government, that how do you implement these when you cannot, when you don't have the enabling laws and regulations in place? The other question we've asked ourselves, and we work within government, is that if I woke up tomorrow within Uganda and they said, we have given you the national health insurance law, what next? What we observe within our society here within the country is that we've not yet used the experience that we have within our private sector institutions to build a robust insurance management mechanism that we shall use as a country if we have a national health insurance bill. So there's a lot of work that has been done, but setting up systems and processes that will make this work is something that we've not critically thought about. And when we think about all these other mechanisms by which we are going to finance the transition, whatever that means, I'm one believer in a global health ecosystem. I don't believe that countries need to transition their health financing. My belief is that the global health ecosystem needs to transition in the way it finances its services. And why am I saying that? If an Ebola outbreak occurs in Uganda, like the way it occurred in Mubende, it was always socioeconomically disruptive to the whole bubble called the globe. People are not coming in here. Some of our delegates are not here. We are scared of each other. We think everybody is potentially transmitting infection. So what we are looking at is a problem that we think is local here, but it is actually a global problem. So the global health community must get mechanisms by which to finance the global health ecosystem. And the only conversation that matters in health, when you have the providers and the willingness to innovate, is how you finance the whole operation for health services. And we've not, as a country, as the globe, critically thought about this. If you look at the discussion around innovative financing, I mean, it began somewhere in the 2000s. Up to today, we are still talking about what do we introduce. We've seen different things being done, you know, attracting more financing, you know, through different mechanisms that have been tried by multilateral and bilateral institutions. We've seen introducing efficiency mechanisms to manage the money that you have, things, results-based financing, output-based aid, and all of that. We keep on changing the statements, but we are basically trying to extract efficiency gains to buy more with the same amount of money. We've done a lot in that area. It has not delivered enough money. And lastly, this period is very scary. There are epidemics. COVID is there. Ebola is a global pandemic. When it occurs here, it is actually a global pandemic already. But we are also seeing disruption in financial markets. I know I'm not an expert in finance, but at least it's obvious to me that financial markets have been disrupted. And this is the biggest disruption of financial markets since the 2008 crisis. Why? Because the COVID has been there. The global leader, who is the US, has decided to do certain things that actually reverberate around the whole world. Many of you may have seen that it is astonishing that the bond market has constricted by about 21% in the last few months. It is astonishing. So if you want to float a healthcare bond, are you going to attract demand for it in a constricting bond market? We don't know whether that will happen. We know that even if you are to issue local bonds here within our markets for healthcare, and you issue them denominated in our local currency, what will be the attractiveness of those local bonds when interest rates in the US mean that we are riding on inflationary pressures within our currency here? It becomes a very big problem. I was looking at some Bloomberg report this morning, and the greenback has I think the interest rates, has appreciated by about 5.5% since August. And what that means to access to money to finance healthcare is massive, because we are competing in the same financial markets to get money to finance all that we want to invest in. So where will this money come from? I know my colleagues who are better, who are better trained in finance, and they think about these things. We'll talk about this in the afternoon, people from Coca-Cola and from the different areas. But I really think that all the innovative financing mechanisms that have been described, they are different areas, will need to be readjusted based on the financial realities that we have in the world today. Government has got the enabling framework. Within here, the private sector thrives, at least to a good extent. And we think that in countries which do not have enough money, they have no choice but to work with the private sector to generate the extra capital that they need to invest. And I'm sure that my government here cannot survive without private capital. Thank you.
Dr. Timothy, I just want to thank you. And also I do want to just share with you, it isn't often that I meet and chat with colleagues from the Ministry of Health that speak so eloquently about the foreign exchange rates and the importance of tackling those as we look at innovative financing. So I really appreciate that we have truly someone who appreciates the barriers, but also the new innovations that we need to take on to solve this challenge. With that said, I am going to turn to Miss Amanda. Miss Amanda, you know, I feel akin to you and the others in the audience who are from the finance side. While I have a doctorate in epidemiology and public health, actually, my background is in business, and that is really truly where I think most of my career has taken me. I've spent time as an executive in the biopharmaceutical industry, and I've started my own companies, and then I even started my own foundation before working in the government, which I never saw myself, and it's been truly delightful and amazing. So I turn to you, you know, and I think about the true challenges when I look at this purely as a business financier, right? We talk about things like risk, yield, return. We also know that when we look at it through the classic lens of when we even compete with other sectors other than health on the continent, or even, you know, back home for me in the US, you know, it is about the bottom line. And in a lot of cases, you know, if you look at it purely through that lens, the things we're talking about don't meet the standards of the private capital markets. But I turn to this as a moment of opportunity and a moment of optimism, that we also appreciate the power of what is represented in this room, not just at a country level, but a regional level and beyond. That not simply discussing X millions of clients who potentially are served in a place like South Sudan, but perhaps your definition of East Africa market as approaching well over 450 million clients. So let's have a conversation knowing that we're not putting you in the spot representing all types of financing, but a conversation about some of these challenges in ways that perhaps we could work together and actually challenge our colleagues who are here and perhaps not here, folks from the African Development Banks, folks from colleagues of mine from Development Finance Corporation, and also folks from the commercial banks, of how we can think in these classic terms of yield and risk and investment, but how do we come together with things which I know, my dear friend, you have been a champion of concessionary financing, layer cake models, of how we truly move the dial so that we're not talking about the same thing in another 10 years of these generalized sustainable financing, but really specific investment cases that we've moved on, and we can look back on this conversation of when we said we can and we will. Please.
Thank you, Jeff. And thank you to the previous speakers. I do echo that projects should not be tagged to donors. I also do echo that medical tourism is not sustainable, especially by people in the public sector. My name is Amanda Kabagambe. I'm a partner of TLG Capital. I oversee operations for East Africa. Our healthcare portfolio spans manufacturing of medicines, supply and distribution of drugs, and primary healthcare facilities in East and West Africa. Collectively, TLG has invested just over $18 million in different companies. Innovative healthcare financing is possible, and it's possible when all actors do their part. There's a role for government, there's a role for NGOs, and there's a role for the private sector. And each one of those parties needs to be clear what their roles and responsibilities are. Speaking purely as a commercial partner, there are ways to increase funding to entities and reduce the cost of that debt. One of those ways is guarantees, as has been mentioned. One of our investments leverages a guarantee from the Medical Credit Fund, and that was able to reduce the cost of debt and increase funding to the entity. One of TLG's flagship investments is in Quality Chemicals. We invested in Quality Chemicals, and I'm happy that they'll be here in the afternoon in 2009, and we're able to support them to get into partnership with CIPLA and manufacture drugs pre-approved by the World Health Organization, and they're now selling in over 8 countries. So it is possible for commercial capital to work with global brands and to support access to medicines and healthcare. One of the things we must also emphasize, and I'm sure people in the room know this very well, is that we need to look at healthcare financing to cover the entire healthcare ecosystem. So that should cover medicines, workforce, our health infrastructure in terms of hospitals themselves, health information systems, digitization of systems, and everything else that we are all aware is needed. And we saw that in the pandemic, that many of those things were tested. And so resilience came down to how well each one of those levers were able to work. Coming back to your question, Jeff, on risk return, it's very easy. It's about having a longer term view, right? The problem with a lot of the commercial capital is that it's very, very impatient. And you want to, starting with commercial banks, right? You want to invest in something for 3 years, 5 years, and expect to get a return on investment. Healthcare is a different kind of business. I think that investors in healthcare must have a longer term view and must work together. It's not a cake that you should want to eat alone, right? It should be one where other parties are invited so that we increase the spectrum of services provided and therefore guard the value that can be gained from there. What do I mean? You could collaborate with guarantee funds. That's what we've discussed. You could collaborate with providers of equipment, could collaborate with suppliers, right? So there are many ways to fund a company. It could be supplier finance. It could be prepayments. It could be insurance partnerships. It's really just to open up our minds and realize that this is something that we need to do. We also must talk about the technical assistance that is required in a lot of these investments. What we did during the pandemic was to provide technical assistance through our partners, CDC and Swedfund, to some of the clinics in which we've invested, particularly in West Africa, to digitize records, train healthcare workers, digitize their electric systems, add solar panels and stuff like that. I also want to echo that this is a local problem that must be led by us locals, right? And the pandemic did show us that every country will look after itself first. So whilst we appreciate donors and development partners, and we now recognize that medical tourism, like Timothy said, is not sustainable. So having a locally led approach, in my mind, is also very, very important.
Ms. Amanda, thank you so much, and exceptionally helpful, and not only really pinpointing those areas that are ripe in the near term, but recognizing the approach that we all have to take as part of what we call a toolkit of asset classes, whether it's debt, equity, venture capital, part of that mix, loans, and really where the commercial capital sees real significant areas of opportunity, but the long-term approach that we have to take, we're then working again with others in the development institutions, my organization, how we start to layer in these concessionary blended models that give us this, what we call layer cake of opportunity of near-term, intermediate, and longer-term investments. So very, very optimistic, hopeful, and truly energized about the types of things that we all can work with yourself and others who represent the finance sector. So with that said, I just want to give a sense of time. I believe we had started roughly almost about 10:45 or so. This panel was expected to go about an hour 15, but I'm looking at the chair and others who need to stay on track. So I am committed. We're probably going to finish sooner than the hour, but we're going to take up a little bit more time. But just so we know, we have one more speaker. I am going to be an instigator with my friend, Professor Rongo. I have a provocative question, which he can so choose or not to address us. And then also want to give an opportunity to hear a few questions from the audience that at least we can hear. And if we don't have time, we can engage in the hallways. So with that said, let's turn over to rounding out the panel. We have Dr. Kagombe and the good doctor, I know that we're going to have some time later on this afternoon. So I kind of put this in the context of we've just had this opportunity to hear from our colleagues here of both, challenges, what we could do together as the local government, where there are opportunities of working with commercial capital, and then, where perhaps there could be opportunities, specific investment cases, not only from your perspective of Kenya, but also thinking broadly within the regional market here as part of AFTA. So really turning over to you, kind sir, where do you see both where you are today, where you'd like to go, and how we could use these toolkits to really advance your mission and strategies? Over to you.
Thank you. For those who don't know me, my name is Gakombe. I am Kenyan. I head the Kenya Healthcare Federation, but I have a day job like most people who are involved in industry bodies. I run a hospital and I'm in 2 tech companies. And perhaps the best way is to share our journey. We started off as a hospital in the 1990s. At that time, banks were not touching private healthcare because they considered it fee for not for profit, and therefore so the money came from friends, family, and fools, and not necessarily in that order, because we needed to raise money. So we did a private placement, and 500 Kenyans bought shares in a concept that became a hospital. And we also got one angel investor from the UK. It's a long story, but he put in a substantial amount of money. 5 years ago, we had become big enough to attract private equity. So Abraj invested in us. Abraj subsequently collapsed. So we were inherited by TPG Capital, who are now looking to exit. And we've also reached the point where we are now an angel investor in a number of startups. So we've gone full circle. So along that journey, we've had funding from the initial investors, call them the angel investors. We've had funding from commercial banks. We've had a lot of support from our suppliers who put in money, either through equipment placements or through commodity placement, or through especially placements, dialysis equipment, lab equipment is all on placement. Along the way, we realized our biggest problem was infrastructure. So we separated the operating company from the property company as a way of raising money from banks that understand real estate and raising money from suppliers who understand healthcare. So we are separate. We own both, but they operate as a propco and an opco. So some lessons. The first is that most of us are too small to attract private equity. There's a threshold. They don't invest below $5 million, $3 million. Most of us are looking for $500,000. So we need aggregators in the market, those who will get these organizations together, create an ecosystem that becomes big enough to attract private equity. I must add that in East Africa, as I know, there is no healthcare company that is listed, because that's the ultimate, an IPO. And none of us is listed. Actually, large healthcare providers are not big compared to other people in the sector. So we need to walk that journey from the initial investor, the angel investors, through commercial banking, private equity, to an IPO. I'm still waiting for somebody to do an IPO. Sorry?
Cipla Quality Chemicals is listed.
Yes. Sorry, I was talking about providers like me. hospitals, yes, supplies instead. So, so we need aggregators. And we need to be aware that many of these businesses are family owned, so they have to be moved from that comfort zone.
Testing.
I'm back.
Oh, you're back. Okay.
So the transition from a family business to a business that is investable, the requirements that private equity investors have, because it's not just about financial returns, there is ESG, which has become a very big matter to contend with, and so on. So as a country, we are trying to improve the environment for doing business, because you cannot grow unless the environment is okay. So there's been a lot of legal reforms in terms of company ownership, limited liability partnerships, commercial justice, because these are foundational to investment. And that's why the Kenya Healthcare Federation exists, to try and create a better playing field for investors, both local and foreign, as a prerequisite for growth. Thank you.
What you just shared is music to my ears, and I would like to look out here knowing who is in this room and on this panel. And I don't know the exact time frame, but I do hope we're not talking 10 years from now. Maybe we make it a challenge of 5 years from now, but we will have a panel representative with several IPO'd organizations that represent private health sector delivery. Let's make that a goal of ours. Okay, so we are now hitting the home stretch. And as I do this, I am going to look at my panelists and ask you, because I will ask each of you to take a short soundbite as a closing moment, as perhaps either your one big idea or one takeaway message you can share with the audience within a minute or so as we close. I'd really like each of you to have that. But as we do that, I'm going to give you a little time to think about it. Professor Rongo, I'd like to not be too prescriptive of what to ask you to maybe comment on, but I do know, even though you say you're retired, I know really someone like you never retires. It's more of what is you're thinking about the next. And rather than sitting watching the sunset in Kisumu somewhere, we have you here with us. So clearly this is on your moyo, and a conversation we've had, and maybe to give a sense of urgency in a few minutes of where we go, not simply as a matter of opportunity, but recognizing what we've seen with COVID and things that have created vulnerabilities. We've heard, again, we know a lot of the private sector are SMEs. We've seen disruptions. We see, other than opportunities, we also see real specific weaknesses, and this sense of urgency of needing to move forward, because as you know, it's the idea of the best way of defining your future is to make it happen. So wanted to hear your comments on some of the urgency of the things we need to do or anything we may have missed. You could do it from the comfort of your seat, or you can come up here. It's caribou, however you're most comfortable.
Jeff, this is a painful thing for me, and painful for me personally, because I don't know whether to celebrate the birth of a newborn or mourn the burial of an old man. Because on the one hand, I'm hearing the same things that I had 20 years ago. On the one hand, I'm leaving what Dr. Kagombe is talking about, because Dr. Kagombe, you remember when you were starting Metropolitan, and with some tenure at the Nairobi Women's Hospital. The same thing. I've lived it. You see, COVID has reminded us or magnified the gaps that are in this sector. First, a couple of years back, I think at IFC, we did a quick and dirty study here in Uganda on which of the subsectors of health are investable. And we did that in Ghana too, and I think we did it in some West African countries. And invariably, it was the pharmaceutical sector. The sector that has goods and manufacture the way the rest of business in Africa works. So it was never in service provision. And if you looked again, it was the sectors where there was infrastructure. There's a building being put up somewhere, or there's an equipment being sold. But then when you put those popular sectors or subsectors together, it doesn't deliver health. And this is the thing that we have been refusing to accept. That even as we sit here and talk about primary health care and the role of the private sector, in our continent today, in my village, we are talking about a nurse or a clinician who is going to open a clinic, bring in goods into it, employ somebody to help him, and open that door for people to walk in. And the only way he is going to fund his investment there is through these people who are walking in. There's no other income. He's not charging rent on his property, no. And these people who are supposed to be walking in are the people who are not insured and must pay out of pocket. So when NHIF in Kenya comes and offers some of these people a cover, then these people walk in with a card. And then when they walk in with a card, this guy starts making claims to NHIF and money starts flowing in. So if you ask this person, what should we do for you, for your business to thrive, to grow? Then he says, give these people this card so that none of them walks in only thinking about the pocket. So how do we get these people a card? A fundamental thing in primary care delivery is giving these people the equivalent of that card. So when donors come and start create programs that are supposed to make service available and compete with this guy, who is still waiting for people to come to with a card, they kill this guy. And we've seen donor money killing private initiative at the primary care level, as if that is the only mission they have. And if that doesn't change, then nothing is going to change. So for countries in East Africa that have already shown some modicum of efficiency in giving the patient a card, why don't we invest in that and make it work better? Because I will be very, very happy to run that rural clinic for private healthcare for so long as I know these people have a card. We have negotiated the cost, and that is. then that is now what we can start aggregating and eventually being able to go to all those markets, because we know that the market is predictable. But right now, the market is not predictable, because tomorrow there'll be Marie Stopes that comes with that will start offering something that is subsidized by a donor somewhere. And he'll be competing with me and he will say that he's cheaper than me. And yet he doesn't go through. Or it will be the inefficient public sector that the donor will put money into and say that now we are better than this private sector because we've now bought things and brought it to the hospital. And this guy still has his investment there. So what I'm seeing out there and seeing out here are people who are passionate, they believe in their country, they believe in their people, and they know that the business is simple, is the provider and the client. We have a clientele at the primary care level that does not have a card that guarantees this provider payment. So Jeff, if we have money in USAID, why don't we go and reinforce the Rwandese social health insurance so that it can run better and can reimburse faster? Why don't we go into NHIF and help in covering this person who's not covered yet, so that when they want HIV/AIDS drugs, it's provided for in the card. TB drugs are provided for in the card. So it's not just a question of bringing the drugs and saying it is sitting in central medical stores. It's saying that when you are covered with this card, you are eligible for TB treatment, for HIV treatment, for delivery, and for everything else. Until this market has a card, as it has in Holland and everywhere else, the provider is being put on an impossible platform. And that platform must not be the platform that forces me to go and talk to Amanda. Amanda is too high up there. As Dr. Gakombe says, Amanda doesn't want to talk to me because I charge people 100 shilling per consultation. Amanda wants to talk to Nairobi Hospital, where they charge 10,000 shilling per consultation. So what we are saying here is that if in Africa, you are not charging 10,000 shillings per consultation, then you have no business talking health finance. And this is where I think the dialogue has to change. Thank you.
Thank you, dear friend, dear professor. And let's take this up as the gauntlet going forward. And you have my commitment in my position as Chief Innovation, perhaps going forward and having a significant opportunity under a reimagination strategy, how we can move forward on some of these ideas in ways that aren't just talk, but what are some of the things we can put in place to see how we can do things differently. So really want to thank you. Now, what I want to do is I see the chair. I think we are about an hour that we've had, but we know that you're running over. Do we have a few minutes still to wrap up, or tell me where you see? Okay. So let's do this. Folks, if you have some questions, we'll take a few from the audience, and what we'll do is if you can tell them, not in a large speech only because we don't have time, but perhaps if you can get to your question pretty quickly, and we'll take several so we can hear them, and then that could be part of the conversation and dialogue as we transition both to a break and the rest of the day. So please, as you have your questions, come up and share them. And as we see people standing, I'd like to then again look at my panelists and say, you know, that one big idea, that one thing that if we could go forward and you had our blended facility or we were working together, what is that one area you could say or shout out that you would suggest to us that we need to do? Do we have anyone standing up that would like? And as I see some hands back there, there may need to come to the mic. And we'll take this for just a few minutes and then we'll do our closing big idea.
Actually, when we talk about this, then we are talking about innovation. And if we are talking about innovation, then we need to discuss scientific research. And I did not hear anything about that from anybody in the panel. So please address that.
I can share that that is extremely near and dear to my heart. So I promise a quick soundbite, but let's hear from others and we can also take up that conversation.
One amazing discussion, really enjoying. I think it was very clear the need for innovative financing models to help create these investments. One of the things that we have experienced from PharmEx's side through the medical credit funds, that is also very important to support this with blended financing and technical assistance, because we've had some great examples from very entrepreneurial thinking. But the vast majority of these smaller healthcare facilities are run by doctors and nurses who may not have the business skills to start with, which is fine because they're doctors and they're supposed to focus on that. So I'm keen to get the thoughts of the panelists. How do we create more blended approaches where we can scale up some of the successful initiatives that combine investments with technical assistance to get an entrepreneurial mindset that is needed to scale these models as well. Thank you very much.
Thank you very much to the panel for the very stimulating discussion. My name is Abigail Turinayo. I work with Design Without Borders Africa, an innovation and R&D consultancy, developing healthcare solutions. My question is very related to the research in healthcare. Specifically curious about what the place is for transdisciplinary collaborations in facilitating opportunities for innovative financing. We could say transdisciplinary collaborations as well as trans-sectoral collaborations that could facilitate a bit more innovative approaches to financing.
Great. Those are really sensational questions. And one moment, the gentleman over here is my hook. So just bear with me as I coordinate before I get thrown off the stage as we wrap up here.
Okay, thank you so much. My name is Michelle, and I am here to ask the person who represents the government of Uganda. You talked about insurance, and you also talked about putting systems in place. But I think I would like to let you know that we have enough systems in place. Some of them have even been forgotten about. I think we need to strengthen the already existing systems and not instead create new ones, to cause congestion. Secondly is we also need to have all, sector players in this thing, especially when it comes to health. For example, some of these challenges, especially in health, affects young people. But when I look around this room, I don't see very many young people. I might be one of the youngest people in this room. So can we have involvement of everybody, including the young people, when it comes to such matters? And then another final thing I have, witnessed in such discussions is we always come, have these roundtable discussions, talk about many of these things, but very many times this ends inside here. it doesn't go back to the community. The government talks about it well and good. The private sector players come and talk about it well and good. But what happens after this? There is no implementation. So what happens to people in the grassroots, level who are supposed to be benefiting from some of these programs? Thank you very much.
Wonderful. So listen, another sensational set of questions. I know our time is running out. So this is what I'm going to kindly do. I'm going to turn to a moment to our panelists to give their one big idea and maybe closing moment. If respectfully you could do that in a minute or less, that would be fabulous. I do want to just address two very quick things. The thing on the research and development, absolutely an incredible opportunity and moment if you consider where we've been with COVID, but understanding and appreciating the idea of global health security. And this is an area ripe, I believe, for partnering with global biopharmaceutical companies, but also the public health side to really strengthen an R&D platform and pipeline for the continent, not just as a matter of essential need for future pandemics, but as a matter of equity to ensure that we have representative populations when we actually do and develop new discoveries. And of course, what was mentioned by our dear friends at Farm Access, the TA piece, I think absolutely essential that as we do this, recognizing that we need to build that in as part of the layer cake model. And frankly, that might be where private capital and USG or other sources of concessionary capital could layer in some of that TA piece, while the commercial banks and the development banks focus on what they do best, which is making new financial products to address community needs. Now, with that said, I am going to turn over, we're going to go sequentially, and then I'm going to turn over to our hook to transition to our next session and break. So we're just going to go down the line, starting with you, dear sir, your final thoughts and reflections.
Thank you. The Medical Credit Fund works. We are beneficiaries of that blended finance and training. And I think there are many institutions that can be used to be training centers for management, would be willing to be one. And there are universities and others doing it. Two, let's not give up. Change is slow, it's laborious, but we are changing. And part of the problem we have is probably, I call it the matatu culture, expecting results in 24 hours. If you look at the Kenya NHIF, between 2005 and today, it's a very, very transformed organization. The journey is not over, but it's a very, very transformed organization. So let's keep at it, let's be relentless, and let's make sure health stays as part of Agenda 4 across the region, because then the political will be aligned to our interests. Thank you.
Magnificent, please.
Thank you very much, and thank you for those questions and comments, which I think enrich what we've been discussing. My thinking goes to the disruptions that have occurred in the world, which began as a health crisis and became an economic crisis, and now it is moving towards a financial crisis. Therein lies the opportunity to rethink the way we finance care. We should learn to use the data that we have to show us the market opportunities that we have. If you look at data from our poverty and vulnerability surveys in Uganda, the biggest single cause of household outlays in consumption are to do with healthcare. That means that at household level, this is what is causing the biggest poverty, occurrence at household level. How do we make sure that we tap into this resource to make sure we organize that financing to be able to use it to buy better? The other thing I wanted to say that numbers matter and small things matter. The biggest healthcare investors are SMEs. And because there are many, they matter, they are big in they are many in number, therein lies the opportunity. We need to tap into that, not to always think that we shall go to the big investors. it is important that we can be able to tap into that. And I think as institutions, governments, we need to recognize the shortfalls that we have and be more willing to work with the private sector and the non-state sector in general to improve the way we are doing things. Donors, lastly, your overseas development assistance should be competitive based on efficiency and what you buy, the value you buy. Do not look at only funding public sector institutions, because private sector institutions can deliver to you more value than what public sector institutions are able to deliver.
Sensational, sir.
Thank you very much. I think to address the Prof's earlier question about donor and what Dr. Musila is saying, that's exactly my belief as well, that donor money should be part of the blend, buying services from public as well as private providers. There shouldn't be a reason, and I don't think any donor does that intentionally to just kick out private sector out of business. But that could be a collateral damage when we don't really talk to each other and understand each other. Private sector has a lot to offer: innovation, quality, the infrastructure. Without investing in infrastructure, if you come to a clinic and just buy services, isn't that already an asset that you haven't invested in, but the private sector did? So for me, really, the big takeaway here is blended financing is a blend of different forms and types of financing coming to support one cause. In this case, we are talking about healthcare service delivery. Governments will always be there, whether we like it or not. Those are the most sustainable institutions. They will continue, bad or good. If one goes, the other comes. So private sector needs to find a way to work with government, and governments actually invest a lot of money in different ways. So that's the first component. Donors can provide some, assistance. I don't call that a sustainable way of, delivering development, but I see it in the near future, in the foreseeable future, we still will have donors around. And so donor money should be part of the pool when we think about blended financing. And then, of course, private capital investors, financiers. I think if you have that aggregate of different flavors of money coming from host government, donors, and I think the private capital will be more comfortable investing in health. And lastly, I think we tend to forget households. Households are primary producers of health, and they contribute a lot of resources to produce health. So we need to also find a way to tap household resources into this pool. And I think the place all of this meet for me still is primary health care. I know it requires a lot of thinking as to, does it really make business sense in the long run? I think it makes business sense. It is food for thought to really think about how can we work together at that level to deliver services to all, because that's where all of us actually meet. Thank you very much.
Thank you so much. And Ms. Amanda, please.
I'll answer twofold. One as a Ugandan and then as an investor. As a Ugandan, it's important that poverty at the household level is addressed. Just as Timothy was saying, if we don't have, we will not get the right healthcare outcomes if things like shelter, food, clean water, good housing, and balanced meals are still an issue. It means that when our people fall sick, they will come late for healthcare. They will not complete their doses. I'm not a doctor, but you've experienced this more than I have. And falling sick becomes very, very expensive, just as Prof said. So that's a national issue to be addressed. And I believe that once those elements of poverty are addressed, then we have more income for healthcare. as an investor, the area I think there is opportunity to invest is in local manufacturing for medicines and for supplies. The last statistics I looked at said Africa is still at only 3% of production, and the practitioners in the room will confirm that we're still importing over 90% of the drugs and supplies that we're consuming. So therein lies an opportunity. And that means we need to invest in world-class facilities, work with partners within the ecosystem, and make sure that we consistently increase the portion of readily available, locally produced modern medicines. And we also see an opportunity to invest in PPPs for diagnostics, primary healthcare clinics that are connected to larger hospitals. Thank you.
Thank you for truly an exceptional recap, and also just from that financial perspective where we could head. So I'm going to just give 2 quick thoughts as we transition and move on. First, what an exceptional discussion, recognizing again that whole idea of if you want to move fast, go alone, but if you really truly want to have remarkable impact, go together. I think you've seen the power of working together between associations, investors, local government, and also folks who represent the international development community. The other voice that I want to also just highlight, we heard from one of the folks in the audience, the youth, the entrepreneurs, where the innovation, the spirit. When I first came to the continent, I was young. Now I'm old. So now it's time. How do we think about all this in the context of really incentivizing, motivating, and engaging the youth who have the ideas, the energy, and passion to move this forward? So with that said, I want to give a round of applause to this panel and all of you. And dear kind sir, your patience, please.
All protocols observed. Good morning. Thank you, Jeff, for this handling the panel, and we can't thank you enough for the panelists for contributing to your thoughts on the healthcare sector. My name is John William Nyakatura. I work for SIA, which is a strategic investment activity that is a USAID activity. I stand on behalf of my CEO, so let me just read some of his comments. We're delighted to be building the resilient systems for an ever-evolving challenges here in Africa. And as SIA, we are key to seeing that the private sector actually plays a part, both from a financial point of view. SIA brings a unique skill or a new set of capabilities that seeks to bring sources of structure. My apologies, let me just start that again. SIA brings a unique set of capabilities that allows us to source, structure, and close deals for investments, but also providing customized transaction advisory services to businesses like yours that are looking to raise capital. And our job is to help you unlock capital and also create a more conducive environment for investors to come in. In achieving our intended objective, SIA works through coordinated stakeholders like UDB, but also investors like Absa Bank. We also partner with private capital partners like TLG Capital, XSML, Iyungu Capital, and multiple offshore investors like Africa Invest and the Medical Credit Fund, trying to bring them into this core space in order to invest in the projects that you have. We work together to foster health facility partnerships that unlocks investments and also productive use of energy, and to accelerate the uptake of on and off-grid energy solutions in your projects. SIA believes that solar PVs can be utilized by both health clinics and pharmaceutical manufacturers to power their medical equipment and infrastructure, but also to support connectivity and the continuous uninterrupted service delivery. And I think here where we give examples, we're looking at solar panels being used to power cold storage and also looking at alternative sources of lighting. I think an example I can give is that we're having conversations with one of the largest pharmaceutical companies, and where we're asking them for the new warehouse that they're going to put out, would they look to alternative sources of energy to powering their big infrastructure that they're looking at? So what do we really offer? SIA offers businesses like you, again, transactional advisory services through our transactional advisory team to help de-risk the investment for many of the financiers. People like Amanda here have a list of things that they go through, and we deploy a transaction advisor to help you achieve those particular targets. And then in the end, we would also like to see the gap between the issues that may arise from the due diligence being resolved, but also the investors trying to appreciate what they find here in Africa. SIA, through transaction advisory firms, aids the investee in the negotiations of raising capital and works alongside both parties to achieve the conditions precedent. For those of you who are not familiar with conditions precedent, when you do raise money from one of these investees, just before you sign, they have a list of items that one has to go over. And we think that by partnering with you, we can actually address those issues to see that deal close actually happens. Upon deal close, we will also initiate a 100-day post-investment strategy that enables us to follow the deployment of the capital, to address the issues concerned by the investor, and also strengthen systems that allow for transparency between the investor and the investee. And with that, we would be happy to invite all of you to attend our deal room that is, I believe, in the Aswa Hall at 4:30. We have brought about some of our transaction advisors. We're hoping that you can have a speed dating session, talk to them about your capital needs, and let's see which kind of investors we can match with you. Thank you very much.
Thank you very much, Jeff, and the panelists. And we can go for a well-earned coffee break now, and let's be back in the room in another 20 minutes. Thank you.
Hey, I'm Joey, and I'm one of the 30 AI voices from SpeechLab. You listen to this video until
Yeah, good afternoon, everyone. Can we have the next team at the front, please? This session, making specialized medical services and medical tourism work in East Africa, sponsored by Gertrude's Children's Hospital. So Simon Luzigi, Miriam Maturo, Thomas Nwire, and Jean Nian Kiawa. And Nia what? Nirin Kwaya. Okay. And Edward Misati. Okay, Edward, come up. Edward's from a thing called Rubik Health, where he associates with someone called Mark. There's a long history of healthcare. Anyway, we're very glad to have all you folks here. I just want to briefly mention our sponsors, because these conferences won't happen without sponsors, as you know, and we didn't have any big sponsor like the World Bank in this program. So I'm going to quickly read your lists. Thanks to Stanbic, to Farm Access Foundation, Gertrude's Children's Hospital, to PATH, USAID, Strategic Impact Advisors, IFC, CIPLA QCI, AMREF, SMART, ThinkWell, Uganda Insurers Association, Uganda Investment Authority, AHB, AstraZeneca, Roche, Health Partners, MP Shah Hospital, Feed the Future, Keen Bright, and this one is medical. It's medical. It's written somewhere else. It's not printed properly, so I can't see. What's that one? It looks like medical supplies, I think. Yeah. EAMV, Rocket Health, and Tucana Solutions. So over to you. They're just going to
Good afternoon, everyone. I am looking for Thomas Nwire from Gertrude's Children's Hospital. I think he's present, so if you could please come up to the stage. Yep. He was here. He was here. All right. Good afternoon, everyone. I'd like to thank the organizers and the sponsors of this conference. We've had some very insightful discussions over the last 2 days. My name is Edward Misati. I represent a firm called Rubik Health Africa. Rubik Health Africa is a firm that creates value for investors, both private equity investors and, of course, founders of businesses, healthcare businesses, particularly hospitals. Today's topic in this particular session is about making specialized services and medical tourism work in East Africa. Whenever we hear the term tourism, it invokes a sense of adventure, travel. We think of coastal locations, bright new cities, and beautiful parks. But in healthcare, medical tourism is born out of necessity rather than choice, traveling thousands of miles away just to get care, just to live another day. Sadly, while that is the case, the reality is that today, medical tourism is a business, and a huge business at that. In 2020, the global medical tourism market was estimated to be around $54 billion. Just think about that for a second. $54 billion. The projections by 2027 are set at $207 billion. That's 3.8 times growth in just under 10 years. So what are the leading destinations for medical tourism around the world? Some countries come to mind. The US, India, Malaysia, Singapore, Thailand, Turkey, among others. In Africa, we don't have so many destinations where people can seek care. What comes to mind is South Africa and the North African countries such as Egypt, Morocco, Tunisia, which attract European and Middle Eastern patients. So these countries offer a wide range of medical services that include dental care, cosmetic surgery, elective surgery, and fertility treatment. So what are the reasons why people seek, or rather engage in medical tourism? Access to specialized care, and also access to affordable care. So to discuss this topic, and we don't have a lot of time, I've got a panel here of CEOs, a C-suite panel who've led healthcare businesses, who've seen what, taking care of patients day in, day out looks like. And so we're going to engage them in a discussion around medical tourism. So starting from my immediate right, we can just introduce ourselves, tell us a little bit more about the facilities you lead, and of course, carry on from there. Welcome.
Thank you so much. Good afternoon, colleagues. Simon Ruzuki is my name. I'm a physician and CEO of Nakasero Hospital. Nakasero Hospital is currently 83-bed hospital. And in the next 8 months, we shall be 150. And the genesis of Nakasero was out of the need at that time, about 13 years ago, to try and bridge and reduce the number of referrals abroad. We as a hospital, that was the gap we envisaged to try and bridge. At that time, it was obvious that there was a growing gap in terms of needs locally for some specialized services. And hospitals like Nakasero came up to try and support government in that way by trying to see if we can develop some such services locally. And that's how Nakasero came. And our vision right now is to become a world-class tertiary care facility in the region, East African community, and the wider region of the East African region. That's what we hope to be. Thank you.
Good afternoon, everyone. My name is Nyirikwaya Jean from Rwanda, Kigali, and I'm the CEO, the owner of La Croix du Sud. La Croix du Sud is very difficult to say in English. So let's say Southern Cross Hospital. So Southern Cross Hospital started in 95, just after the genocide in our country. It was to deal with the problem at this moment, because in this moment we were only 3 gynecologists. I'm gynecologist obstetrician. This time we're in our country, we're only 3 gynecologists for nearly 9 million people. So we started with a little clinic, and then we shifted in another one, the next door, with 23 beds, 1 theater and 1 maternity. And in 2009, we shifted to an hospital now with around 110 beds, 4 theaters, neonatology and ICU, radiology. But now we are still starting a 4th stage by an extension, where we are expected to do to promote imaging department, very strong imaging department, and also good theaters for bigger operations. And also we'll do the dialysis and even operation on the kidney and cardiac catheter, cath lab also, and IVF. So I think this aspect will help us to reach the level for a good medical tourism. But what I want to say, maybe you see that the previous panel has answered a big question of medical tourism. To do medical tourism means a good infrastructure. Medical tourism means a good and skilled personnel from the top to the level, because you cannot go to the medical tourism if you are not accredited. You need to be accredited. It means you have some prerequisites you need on the quality of your service and the quality of the structure. So it means you need, but the prices, the money you get from the services can help you to sustain your business and also help you to make progress. And it was the problem Dr. Kagome said, and Professor Kamarobo said, this is the key point for development of medical field. We need absolutely to see how we can get good money so that we can be sustainable and we can be able to develop our facilities.
Okay, thank you very much.
Dr. Miriam Mutero, I'm the General Manager for CCare IHK, which we have recently rebranded. We are part of what was the International Medical Group that was started out 26 years ago by Dr. Ian Clark, the current chair of the East African Healthcare Federation. And we have CCare IHK, the hospital. It's a 100-bed hospital. It's the first private hospital in Uganda. We pride ourselves in being the first to do a lot of the first things, innovation. We were the first ones to do an open heart surgery, the first ones to do minimal invasive surgery, and we'll continue with our commitment to be the first in terms of technology and innovation. We have a group that has CCare IMC, which are clinics. We have about 18 clinics across the country. We also have a C-Lab business, and we also have C-Pharma. So we are one group that's a one-stop shop for healthcare needs. And we are positioning ourselves to be the medical tourism provider of choice in Uganda. And we hope to tap the market from South Sudan, from Rwanda, from Burundi, from Congo. We hope that these people can be able to come to us to be able to access super specialized services. Thank you.
Thank you.
Good afternoon, colleagues. My name is Thomas Ngwiri. I head clinical services at the Gertrude's Children's Hospital in Nairobi, Kenya. And I'm very happy to be in Kampala today for this great conference. So Gertrude's, for those who may not know, is a children's only hospital. So we only cater to children. And that is 0 to 21 years. Although we are a children's hospital, I think we are the oldest in the room. We were founded in 1947, so we are a very old child. We'll be celebrating our 75th anniversary next month, that's October. And we'll be sending some invites to some of the colleagues here to come and celebrate with us. So Gertrude's is a private, not-for-profit, which means we are responsible for our sustainability, not drawing from the exchequer, but all the proceeds, once we pay our expenses, we don't have shareholders, so we plow back everything into the business. So that allows us to develop rapidly. We operate a hub and spoke model. We've got a main campus in Muthaiga in Nairobi, where we have another 16 facilities in and around the country. Majority are within a 50 kilometers radius of Nairobi, but there's also one in Mombasa, which is 500 kilometers away. And just this week, we opened one in Kisumu, which is 400 kilometers away from Nairobi. So as a provider who has been in the pediatric healthcare space for more than 7 decades, we can say we have seen certain trends which are noteworthy. One of them is that when our first satellite clinic, which is what we call them, was opened, it was an attempt to decongest the main hospital, which was bursting at the seams because of very many sick children, the limited infrastructure. But what happened is every clinic that was opened did nothing for the congestion in the main hospital. It just created its own market in the area where it was opened. And that's why the trend continued for all these years. But we also noticed a change in the last maybe 5 years, that the demand for primary healthcare in many of the neighborhoods that we operate, we might say is finally being met. So there are probably trends in the population, health-seeking behavior, healthier lifestyles, nutrition, hygiene, that have seen many of the common pediatric conditions actually reduce. What it has done, it's been a challenge, but also an opportunity. It has made us realize that now the demand that is growing is for specialized services. Good immunization takes care of the everyday problems, but now we are left to deal with the more complex problems. And as an institution, we've seen many of the common pediatric conditions actually reduce. What we've noticed as an institution is that now we need to provide more specialized services. And that's what the population wants. And I think that's a trend that we are going to see, not just in our hospital, but in many of the facilities in the countries in the region. But now we are left with the more complex problems. And
Is the sound okay? Yeah. Okay, let's carry on. So with that introduction, Dr. Ngwiri, I'd like to just follow up on relating medical tourism to a pediatrics only hospital. What are you seeing in terms of both the numbers, the nature of cases, and even just the complexity of a parent moving across borders, if you will, with a child just to get care?
Yeah, thank you. The main trends in the demand for specialized services, a big one is actually cardiac and cardiac surgery. The difference is, unlike what we see in adults, which is degenerative condition, many of the children have a congenital problem. So it's an inborn problem, which, by the way, when corrected, really improves quality of life, and it's usually a one-off. We've seen a major growth in cancer. So oncology services are growing, and there's a big demand. We've got conditions like orthopedics, children born with spine deformities and other forms of deformities that are correctable. We have quite a big number in urology and neurological surgery. And then there's a big growth in the area of metabolic diseases. These are children who have the less common conditions that are of metabolic nature. Most of them are inborn, and usually there's a very narrow window to detect them and correct them. But fortunately, many of them, with the right set of environment, are things we can pick and correct at an early age. The unfortunate bit is if they are not picked early, then usually you miss the window for correction, and that really complicates things. But those are the areas, like fibroid areas, that we are seeing a growth in.
All right, thank you. I must attest, personally, Gertrude's treated my daughter last year through successful surgery. And so I can attest to the fact that they're a top-class facility. Miriam, so you want to be a preferred medical tourism destination of choice for Uganda. You've mentioned countries like South Sudan. And so what are your plans, if I may put it that way, to attract from those markets? And have you already started, attracting from those markets?
Thank you. We are one of the only hospitals that has COSASA accreditation in the country, just showing our focus to quality and ensuring that we have good patient care, and our commitment to making sure that we're able to give the best services to customers. Some of the things that we are doing is to look out for what conditions people will travel out of the country to go and get services for, and make sure that we can build our capacity internally so that we are able to manage this kind of conditions. And this is through collaboration and partnerships with hospitals. We currently are running a medical camp in partnership with one of the hospitals in India, Jupiter Hospitals, and we have brought in specialists who have been able to see patients and do diagnosis. And we're hoping in the future we can actually have them, do a surgical camp by bringing these specialists here, just to make sure that people do not have to travel to India. But if those specialized services can be done within Uganda, because we have the right infrastructure, we have a 10-bed ICU, we have 4 operating theaters that are well equipped, we're able to offer some of these challenges. Part of the big problems that we struggle with in Uganda is around the healthcare workers. We do not have very many super specialists, and therefore there is need for the country to develop the capacity on healthcare workers, and especially specialists. I was talking to my colleague, Dr. Luzige here, and the country has only 4 pulmonologists. So if you have a very sick patient that requires a pulmonologist, you will struggle looking for them. But with partnering with countries that have already developed their healthcare system, that already have very many super specialists, and bringing those specialists here to be able to provide care within our facilities, we believe is one of the quick wins in terms of achieving medical tourism in East Africa.
Thank you. Listening to Miriam, Dr. Luzige, I'm wondering whether in the context of scarcity of resources in terms of health workers, is there an opportunity to collaborate with other facilities rather than compete to be the preferred choice when it comes to these cases?
Thank you very much. And thank you for that point, Miriam, Dr. Miriam. Indeed, if you look at our region, especially Uganda and East Africa at large, I think the low-lying fruits have always been building infrastructure, equipping the hospitals. If you see what has happened in the last 10 years, at least in Uganda, the amount of institutions in terms of infrastructure, even in Uganda, if you travel along one road from Kampala to Namugongo, you'll find how many hospitals we've applied to put there. Those seem to be low-lying fruits. The gist of the issue seems to be in the human resource. And I think if we are to break the box, or to crack the nut, I think the issue is going to be how do we address the human resource issue? Because it's not only a scarce commodity in the public sector, where we are seriously contributing to internal brain drain. That's another conversation somewhere. But even then, they do not meet our needs. So quite often we onboard human resource and we have to retrain them to best practice to suit the standards. And that has been, unfortunately, an ongoing issue. From what I see, we do not have any choice, at least temporarily, to continue advocating to public institutions and the private not-for-profit institutions that have largely been the backbone of training nursing staff, for example, and medical staff. But they have always done that the basic. Now, for us who are trying to provide super specialized services, now Nakasero Hospital here trying to provide tertiary level care facility, we do not have any sample to pick from. If it's there, it's a very small sample size. And so we end up competing. But I think the opportunity we have here is as the private institutions and the private sector, I think we have to. And I'm aware of some institutions like the Clark Institution that Ian Clark already has an institution that's trying to bridge that. I think we definitely need to jump in there. We've left it a lot to the public sector and then the PNFPs, church-based or faith-based institutions. But I think the private sector also has, especially for super specialized staff, nurses in ICU, and nursing in cardiology. Right now, we are doing a bridge. We are doing a lot of collaboration with external institutions. Right now, we have, just yesterday, we had we have a one-year training program for NICU, neonatal intensive care unit nursing staff with the University of Connecticut for a one-year program. So they are here with us for the next 6 months for hands-on training. Those are bridge kind of, they will always help, but they cannot take us far. So as private institutions, I think we have a very huge gap, and it's also an opportunity for us to also provide. I don't think the current setup, and listening to the initial conversations in the morning around investment and funding, government, it will be a very long shot for the government to bridge that gap for us. I'm really struggling with the ICU nurses. I'm struggling with emergency care nurses. I'm struggling with the cancer medication nurses. I'm struggling with the interventional radiology nursing staff to support doctors. We now have a cath lab, 24-hour cath lab. I think the first private hospital to have a 24-hour service cath lab. But, again, mobilizing staff. If a patient came at 2 a.m., mobilizing staff for a time-sensitive procedure like a cardiac intervention for a patient with an acute heart attack, is always a big trouble. So I think the opportunity here is definitely, I think, as private institution, we have to come on board. There is no room. There is no room for us to try and pretend about it. Government does not have that capacity, at least for the meantime. Maybe in the future, but for now, we have to come in and bridge.
All right, thank you. I'll move over to Dr. Nyirinkwaya. Have I pronounced that correctly? So Rwanda is a young economy, growing economy. How are you looking at medical tourism and what are you doing to grow that segment?
Okay. Tourism, medical tourism is hardly promoted by the government. But as my colleagues say, we are in motion. We must understand very well what it's motion. We are in the process to reach a good level. It means we are helped by the government for, so it's okay. It's okay. Okay, so it means that we have a lot of problem to get doctors, as I said, to get equipment, the funds for everything. But with time, we are tackling these problems.
Thank you. I'd just like to let everybody give a quick, soundbite around the lessons we can learn from premier destinations like South Africa and India around medical tourism and how we can implement those lessons in the region. So I could start with Dr. Luzige.
Thank you. So fortunately, there are lots of lessons to learn, but in case I forget, please remind me. There are also some very weird lessons that we need to learn to avoid. Maybe I should start with that one because I might forget. Somebody mentioned here that medical tourism is a big opportunity for us economically as a region. And we've seen what has happened in India, Thailand, and South Africa, and most recently, Turkey. What we have observed, at least, is that we need to be very careful with the way we plan. We need to look at the continuum of care. We've sent our patients to India, had surgeries, very nice spine surgery, then the rehabilitation becomes an issue because, of course, they have to come home. Then the outcome of that procedure becomes interfered by the aftercare here. So we also may attract patients from the South Sudan, from the Congo, and as far as the Central African Republic, they come here. We try to get a package for them, they get care, they go back home. After that is an issue. We need to plan to think about that. I think that's something that probably was not thought through in the beginning. We have also observed that medical tourism, much as we intend to look at it in a very, very good economic terms, but it's also upon us as we plan for it to avoid what we have observed with the current destination, the effects it has on healthcare or health disparities, either in the communities where these destinations are, or from where these patients are coming from. We've seen what has happened in Uganda until recently. COVID, of course, gave us a wake-up call. Our institutions were largely neglected because I could get care and just travel out. The same thing can happen to our colleagues, our neighbors that we are trying to attract. So we need to have, with this regional presence, I think we need to put those things in mind, that medical tourism can also contribute to disparities even within the institution, the countries like Uganda, where we don't want to create a big issue of brain drain. Right now, that is the big issue. Whenever I have an opportunity to meet the minister, they're always looking at me. You are taking our doctors, you are taking our nurses. So those are some of the lessons we need to learn as we craft and we put ourselves to that stage. I think the potential negative impact in terms of health, increasing the negatively impacting on the health disparities, but overall, I think we have lessons to learn in terms of infrastructure and how we can do things quickly, but also creative ways of providing care cheaply. Because quite often we've never had chance to see things how they are being done in the Far East. Our reference point has always been Europe and America, North America, but we are aware about the challenges in terms of instruments, equipment, low-cost equipment that can still do the job. And I think these are things we have learned. If you travel to Dubai, you will find that they do not necessarily, for example, have Siemens. They do not, but they have other alternatives which are affordable. So these are some of the lessons we've learned and given us the courage. But remember about the negative effect that I've also learned, and that we have to keep thinking about this.
Thank you. John?
The challenge, I say, it's a problem of doctors, nurses, well trained. And as we said, we have the competition with the public sectors, but also among us. So, you know that in Turkish, in India, in America, medical schools are very strong. And also the Indians and Turkish, for a long time, were in the field of the medical field. But I think in our country, we are just starting. And this is one of the issues. And I think we have to be very strong. We're discussing with the government how to increase, how to improve our medical schools. And but now I think it's just a question of time. I think we have to be modest, humble, and to follow our own speed, but with a clear target.
Okay, thank you.
So some of the things that we can learn from India as one of the most preferred destinations for medical tourism is government commitment and that deliberate effort by government to work with the private sector through private-public partnerships to make sure that we can forge our way forward in terms of medical tourism. Therefore, there's need for focus in this area. There's need to build capacity through HR, making sure we get the right competencies to be able to support this. And as a private sector, we have an opportunity where we can work together within East Africa. We can, through the East African community, the East African Healthcare Federation, we should be able to market the unique specialties that we are doing. I believe every hospital is a center of excellence for something. Just yesterday, the parliament passed a bill on organ transplants in Uganda. And therefore, as a country, we're looking to doing our first, kidney transplant 2023. We hope to do that at our hospital in 2024. But for us to do that, then we can learn from the facilities within the region that are already doing these services. And we partner, we can have staff placed there. We can have the doctors interacting and engaging. We could send our doctors to Nairobi, to MP Shah Hospital, for example, that's, doing these transplants and have them placed there for some time to learn and to benchmark and to take up the best practices. So I believe together we can work and we can be able to have ties that can help us to synergize and help us to be able to deliver the promise of medical tourism and reduce the burden of people having to travel. The other key thing is definitely going to be around financing, healthcare financing. How will people be able to afford these services? And that's where the conversation of national health insurance is very, very important, because we may have the services ready and available, but people may not be able to afford them. And for us to do that, then we need to work closely with the government to see that the national health insurance, at least for Uganda, becomes a reality. And that will be a very, very strong pillar in making this a success. Thank you.
Thank you. Dr. Ngui?
Yeah, thank you. I would reference to India because even in Kenya, it's been a popular medical tourism destination. And a lot of the lessons are what my co-panelists have said, but also I would want to add that even we as private institutions, because of how critical the human resource component is, we'll have to get into that space of training. We'll have to open our institutions to be clinical training sites for various programs, because a lot of the private hospitals in India are themselves training sites. They have partnered with universities, they've partnered with public institutions, because we tend to have good physical infrastructure. And some of the services that we have to offer may not be available in the public training institution. Just opening ourselves up for trainees to come to our sites works. It's a win-win, because we get to have to increase the capacity to develop the human resource, not only for ourselves, but also for the country. And the trainees also get a good experience with exposure that they would normally not have obtained in the public training institution. The other lesson I would say from India is to think of the medical visitor, to think about them in everything we do. It's about the entire experience. So it's good to deliver first-class clinical care, but the other needs that medical travelers have, we need to understand culture, what works for people, what do they like to eat if they're coming from a neighboring country? Are they clear? Are they fluent in the language of the destination? Or do they need assistance with the entire process? The other requirements like visa, what's our role in assisting them to obtain those things, or do we just sit and wait? So we have to think about the entire patient experience and take care both of their clinical needs, but also of the other supportive needs, so that we give them an experience that is pleasant, apart from solving their medical problem. So thank you.
Thank you. And with that, I'd like to thank all our panelists, and please, with the audience, please give them a round of applause.
Thank you, everyone. That was a interesting session in terms of what's needed. Can I just ask for the next session the people to come forward, please? Daniel Okello from KCCA, Dr. Joan, Mr. Tapley, Nelson Mandela. I always like inviting Nelson Mandela to come forward. Nelson from Strathmore, and then Bilhar. Just come on up if you don't mind. As you're coming up, I just had a couple of thoughts from that last session. One of the things that came out was about human resource, and I think there was two issues in human resource. One was specialty doctors who are highly specialized, and the other, I think, was just care, nursing care, ICU nursing care, post-transplant nursing care, post-operative nursing care, and we don't in Uganda have a shortage of nurses, and probably in the region there's not a shortage of nurses. Kamo was referring to nurses who go out to the of the country. But I think that what we do have is a shortage of nurses who are specialist nurses who can really give that level of care that is needed. Now, a long time ago, I sent several batches of nurses to India to get some training in intensive care And those nurses, in fact, came back and trained many other nurses. In fact, IHK was probably the first place that trained intensive care nurses. But the nurses said to me when they came back, they said, actually, they said, we're as good nurses as the Indians. Our language is better, our English is better, our clinical skills are just as good. But they said there was one difference. He said when it came to the end of the shift and the bell would ring, we would just go off and the Indians would stay there and keep working. They said it was the degree of commitment that the Indian nurses had. And I think it was a tremendous exposure for our nurses to see that, just to be exposed to another environment and to see how they stacked up. Our African nurses can be very good. Our African doctors, our Ugandan doctors are second to none. But we are going to need in Uganda especially to bring back the doctors who are in Kenya, who are in South Africa, who are in the States and in Canada. And we're only going to do that unless we facilitate them in terms of facilities, which is capital injection, and in terms of the conditions that they work in. With those few remarks, let me hand over to my colleague here, Dr. Daniel Okello. Come on, Daniel. Man I used to work with. I'm not sure if I was his boss or he was my boss.
Thank you, Ian. Good afternoon, ladies and gentlemen. We are going to this session about strengthening the role of the private sector, serving the continent's evolving health demands, and is sponsored by MP Shah Hospital. I looked around East Africa and also the world, history about hospitals, and the first modern hospital, or when you talk about modern, was built in the 4th century and was built by a lady called Fabiola. So ladies have been part and parcel of the private sector for long. And in Uganda, the first hospital, Mengo Hospital, was built in 1897. It was also private. And also when you look around East Africa, most of the hospitals came about that time. So with me, I have a panel from MP Shah. MP Shah Hospital is making 94 years. So St. Gertrude, you have competition here. I think MP Shah is taking the lead. So from MP Shah, we have Dr. Joan. Then from Strathmore Business School, which has been in existence from 1961. When you were in high school, when you didn't make it to university, you would actually be told, go to Strathmore. And a few of my colleagues are now CEOs because they went through Strathmore. So Strathmore, thank you. We have AMREF Flying Doctors that is represented by Ms. Bilha Fini. And this would, AMREF, I think 50, you've been there for a while. I think since the 50s, 50? 57. And I think the dream started on the foot of Mount Kilimanjaro. Very, very nice. So AMREF, you're welcome. And then Think Well by Tapley. Jonan Wood, have been working with him. Uganda is his second home. This is Think Well. And he's the senior health system specialist. Think Well was started in 2011. Yes. Yeah, so we have quite a wide range. So let me start with Dr. Joan. She has a small presentation, 5 minutes, that would be able to come up down a little bit. So if you just give us a 5-minute presentation from Joan, which will tell us a little bit about how MP Shah, for the 94 years, how they have managed to be in this private sector space, and how they have managed to increase access, but also utilization of health facilities. Thank you.
Thank you, Dr. Daniel, and fellow colleagues, all protocols observed. So just to give you a short story about MP Shah Hospital, as you heard, it began 94 years ago in 1928. And we date back to Lady Joan Grigg, again a female. She was the wife of Lord Grigg, who was running the Imperial colony at that time, and she began a 5-bedded nursing hospital and a midwifery hospital at the same time. And so as we continue to grow, we were able to grow organically like any old hospital, beginning with, we can move on, beginning with a small 5-bedded nursing home. Then on the top right, you can be able to see our first ward, which is still in existence today, and then went on to build other wards. And now finally, next slide, being able to be a 217-bedded hospital. We have 2 satellite centers currently. One is our biggest CSR program. It's in downtown Nairobi, where we serve the bottom of the pyramid. We have a lot of markets, the main bus terminus that you find in Nairobi, and our consultation fee is only $3. And then we have our village market outpatient center, which is in Gigiri, where the UN and a lot of embassies are. And that's a center that helps us to keep our CSR center running so that we can still reach out to the community. We are aspiring for JCI accreditation because we realize that when we do things in regards to quality, improving efficiencies, then that's how we are able to maintain quality in the hospital and reduce affordability, whereby we are looking at affordability not just from a purchasing perspective, but also from an efficiency perspective. So we can continue. That's the first stone that was laid in 1930. And I think the next slide is our village market center, which you can have an idea of. So just to appreciate the continent's evolving demand, we have seen, and especially during COVID, change in patient-seeking behavior, whereby many people did not want to come to the hospitals. And so basic and essential services like your TB, HIV, malaria, vaccination were affected. Deliveries were a bit late, especially in the public hospital. We appreciate that a lot of our people come from different places and we have become a global village. The third thing that we've been able to appreciate is increased inflation, especially in Kenya. We've had a lot of challenges after COVID, people losing jobs. We've had supply chain challenges where we had delays, doubling the time of delivering some of our supplies, and yet not having enough manufacturing and industrialization. And finally, our clinicians being pulled away, especially the nurses. It's nice in Kampala, you don't have that challenge. But for us, our nurses are going to the US, to the UK, they're going to Canada. And it's a good thing for us, they're ambassadors, but then we are not able to fill that glut fast enough. So in that regard, then for us, having looked at 4 ways in which to respond to that, and one is ensuring that we keep track of the data that we have in the hospital. Data not just of how many patients are coming in, occupancy, but data on what's the turnaround time, are we meeting the patient's need, data on the outcomes that we have so that we can be able to be sure that we are truly delivering value, data on trends in terms of adverse events, in terms of incidents, in terms of the disease burden that we are appreciating. And that data has helped us to focus on 4 areas which we consider our centers of excellence. And those 4 areas that we have picked up, then we have gone ahead to see how can we make a responsive care delivery model. And so from a physician engagement model, being able to appreciate that there are some we will be able to build. And so this we are taking to school, because we are a tertiary hospital for the specialist training, subspecialist training. There are some we borrow who will come in every so often, and especially for our CSR project for congenital heart diseases in children that we run twice a year, where we screen about 120 to 150 children. And we are able to do 25% usually end up getting either open or interventional procedures. For those we borrow, we have a set of specialists who join our team so that we can be able to see as many children as possible. And then there are those we buy, whereby we feel there's a need in the country. And so rather than export our patients, we actually employ them in the hospital for the period that we need to build our own capacity. And then also looking at financing models, or rather payment models, that will be able to attract our insurers. In our hospital, 67% of our patients are actually insurance covered. So we looking at things like diagnostic related groups, bundled payments and packages is very useful. And finally, whatever it is we do, being engaged in research, education, and knowledge sharing. And so even as we do that, next slide, those are the 4 centers of excellence that we have looked at. Cardiovascular diseases, which for us is big, because even our infectious diseases have ended up leading to sequelae of hypertension, diabetes, and dyslipidemias, because they've been on treatment for long, whether it's HIV, whether it's TB. We've seen a lot of those patients also suffering from cancer, and that's a big burden in our country. It's one of the top 5 causes of death, because we are still fertile. Maternal and child health cannot be forgotten. And finally, ambulatory and surgical care. So home-based care, telemedicine, and finally, surgical care. And then under those pillars, we have the various clinics that support those pillars, where we are able to deliver the care based on the disease trends that we have. Next slide. And our pediatric hospital, I won't speak too much about it, because Dr. Ngwiri's hospital is the oldest pediatric hospital in Kenya. Next. And so to do this, we've had to collaborate. The photo there is a collaboration with Avenue Healthcare. One of the participants here noticed a Ugandan doctor in the photo. So they are thriving in Kenya, but partnering with fellow hospitals in Kenya where they do not have a service that they're able to deliver, that we are able to fill that gap, so that we are all not duplicating our efforts. Next slide. PPPs with government. And so that photo is actually as recent as Tuesday this week, where in Kenya, we launched our diseased donor renal transplant program. And on the extreme left is the head of East African Kidney Institute in Kenya, Professor Mungai. Next to him is the CEO of the Kenya Tissue and Transplant Board. And so just partnering so that, and for us, appreciating that the government takes a long time to implement. And so they are constantly looking at who in the private sector can actually pick up and we get the services running. And then knowledge sharing, we had our first annual quality improvement and patient safety symposium. We had 37 hospitals from all over Kenya attending, and a total of 360 people who attended. And the photo next is co-creation. We meet with insurance companies together to co-create and see what will work for our mutual patients. We meet with corporates, those are HR managers, to be able to support the needs they have. I think next slide. And finally, just to know who's behind this, every big team or success story has human beings behind it. Next slide. And our people are, we have about 1,000 staff, and someone asked why so many, but this is determined by the volumes that we see and the ratios. For example, in our ICU, it's 1:1. Our HDUs is 1:2, 2 nurses to 1 patient, two patients to 1 nurse. And then in the wards, depending on the acuity, is 1 nurse to 4 to 6 patients. Our senior management team is 84% female, and thank you. And the rest of the hospital, we are 64% female because of the nursing fraternity. So also just encouraging growth of the different people in the hospital, and also appreciating that nothing happens without the team that works behind us. So finally, we leave for stories that we can be able to share that patients can talk about. And those are different aspects with the CS for Health, with the First Lady, with the team of nurses celebrating, and one of our doctors was appreciated with the WHO DG Award for her innovation in last mile care delivery for mothers who could not access medical care. Those are just 3 photos of some of the beneficiaries of our renal transplant program. One of the challenges is that it's an expensive thing that we have. However, we've been able to reduce the cost to 16,000 USD so that we can help Kenyans and hopefully the region not to have to travel out of the country to India, but get the care here, capacity building, knowledge sharing, reduced hospital stay, cultural issues are not as difficult. So thank you very much.
Thank you, Joan, for taking us through that, how the private sector has been able to place itself, especially the innovations. I picked up the issue of cross subsidies. The other was use of quality indicators for management, then the employing patients. There we can have a discussion after this, how to employ the patients, innovative pricing, and also collaborations. And one of them you gave were the PPPs. So next, Tapley, Joan has taken us through the innovations in the private sector. And right now, everybody is talking about universal health coverage. And one of the things there about people should not be financially disadvantaged in order for us to have universal health coverage. What are the prospects of the private sector involvement or fitting into this? You can speak.
Thank you very much, Dr. Okello. Again, my name is Tapley Jordan Wood. I'm working with a group called ThinkWell that does a lot of work closely with the government on health system strengthening and health financing. One of the clear areas that we're interested in is finding ways in which to move towards UHC, which is not always easy. And if you look across sub-Saharan Africa, and is very true here, you see a lot of the health systems taken as a whole have a tremendous amount of resources that are within the private sector. And if countries want to move towards UHC, they're going to need to harness as many resources as they have available. And so that is going to include finding ways of bringing what's often a large, not always well-organized private sector into a larger vision of delivering affordable healthcare, especially to those who really need it. So one of the strategies that has really come to the fore has been the idea of strategic purchasing, which put really simply is government pooled money being used to buy services based on really clear objectives, and then using evidence to make sure that they're buying the best value that they can to achieve those objectives. And so here in Uganda, we've been working very closely with Dr. Okello and at KCCA to look at really practical ways of putting into practice this idea of strategic purchasing. And one of the things that Dr. Okello has brought to our attention very early on was the idea, the fact that here in Kampala, it's only about 1% of the facilities are public. It's a vast array of private providers. And the few public facilities that do exist are, of course, delivering services for free. And that creates a dynamic where a lot of people want to access those free services. And it creates a lot of congestion, and that can directly affect the quality of care, et cetera. And so we started exploring how can we address this clear problem of congestion and look at ways to use strategic purchasing with the private sector to come up with a solution. And so that involved a lot of very analytical studies. First of all, we really needed to understand what was driving the congestion within the public facilities. And we focused in on maternal child healthcare as our area of because you can't take it all on at once. You need to really focus in. And then, looking at why is this congestion? What's driving this congestion? What are the effects of this congestion? How are facilities trying to cope with this situation? And then after we did that, we started to undertake another study, which was who are the clients coming for this service and where are they coming from? And why are they still seeking these services, even seeing that they're so congested, and what's their experience? Moving from there, looking to the private sector, we did an analysis of private providers in the near vicinity of a couple of these congested facilities here in Kampala, Kasenye and Koala Health Center 4s, and did an assessment of their capacity and their willingness to enter into some kind of agreement. And so what's come out of all of this is an idea that KCCA could use public money to purchase private healthcare services that are very clearly coordinated with what's available in the public facilities to essentially form a network around that facility and access additional capacity in the private sector in order to move towards decongestion. Strategic purchasing requires that you really think carefully about how you allocate your money to achieve that. And I think the analytics have driven us towards putting together a good first model pilot of how this purchasing arrangement would work. And without going into too much detail, it would involve, an essential element of this is that there's government money involved. It needs to be government pooled money allocated to this task. That said, there's still a lot of research and development that needs to go into this. This is a very small pilot idea that would be testing the operational aspects of this idea. And then once we do that for even a short period of time, there's a tremendous amount to be learned that can be used to iterate the model towards something that's more efficient, buying greater value, and deepening the contractual relationship between public and private, which in our minds is not only an interesting thing to explore and potentially a solution that could help out Kampala's health system, but would generate a tremendous number of lessons for future purchasing in Uganda, namely the NHIS, which if it's going to really purchase sufficient services to cover all Ugandans, is going to need to access a lot of capacity to deliver those services. And a tremendous amount of that capacity lies within the private sector. So that's a summary of what we've been working on.
Thank you, Tapley. I always have this thing that the public sector can be as good as the private, and the private sector can also be as good as the public. We are all in this together, and I think that's the way we need to look at it. So next, we'll shift gears to the academia, Strathmore Business School. Many players tend to invest in the health sector, especially the private, those are visible. But usually academia is not very visible outside there. So Nelson, you tell us the role of the academia in the transfer of cross-border investment and what Strathmore has done, especially investments as regards the health sector.
All right, thank you so much, Dr. Okello. So a disclaimer to Dr. Ian Clark, I prefer being Mandela Nelson because you see the name Nelson Mandela is a hard name to live up to. So I think I work at the business school, which is a branch of the wider Strathmore University, which is a mid-level university that has been in existence since 1961. It started as a mid-level college, moved from a school, moved to a college, and finally moved into being a fully chartered university. So the business school has been in existence for the last 10 years. And for us, I'd align my talk in terms of the 4 pillars that the World Bank has been talking about UHC, which have been based the discussions for this particular event. That's financial protection, strengthening health service delivery, inputs, governance, and fostering innovations. So on our bit, I would say all these particular investments, all these cross-border interactions can only work if and only if we do proper capacity building in terms of, yes, we're having this innovation, we're having these investments, but there are people who will push this agenda forward. Are these people trained in the right direction? Do these people have the capacity to ensure that these particular investments go to fruition? Are these people, are the leaders that you have in terms of, do they have the right terms in terms of governance? Do they understand governance? Do they understand policy and the like? So in terms of cross-border interactions, we've really tried, and really appreciate considering this an East African Healthcare Federation. We are based in 3 East African countries, that's Rwanda, Uganda, Tanzania, and Kenya. So I believe we have tried to improve capacity building in terms of the critical sector, in terms of what you guys are doing in the healthcare space. What is the main thing that you miss in terms of training, in terms of what don't you have as you train in the medical field? So our major courses are aligned to the leadership aspects. We look at, we have trained over 1,000 executives, like Dr. Okello had said, majority are CEOs. We have quite a number of executives out there. And for us to foster these discussions forward, you need to do the research. You need to employ guys who have the proper learning, who have a proper leadership. Yes, you can have an innovation. You can start an innovation, but give it to somebody who doesn't have the right governance skills. He doesn't have the right skills to foster the forward. So for us, it's more of about capacity building in terms of growing the economy, looking at opportunities and programs that are aligned to specific agendas. We've recently, here in Uganda, trained the Board of Governors for CIPLA. And I believe such customized programs go in line with what we have been discussing in the last 2 days. Thank you.
All right, thank you. We'll move to Bilha. Health access, reach, and coverage. I think these are words that you're very familiar with, and we know you've been a leader in the air ambulance in the region. So what are the lessons that have been learned from 1957 that can be shared? What are the opportunities to improve access, reach, and coverage, being that you're a private sector player, but also in the mind that for the last 2 or 3 years, we had the pandemic, and AMREF Flying Doctors was heavily involved in evacuations, both within East Africa.
Thank you. Thank you, Dr. Daniel. I think first I'll just mention about the EMS as large, and this is for the East African region. I think this is one department that has been, I wouldn't say ignored, but it's a very sensitive department, because I think all of us in this hall are talking about how to make sure that this life gets to the hospital, how to make sure that the medicine gets to the patient. But I think there's one key element that we're missing out, and the key element is, how does this patient get to the excellence of, the medical excellence where he needs to get treated, or where he needs to get the medical excellence that he needs. And I think with the pandemic, we saw a lot of gaps, and this is where the EMS platform really joined hands to see how best we can work out on how to save this unstable life. And one of the key things, I think maybe probably most of you realized, that the ambulances don't have oxygen, for example. Maybe we don't have a paramedic in these ambulances. And this is where the EMS comes in. So I'll just first mention one of the things that we did under the pandemic from AMREF Flying Daughters. And one of the key things, or to ease the burden, was to bridge the gap between getting the patient from where or she is to the point of excellence where he needs to get the medical facility. And that came in from retrieval and prompt retrieval, which means we had, time is of essence when it comes to emergency. So we had to make sure that, it's prompt for us to do the retrieval of the patient. One of the other things from AMREF Flying Doctors is that we invested in an ESO chamber. This means that once the patient gets into the ESO chamber, you can't, there's no more infectious, again, from the nurses, from the doctors who are taking care of the patients. The other thing is that we also added our capability and capacity, which means we invested in more infrastructure, and we are proud to be having invested in a jet that will do long hauls and short hauls. And I think when we mention about Africa at large, we are supposed also to be very proud that we have a long haul that the international insurances and the international, outside are also giving us a leeway to make sure that everyone is at it. So the safety in patient care during transfers, for me, it's a very crucial part of it, because it's actually a gap between how do we put this person to be alive by the time they're getting to the medical facility of their choice. The other thing is that we proudly evacuated over 500 patients in East Africa and also in the continent. So one of the things that we did, again, as we mentioned, just to be on the platform of the East Africa, is that we had partners with hospitals, that is East Africa hospitals, being in Uganda, Rwanda, South Sudan, Ethiopia, and Kenya at large. So which means we made sure that as we do the evacuation, we had clearance from different countries so that we can get into the in-depth of where the patients are to make sure that we evacuate effectively. Thank you, Doctor.
Thank you very much. As far as I'm concerned, I don't think there is a public flying ambulance service. So again, you could see what the private sector have done. But what you've learned, training is critical. We have also seen the practical methods of how M-PESA has been able to increase access, although the private entity. So I would like to pass it over to the audience. We'll pick 3 or 4 questions. I know I'm between you and the lunch. So if there are any comments or any clarifications, could someone move around with the mic and just be able to speak? You could raise up your hands. Yes, we'll start from there. All right, here to my, okay, you can start from there, then come right.
Thank you, Dr. King. My name is Robert Wostrom. When we come to forums like this, we are given an opportunity to extrapolate more conversations around issues. To attain health-related goals, and particularly universal health coverage, emphasizing the need to strengthen partnership between government, civil society, and businesses to reach the agenda objectives. It becomes very important to effectively or find ways to effectively convince the private and public sectors, and to effectively engage the private sector in health. There is a need to necessitate greater understanding of the contributions of the private sector to healthcare. This goes to every person at the panel. What do you have to say about this as regards better engagement of the private sector in health service delivery?
Thank you, Robert.
Thank you very much for that presentation. I think mine is a comment, and where I see an opportunity for public-private partnerships, especially on the emergency evacuation aspect. There are examples in Kenya where you do have an evolved system, even county governments contracting private providers to be able to do the evacuation and the emergency transport of people within the counties. And so if I use Narok as an example, in Kenya, the county has contracted E+. And within the county, they have established a central area, a central command post that if there's any emergency that is within the county, you can coordinate that with their central, with the central office where they coordinate all the emergency services. They are able to dispatch, they're able to collect the patients and get them to wherever they are needed, not only within the county, but also out of the county. That way, you end up having a very strong emergency response, and I see that as an opportunity, even with AMREF, where if the governments are able to do this through partnerships with the private sector, then you can end up having better emergency care as and when you need across the country. Thank you.
All right, thank you. I can have one there. As you get there, I have a friend who owns the tourism lodge, and one of the things, the questions was asked from his clients was that if I fell sick, how would I be evacuated? So we could look at the opportunity of coming together and then trying to get there in the tourism sector, because I know in Rwanda we have the mountain gorillas that seem to be rather remote. In Uganda we have the parks that are remote. In Kenya we have the big five, and I know most of the parks are quite far from health facilities. So that partnership, I think, would be something you could explore. Yes.
Yeah, good afternoon. My name is Membo Musizi. I work with Uganda National Health Consumers Organization. And my comments partly are for the previous speakers, but also for the current panelists. I started toward the exhibition side, and I really learned a lot about the different services that the different health providers are giving, which I didn't know. So, which I learned from SHA, but also from Gertrude's Children's Hospital. So it pushes me to the issue of how can this platform, East African Health Federation, create sort of a database for us as consumers, in case you want a certain service that is not provided by a health facility in this country, then you are able to get such services from wherever they are for affordability, but also the accessibility. Is there a way? Because when I was discussing with them, some of them actually indicated that is the gap. You know, if the health facilities in this country can create, you know, those clear linkages, and we know all the way from prevention, even this screening that we are talking about, so that we know that if IHK or Nakasero Hospital, whichever, can't do certain screening, then we are able to go to another facility, even outside, especially in East Africa, since we are talking East African integration. But also to bring in the issue of these lower health facilities where majority of patients go. Because we have big facilities here, but there are other small health facilities, and the patients go there, but you don't find services there, and you cannot afford the cost at these big hospitals. So if there is a way to bring all this together, you know, for availability. Then I also wanted to talk about the issue of the cost. We have had and seen the patient situation. They are of recent on increase because, you know, majority of people cannot afford it. So as private players in partnership with government, how can we actually try to reduce on this? Because it puts a lot of fear among the patients, and patients actually choose to die other than they actually, it is not only consumers like me who is not a health worker. last year, I think in 2021, a doctor was detained for failure to pay. Yeah. So I think maybe we need to look at some of those issues of the cost and the prices. The last comment from my side is the issue of how government health workers, especially the doctors in the government health facilities, can, work properly in a way that they can both work in private like they are doing, but also be able to deliver services to government at the appropriate time.
Thank you. I was told that a man may be a pessimist before lunch and an optimist after lunch. I want you to remain optimists. So please allow me to cut this short. But Mabel, let me take the bullet for them about, I think you more or less summarized how our health system needs to be run. I don't think we can have all the answers in this room for your first question. The second one about patients' rights and how they should be managed. And I'll speak on behalf of government since I work with government. I think this is something we need to work together. But again, it looks about affordability and the discussion of pooling and national health insurance. So this is not something we may have all the answers within, because as I say, is that everybody is trying to see what we can do the best. But again, which investments should government do to interfere in the market, and how do we allow the private sector to be able to come in? So I think there was a question. The other one was a comment. Robert's question, if you'd allow me, was addressed to all, and let me use that question to be able to summarize our session, if you remember it. So I can start from Nelson, then you can use that question, summarize, and we come to the end of our session.
So thank you so much, Dr. Okello. Thank you, Robert, for the question. So I'll try to summarize in terms of health system delivery, and I'll look at digitization, as that was the second bit of what we were to discuss from an academia point of view. I would say digitization, we are a global village nowadays, and you can be here and be having meetings that are miles away. So in terms of health system delivery, my comment would be for us to be able to interact and be able to form in this global village, we have to go digital. And digital means training in this particular phases that we are going into. The global pandemic, COVID happened, majority of people did not understand how to use Zoom. Majority did not know that I could be interacting here. We've seen live sessions of guys discussing while they're still in their, guys in Tanzania discussing, but they're still here. So for us, I would say in my conclusion, health systems delivery is critical. But it's critical in the sense that do you have the knowledge? Do you have the skills? Do you have the training to be able to deliver in that health systems? Because in a health system, it's more or less digitization. We're going global. So are you able to align yourself with those skills? A few years back, we didn't know that digitization would scrap off a lot of jobs. But look at us, where you're going now. The world is going digital. Everything is global. So in terms of health system, we need to really align ourselves in the health system sector and ensure, and by aligning this, you need to invest in your personnel in the various capacities that you are in training, various capacities that you are in knowledge development and research. Research is very critical, like Professor Kama Hadia said, that we need to do quick research and innovative research areas that would help us be able to underscore, underline these particular facets in the healthcare space. Thank you.
Thank you. I think I'll mention on the partnership of the evacuation part of it and the pricing of the evacuation. So the first initiative that we have taken as Ambre Flying Doctors is that we saw what happened in the pandemic part of it, where we saw a lot of people not able to raise funds to do the evacuation. So one of the things that we have done is that we have come up with something for the East African region to make sure that each and every East African resident can access affordable evacuation, not necessarily just incurring that huge costing. So previously we used to have per evacuation, it's around 13,000 USD. That is one evacuation. But we came up with something for the East African resident just to make sure that in case you need an evacuation, you don't incur costs. So for $55 per year, for the Kenya, Tanzania, Zanzibar, Rwanda, Uganda, and Burundi, a whole year, you can access unlimited evacuations. So maybe probably I'll just urge the members who are here with us, in terms of partnership, we are very ready for partnership in terms of just making sure that our members access evacuation, not necessarily having to have, that headache. So it's more of just a peace of mind, just knowing there's a team on standby for you in case you need that evacuation. The other thing is that we're also open to the government. We are trying to do a lot of initiative for the government to just, approach the EMS companies and also EMS at large, because we feel like it's a very delicate part of it to just save that life when it comes to be saved and stability in the first place. So I would urge, if we have any government, probably for the Uganda government, Rwanda, South Sudan, kindly just reach out to us so that we can partner. And again, just to summarize, we really would wish a lot of clearance in terms of the landing permits, because that is one thing that really gives us a challenge when it comes to the landing permits. Because again, for maybe probably I just mentioned for Uganda, we have to go first to Entebbe for clearance for us in case we need to go to any other region. So some of these things, if we have a government intervention, will really help us to get into the internal places where we can just, have a leeway and make it much easier for us to just get to the patient as fast as we can. Thank you.
Okay, mine is how do we partner and collaborate? One, we need to know what options are available. I think from yesterday's discussion, you saw for Kenya, we actually have a PPP collaboration strategy. So appreciating what are the models that are available. We have both PPP and non-PPP collaborations that can happen. And I'll just give an example of during the COVID pandemic when we began vaccinating. A lot of the vaccinations were done by private sector because we were able to go out into various communities to vaccinate. We did not charge any patients any money. To this day, we still do not charge. It's a free service that's been given. And we went to the community, to the markets, to the offices, everywhere to support and ensure that the government is able to meet its goals and demands. In regards to services in areas that are difficult to reach, which are not emergencies, we have to be innovative. We have to find the gap and then try and fill in that gap with a solution. And I remember, especially during COVID, we created a service called Lab on Wheels, and we had different lodges come and pick our phlebotomists to go and collect samples, do testing on patients to be able to serve them and deliver medication as required. So the question is there a gap? Is there something I can do? And it's interesting, those people are willing to pay. And then finally, just to share learning from the Kenya NHIF, we have been able to stratify different hospitals that different patients will go to. So the referral system has been streamlined so that not every patient will go to MP Shah Hospital or Aga Khan or Nairobi. They will go to the hospital nearest them, whether it's secondary care or primary care, and dependent on what is found at the place where they go, then they will be referred to a tertiary level hospital. So also having those streamlined systems in place helps in regards to referral processes so that patients don't all go to one place. Thank you.
Tapley, you may close this.
Yeah, thank you very much. Robert, I really appreciate your question about what's it going to take to really create meaningful partnerships between public providers or public systems and private providers. And I think there is a really significant gap there right now. In my work within the public sector, I've often heard profit being called a bad name. Yet there's not a real honest examination of inefficiencies in the public sector. And I think one of the ways that this can happen is to have some really unbiased, clear evidence about which system and where is not only delivering the best value, being a combination of cost and efficiency and quality, but which one has potential in particular areas to deliver the best value. And the other way I think to bridge this gap is through practical examples that explore this territory, set up relationships, iterate based on learnings, and build out a set of positive examples that show the added advantages to both government and private providers in a meaningful public-private partnership arrangement. And so those would be my two suggestions. Thank you.
Thank you, ladies and gentlemen. Please let's clap for our panelists. And I've learned that for a bottle of wine, you can be evacuated to MP Shah for 1 year at no cost. So the holidays are near. Make sure that we can reserve that bottle of wine and evacuate it by April. Thank you again. Please, May.
Thank you, Daniel. Thank you, panelists. Interesting session. Could we have, we've just got one more quick session before lunch. May as well bite the bullet, get it done. If we can have Nevin Bradford, please, from UHF. And then we've got Quality Chemicals Director, John Mahili, East Africa Medical Vitals Managing Director, Brian, and Africa Health Business, Dr. Daniela, AHP. Dr. Daniela? She's here. Okay. So this is under security of supply, made in Africa for Africa, sponsored by Cipla Chemicals. Thank you very much.
Thank you, Ian. Although we are running late, we'd just like to guarantee that the security of supply of your lunch is guaranteed. Seriously though, one of the myriad challenges that was thrown up by the COVID epidemic and is ongoing is the security of supply of essential commodities. Not just healthcare commodities, but commodities across the board. But for the next 30 or so minutes, we'd like to focus on the security of supply of essential healthcare commodities, pharmaceuticals, other healthcare commodities, which faced considerable challenges during the COVID period. Several African countries faced severe potential out of stocks of life-saving drugs, ARVs amongst them. Fortunately, to my knowledge, none of them actually went out of stock of these essential medicines, but at least in one country in Southern Africa, it was really touch and go. And it was only through local manufacture in Uganda of an essential first-line ARV that an out of stock was prevented. And even in the last 2 weeks, we read that Zambia is facing supply shortages and difficulties of the first-line ARV therapy, TLD. So security of supply, which we've been discussing for several years, really is top of mind amongst not only healthcare providers, but also I think moving forward will be top of mind amongst ministers of health and governments as well. We're joined today by a panel of three. Dr. John Camilli, who's the company pharmacist and a director of Cipla Quality Chemicals, which is the largest pharmaceutical manufacturer here in Uganda, and one of, if not the largest in East Africa. Exports ARVs and antimalarials from Uganda to, I think it's 18 countries in West, Central, Southern Africa, and also exports ARVs to South Africa. We're joined by Brian Kivuya, who's the MD of East African Medical Vitals. East African Medical Vitals is a relatively new healthcare manufacturing provider here in Uganda, focusing on the manufacture of medical gloves and sterile gloves for surgery. We're also joined by Dr. Daniela Winene, who's the head of consultancy at Africa Health Business, a consultancy partnership based in Nairobi, which focuses on the healthcare industry. Without further ado, I'd ask John Camilli to explain how CIPLA Quality Chemicals is addressing the issue of security of supply and how you intend to move forward with this. Thanks.
Thank you, Nevin. Good afternoon, everyone. I'll introduce myself once again. My name is John Camilli. I'm Executive Director of CIPLA Quality Chemical Industries Limited. I'm also business lead in public sector. Just a bit of background about CIPLA Quality Chemical Industries Limited. The company is a publicly listed company, but we started our journey way back in 2008 when we commissioned a factory in Luzira. The company was formed as a joint venture between CIPLA, a global generic manufacturer based in India, and Quality Chemicals, which is a local company that at the time was into distribution of pharmaceutical products, specifically from CIPLA, India. So that joint venture with heavy support from government. And I must emphasize that particularly the product that we are ventured into, HIV, malaria, hepatitis, are heavily funded by government or donors. So we needed that push from government to be able to convince our technology partner, CIPLA, to come on board. So we, knowing that the products were into funded by government and donors, especially Global Fund and USAID, we knew that the required quality system that we need to be able to access that funding is world class. So we had to prepare a facility for WHO approval for GMP compliance with the GMP, the good manufacturing systems, to be able to access the fund. So we secured a government offtake after the inception of the factory to guarantee that investment, because it's huge investment. Our initial investment was about $32.5 million to set up the factory. So that helps us, the government guarantee or the offtake agreement gave confidence to our technology partner to be able to invest. But relying on government alone was not sustainable. That's why we invested into a WHO facility. We invited WHO team to come and do inspection in 2010. And in less than 4 months, we had the pre-qualification. So we had a WHO approval. And I think we're the first company in Africa to have the World Health Organization pre-qualification certification. So when we had the inspection approved, the next step was to access the Global Fund and USD money, because if you look at the funding mechanism for HIV, malaria, and hepatitis, 30% of that fund comes from government of Uganda. The rest, about 60% of that comes from the Global Fund and the USAID. So we, after 2 years, we started doing business with the Global Fund, and we kept really talking about local manufacturing as a solution to security of supplies in the region. But at the time, that was very difficult to convince the funders and governments until COVID came. And that's when things started to be real. Because at the time when COVID hit, just to give you a bit of background how the system, the healthcare system, especially the security of supply was designed, was on two foundations. We had, and I think it's still the same way, we had entrusted manufacturing or sourcing in one part of the world, especially India and China. India as a source of the finished product, China as a source of raw material to supply to India to provide us with the final product. The other way we had entrusted the world also is the global supply chain systems.
So the product, we were so confident that when the product manufactured in one part of the world, especially for Africa, where we don't have our own manufacturing capacity, we place the order in the manufacturer in India, and the global supply systems will deliver that product in a very short time. So things look nice until COVID came. The manufacturers, when COVID came, manufacturers ran out of capacity. First of all, they had to repurpose to fill the needs of COVID. Secondly, we don't have enough the deep pockets to be able to queue up at the front to buy those products. Secondly, the supply chain had also broken down. Airports were closed. Those who managed to move products also had challenges because they had to prioritize rich economies who have more money than we do. So in fact, if we have colleagues here from the Ministry of Health, they will tell you, I think we're in a dilemma. Because even when we don't have much money, but even the little you have, there's no one willing to sell you. The queue is long. You're at the bottom. And that's when the government and our partners started seeing the value into local manufacturing, because the only option was to source from either Uganda or from the region and share the little we had. Now for Cipla Aquatic Chemical Industries, because we are partnered with a global company that has presence in India, in Europe, and in South Africa. When COVID came, at first, many of us in Uganda, we thought it's a European problem. It's an Asian problem. We have enough, a strong immune system, all kind of justification that COVID is not going to come. But because we were connected with Cipla, we started planning as a global company. That back in March 2020, when COVID has started. So we had to take measures as a company to procure, very painful measures, procure stock, raw material stock for up to 9 months. In finance, we actually, at the time, Nevin was there, finance team was like, this is a lot of money you're keeping here. But we knew this is going to happen. So we stocked. And when COVID came, all the patients on HIV medicines had trouble with the supplies, not just in Uganda, but also in Zimbabwe, in Botswana. So we had to ship during COVID, charter planes from here to Gaborone in Botswana, to Zimbabwe through trucks. For the first time, imports from Uganda, they saw the first import from Uganda to Harare, Zimbabwe. So all these countries, the only option they had was to source from Uganda. And we had to run 24 hours, trucks moving from here to Mozambique, to Zimbabwe, to South Africa, to all these markets to be able to supply. So from that background, Nevin, I think local manufacturing is one of those areas in the designing of public healthcare systems and security of supplies. Local manufacturing has to take center stage, and not just on a piece of paper, but to have tangible actions to have sustainable supply.
Thank you, John. That's a powerful exposition of the importance of manufacturing in Africa for Africa. Brian, your company is a relatively new entrant into the healthcare manufacturing field. Maybe you can share with us some of the challenges you faced before and after COVID, and how you see your business developing, maybe not just in Uganda, but how you intend to develop your business outside of Africa, in East Africa, outside of Uganda, in East Africa, and maybe beyond.
Thank you, Nevin. So once again, my name is Brian Kavuya, the Managing Director, East African Medical Vitals. Our journey started December of 2016. And the company, basically, the idea was formed by 3 companies. One, a subsidiary of the Legacy Group, which is our main financier, Ugandan business. Also, we had a Vaso Investments that was supplying government with Mama Kit and gloves, surgical gloves. So there we had a bit of the money needed as well as the market. But important for us, in order not to get things wrong, our third partner was a Sigma Capital, which is an investment advisory firm, which took on the feasibility all the way to sourcing for financing, and furthermore, all the way to project management, project implementation. Just like us, short in the feasibility took us a bit of time because finding the right technology partner, or maybe in our case, it wasn't a partner, but the source of the technology. It was really difficult. The best manufacturers of our products, which we started with, we have a dream to do more than just gloves. We want to go into syringes and catheters, and we have a whole wide range of medical consumables. But we started with gloves from our market research. Now, one thing that we saw from the get-go was that in Uganda, over 70% of the medical consumables market is controlled by government. And again, from our market, from our feasibility study, we knew of the CIPLA story. And so we did the same, went to government and asked to get into an MOU, which would, finance, which would basically say that if we manufactured anything here and it was good quality and fair price, the government would buy it. This was extremely important for us to get financing, which we finally did get in December of 2019. One important thing that we did also, we realized, because we've realized the technology was quite specialized and it was going to be quite overwhelming for our Ugandan people to get into, to actually see this whole machinery set up, and having never been involved in the same industry with no reference points in Africa, really, we took the bold decision to send 14 actually, engineers. I am an engineer myself, and I was supposed to be the 14th. Our team of young, bright engineers got on a plane in early January of 2020, after they had all just got contracts. And as soon as, or shortly after they landed, maybe a month into their training, we were hit by the COVID. They were affected by the COVID pandemic. Whilst in the initial stages, they were able to work and to get the training. I think they did it for about 2 months. And then we got real concerns at that point. How would they come back? The bank had financed us and we had made deposits on machinery. Construction was up and running. And so we were stuck. So, I mean, all in all, I must say we went through quite a lot of challenges. I think we had an overall delay to project startup of about 18 months that was totally connected to COVID. Financing was a big challenge because we got some waivers in terms of restructure of the timelines around our grace period, but interest kept on running and we had to keep, financing that. It was quite a challenging time, but we somehow managed to get through all that. And in September, we started operations. We are 1 year old now. After getting our licensing from the National Drug Authority, I'm happy to say we were able to go all the way to good manufacturing practice. And, we've been in the market. This year has been, now to answer your question, Nevin, this year has really been, because we got certified after most of the government contracts had been given out. So this year has been really trying to, the first financial year ending June 2023 was all about trying to get our offtake agreement actualized while in doing our best to keep our doors open. We've received finally some support and we continue to do that. We've also broken into the private sector. In our product line, the prices are as volatile, I think, if not more than oil. So it's been a bit difficult because I think we had a lot of gloves come in and because of the COVID pandemic, and then quickly after 1 year, it reduced in its intensity. So we've had challenges, but we are in the market. So once we realized that our local market and government wasn't fully ready for us, what are we doing now? What did we focus on? We realized that in order to get into the international market, certification was really, really important, because as much as we are in the East African community, the challenge we have is that the regulations for medical consumables and pharmaceuticals are still not regulated in unison. So we faced a challenge then of getting ISO certification. Even though after reading through the standard and seeing that we had actually put all the right infrastructure and systems in place, we struggled because there's hardly any representation in Africa for bodies which are certifying bodies, which are accredited to certify an entity such as ours. That has really been where most of our focus has been since we got our NDA certification, and I'm happy to inform you all here today that we are finally ISO certified for medical devices in our product. And it was quite an achievement. We're about less than a week old in this certification, so we're quite happy about that. But that has opened us up now to more market. And we hope that in the next year, we'll be able to actualize our agreements with government more firmly. We are already we already put in place plans, and we're in the process of doubling our capacity. Because of concerns still around COVID, we decided, and also lack of finances, we put up our factory, but in a bit of a suboptimal way. So we need, because our current capacity right now is equivalent to 85% of Uganda's need for surgical and examination gloves. That's about 75 million pieces of gloves annually. But we need to double our capacity so that our factory is optimum and we can serve the East African region and East African markets. Just to give you a perspective, we currently, when you compare us to a typical factory at supplying African countries with gloves, we have one production line, whereas over there in Asia, they have about a minimum of 6 to 9 production lines. So important for us is to expand, bring our costs down so that we can access the market. Thank you.
Thank you, Brian. Yeah, economy of scale is important in any field of economic activity, and the best of luck in getting there. Dr. Daniela, from your perspective as head of consultancy in the Africa Health business, do you see that the concept of made in Africa for Africa is better accepted post-COVID than it was pre-COVID? And do you see actually any concrete moves by potential healthcare manufacturers, providers to invest in this?
Make in Africa for Africa, I think is definitely better accepted post-COVID. But I think it's always been the reality that for sustainability, we can't escape being self-sufficient. But I thank the pandemic for accelerating our thinking to see that nobody really cares. We have to care for ourselves. Africa Health Business is a management consulting firm that focuses on healthcare business in Africa. So we provide strategic advisory for people who are in healthcare, whether they're foreign-based or locally grown, but they have a footprint in Africa or they want to enter the continent in health. And I'm very inspired by the stories of CIPLA and East Africa Medical Vitals and how they're bridging supply gaps in our continent. The reason we do what we do is because we still feel that private sector is not leveraged enough to contribute to the health system. The health system has very many pillars, and today we are focusing on health products and technologies. But first, let me start by saying, Naveen, that, just from what we noticed during COVID, that we're very import driven and that's risky. We must grow our local capacity. The other thing we must recognize is that donorship is also not sustainable. We must move from donorship to ownership of our health system needs. Now let's zero into the needs for health products and technologies. In the East Africa regional bloc, we have close to 100, I believe, local manufacturers of health products and technologies. If you add Ethiopia, the number easily crosses 100. That's not bad. If you see that just one firm is meeting 85% of one country's surgical glove needs, what we can do a lot with 100 drug manufacturers, and I believe the medical device manufacturers are close to 30 in the region. But are we leveraging them well? Are we optimizing our use of this existing capacity that we have? Are we harmonizing the tariffs around the regional bloc? So I think, because we know that we want to move from donorship to ownership, we want to be less import dependent. We also know that we have no shilling, or franc to spare. I think we really need to adopt private sector thinking, business thinking, to manage our health systems in East Africa. We must adopt an enterprise planning approach. Let's think of our 7, if you like, 8 countries as a business, as an enterprise. And this will require us to map the demands of our health products and technologies, to map the supply gaps, and then to keep tracking performance. This will reduce fragmentation, it will reduce duplication, and it will lead to efficient use of the meager resources that we have. We also need to go further than that and map not just the demand of the actual products, but map the enabling environment, our policies and regulatory frameworks. It's very disheartening to hear from a leading manufacturer of medical devices that's ready to go that the lack of harmonization in the region is hampering his progress. And we come here every year and we talk to government and we say, create a better enabling environment. So government, wherever you are in the crowd, we need this harmonization to be effective and to reflect the real on the ground needs of the market authorization holders. It should not be difficult to get recognition across the region once you're already approved by the NDA. Now, we also need to map the capabilities we have across all the business processes that go into producing our medicines and medical devices. And thinking of the region as an enterprise, let's map our API manufacturing capacity, if at all it exists, our clinical research organizations, our final product manufacturers like CIPLA, our bioequivalence labs, our QC reference labs, our supply chain and logistics capabilities. And then where there's gaps, we identify areas of investment. I dare say we don't need a bioequivalence lab in each of the 7 or 8 countries. We don't need, CROs in all of them. We can start with what we have, or we can target to invest where it's an easier win, and then the whole region benefits. And I think we can have some quick wins from this framework of thinking, because every country we know has some protective, tariffs to protect their local manufacturers. We can benchmark and copy and implement. We don't have to start from scratch. So for example, I know that in Uganda, for the products that have been identified to be sufficiently produced locally, there's a bit of a tariff barrier for those people who want to import. But can we change our definition of local to regional, so that we're thinking about the capacity to manufacture for all the 8 countries? And I know that each country also has preferential procurement in the local tendering, from the central medical stores, and the local manufacturers have their preferential pricing. But to progress, I think we have to extend this preferential pricing to the regional manufacturers. So it's a mind shift. It's a mind shift from local to regional. Let the new meaning of local be regional. Otherwise, we're never going to be a regional bloc that can contend with the rest of the world. Yeah.
Absolutely. Thanks, Daniela. I wonder if we have any questions from the floor for our three speakers. Yeah, maybe we can take one or two. Yes, there's a hand there. Yes.
Thank you, Joseph, as National Laboratory. Very here from East African rivals at the performance of SIPLA, but also to inform the audience the previous submission that Uganda took the position of East Africa as law effective March this year. So the taxation process we had requested to Uganda, I think Kenya took lead in making noise in the East African Federation. I mean, under the East African. Where the other East African member states take the same step in considering the pharmaceutical manufacturing within East Africa as local. When it comes to procurement, there is need for prioritization of every member state. We started a journey, I think around 2017, to transform, to introduce a 25% CET for East Africa. But that has not seen light of the day. And that requires a concerted effort of governments within East Africa and the private sector to push this drive if we are to grow the regional bloc, to have the 25% CET come to realization for the 8 products originally that we had put across, including now the gloves. I think that should be included to have probably 9 or 12 products. Thank you.
Thank you very much. I think one of the takeouts from this session is that the security of supply of electricity is also an issue, at least in this hotel. Any more questions? We'll take one. There's a hand at the back. And then we will adjourn for lunch.
Mine will be quick one. In terms of African Medicine Agency that has just been set up in Uganda, I was expecting somebody to be able to kind of discussing what that means for East Africa. And we have the FTA, they're talking about manufacturing on a continental level, but we still see that they're talking about East Africa being all localized. But it looks like we've let somebody who's discussing manufacturing of medicine on a larger scale, on a continental scale, out of this conversation. So what does that mean? We're still talking about East Africa, yes. These discussions are on a continental level.
Yeah, well, these are, yes, the African Medicine Agency, which will be located in Kigali, will be online and up and running, we're told by our Rwandan colleagues, within the next year, and hopefully before then. But it's a continent-wide organization, not just focused on East Africa. There is, of course, an ongoing and has been in existence for several years, an East African harmonization program. But the African harmonization program, which is going to be run out of Kigali, is continent-wide. Thank you. Well, join me in thanking all of our three panelists. I think it was an interesting discussion with several points of action for the future. Thank you, and bon appetit.
Thank you very much, and we can go down for lunch, and we will reconvene at 3:30.
we have state-of-the-art equipment like ultrasounds, which can do 3D, 4D, all the soft tissues, the transvaginal, transrectal scans, and then we have 1.5 Tesla MRI, 128 slice CT scan, mammogram, fluoroscopy, mobile X-ray, all these sorts of high state-of-the-art equipment.
One of the most critical tests that we do is electrocardiography. This is what we often call ECG or an EKG testing, a test which will be able to record the electrical activity of someone's heart. The second component is what we call echocardiography, and this is often, shortened as echo. In summary, that is an ultrasound scan of the heart. So basically, like we know all ultrasound scans, there is no radiation that's involved, so we can do this test even on pregnant mothers, on babies. It's very safe. It's a basic scan, just like you do other scans, but this time we are scanning the heart. The third component is treadmill testing. This is to look at the function of someone's heart when they are exercising. It can be used to assess different problems of the heart, but one of the most common indications is assessing for patency of the blood vessels. The other component is what we call Holter monitoring. It is again an ECG recording, but it's going to be for a prolonged period of time. And we can say it's going to record the heartbeat for 24 hours, 48 hours, or even longer.
Cardiology, specifically in cath lab, we do the CT coronary angios, which normally checks the blood flow.
Consistent support is needed for the expertise that has been put in that area to ensure the implementation processes are completed. With the launch of the Kasero Hospital Cath Lab, care was brought home closer to the people, meaning people don't have to move looking for the services. And nursing department plays a significant role in this role to ensure patients are safe and quality is maintained. We have a team of dedicated and committed nurses, doctors. We work as a multidisciplinary. We work quite a lot with the radiology department, whereby the initial diagnosis is made and then intervention is done in the cath lab.
So we can do a 3D image of the coronary angio, then we can specify which part of the artery is blocked, or it has stenosis, or it has a problem in it. If the slice is a high-end CT, that's why we can detect, because the arteries are very small, we detect the stenosis, the blockage. That's how we integrate with cath lab.
With this, the doctors are committed 24 hours. We are on day, night, over the weekend, or during the public holidays. We look forward to better opportunities, both locally and internationally.
When a patient comes in to the hospital, you realize that we don't know what brings the patient to the hospital. It can be an emergency, or it can be usual illnesses, which are not necessarily emergencies. So at the accident and emergency department, they are screened, and those who are true emergencies are separated from those who are outpatient. So the emergency patients, usually they tend to be too sick that they may end up being critically ill. So their journey begins in accident and emergency, and we end up sometimes resuscitating them quite well, and they don't have to go to the critical care units. However, a number of them, even after resuscitation, they remain critically ill, that they need a lot more days to stabilize. These kind of patients, they qualify to go to the critical care units. And the critical care units are two. There is intensive care unit and there's a high dependency unit. So those who are having moderate illness, they will go to the high dependency units, while those who are critically ill, very sick, they require a lot of support, they go to the intensive care unit. accident emergencies is a station area. It is basically a unit where all patients who come in, they've been injured or they have very severe illness, be it infection, be it trauma, we handle them there to stabilize them within the shortest period of time possible. If they get better, we send them to the ward. Those who don't get better, they still have illnesses that require a lot of support. And the support means most of their organs are dysfunctional. We transport them to critical care units. In the critical care units, that is HDU and ICU, we give these patients different levels of support. So in critical care, we will do anything. We either do it within the unit or we outsource services where they come in and do them within the unit, or we can move the patient as the critical care team to wherever we need the service from. And these services will include a number of procedures. We do lots of procedures, like we ventilate patients, we put them on dialysis, we give them drugs, multiple drugs that require multiple gadgets to infuse these drugs. We give psychosocial support to the patient, to the family, and to the staff as well, depending on the needs of the given patient. Internationally, when we are defining critical care units, we talk about ventilated beds and non-ventilated beds. Nakasero has a total of 8 critical care beds, and these beds can serve as ICU or HDU. So these beds, we have 6 ventilated beds and 2 non-ventilated beds. And with this capacity, I mean, we are able to look after a total of 6 critical ill patients at a single go and 2 HDU patients. Critical care is, I think, one of the most expensive service one can experience during their illness. We advise people to invest in insurance. Nakasero also has a form of insurance, but this insurance is basically your own money. There's a Nakasero health card. You can acquire one, keep depositing money on it in preparation for when you get sick. The beauty about it, if you don't get sick, you can always get back your money. When it comes to critical care, we are well trained, we are well experienced, and we are well equipped. Nakasero Hospital is one of the few hospitals in this country where you have specialized physicians in critical care available 24/7. Any clients who comes to Nakasero Hospital is likely to get state-of-the-art critical care service within the shortest period of time. And therefore, we improve your chances of survival just by giving you our professional, advanced critical care service.
The maternity services provided at Nakasero Hospital include antenatal care, labor and delivery, as well as postnatal care services. The care is provided by a group of obstetricians and gynecologists, as well as midwives, pediatricians, and other support staff necessary to make your delivery process a pleasurable experience.
The importance of the antenatal clinic is one, if a mother, for example, has an issue, it can be captured early, any potential concern early enough, and any risk can be mitigated in good time. During the visits, there are quite a number of investigations which are done on this mother. For example, we need to know the blood group of the mother. We need to know the hemoglobin level, that is the HB. We need to run tests like malaria test. We need to run hepatitis test. We need to do a syphilis test. And these are very important in preparation for the mother and the newborn baby.
Expectant mothers, we encourage them to come for antenatal first before they come to labor suit, because there are so many things that happen in antenatal, and the antenatal care means taking care of those mothers, educating them on what will happen during their time or their pregnancy and even labor plus delivery and even after delivery. So we expect mothers to come for antenatal classes before they come for delivery.
During the antenatal classes are very, very important, and in other words, these are birthing or parenting classes. The mother is prepared with the partner on the arrival of the newborn babies. Different topics are given at different trimesters, depending on the gestation. For example, in the first trimester, we take mothers through how to handle minor disorders of pregnancy. Mothers who are having morning sickness, headache, they are taken through that. We take them through breastfeeding classes. We take them through labor and delivery, so that by the time the mother is getting ready for delivery, they understand what is going to happen, what they are going to go through. And in the event the mother is told that you are not able to deliver normally, you need to be taken for a cesarean section, they really understand what is happening.
For you to achieve the maximum benefit from your antenatal care, you need to start attending the antenatal clinics as soon as you realize you're pregnant.
Labor suit is where we offer the labor and delivery or the intrapartum period. This is whereby the mother will be in labor, the mother will be supported until delivery happens. After delivery, the mother now gets in immediately, the placenta is delivered, the mother starts what we call the postnatal period. Postnatal period starts from the time the placenta is delivered until 6 weeks of delivery. The baby is immunized with the first BCG to protect the baby against tuberculosis. The baby also gets polio vaccination, which is a drop, and the mother also gets a vitamin A to support the mother's immunity.
Following your labor and delivery, you'll be guided through several aspects of how to take care of yourself and also take care of the baby by the midwife, your obstetrician and gynecologist, as well as the pediatrician. There are postnatal classes that are available on request and on Thursdays as well as Saturdays. You are encouraged to attend them, as they might give you more information on how to safely take care of your baby and yourself following the delivery.
Remember, during pregnancy, we all plan for delivery, normal delivery, we all plan for normal baby and everything. In case anything happens beyond that, we get most of our clients get a bit constrained. And that's where Nakasero Hospital has come up with the Nakasero Health Card. The health card is very important. It supports in the event you've not prepared for anything. Any patient anyone can put little money on that card. And when they come and they need to pay extra fee, we don't want to stress them during their puerperium. We want them to enjoy their puerperium, we want them to enjoy breastfeeding, we want them to enjoy their motherhood. During pregnancy, we all plan for the best, we all plan for everything normal, but it's important also to look at the health card. It supports and it makes your life very, very comfortable.
happy as an institution to introduce our loyalty card, the Nakasero Health Card. This card is aimed at improving the experience of our clients while accessing our services.
What is the health card? It's a savings card. It's a personalized card. It's a smart card that enables you to protect your money once you've deposited on the card. It means that whenever you come to the hospital, you do not need to carry cash. You already deposited your cash on this card. Whatever money you deposit on this card, you'll use every cent of it.
As the lab, we do evidence-based medicine. So we're charged with testing and finding out what could be the problem with your body. So having the health card enables you to do quite a number of tests, and actually do more tests which are discounted since you're earning points. So you're able to do tests. If you can do malaria, you can do CBC, you can do typhoid, and then in the wake of COVID, you can also do the COVID testing.
As pharmacy, we have a service that's of drug deliveries. Normally, it targets people who have valid prescriptions. So in the comfort of your homes, call us on our special delivery line. We shall search you up in our system, see the medication you're on. Then we shall pack it for you, use our delivery bike, it will come your way. So this service can be used, yes, with patients who have the health card. It can also be used by other insurance patients and also cash patients.
With my kind of job, I take care of long-stay patients, and with a long-stay patient, they always have challenges with finances. And so with the Nakasero Healthcare Card, once you have saved money on your account, you don't have to worry when you have your next visit because of finances.
With the introduction of the health card, I'm seeing services becoming more convenient for patients, more accessible. That in one way or the other will also help to improve our turnaround times, where patients come in and are channeled as fast as possible, which in the long run will lead to excellent client experience for our clients.
Medical finances can really be strenuous. When one has a health card, the family is safeguarded, whereby whenever a family member or anybody in the family is not well, the person in charge is very, very well catered for, because this member can get the services regardless of the cost.
The card will be available for individual and also for family. For instance, the family, the card allows you to put people in the next of kin or any authorized persons to access medical benefits. There are no age restrictions, there are no service restrictions.
We know that when you have planned for normal deliveries, sometimes some things come in which you are not planned for. So once those things come in, the health card will always help you to overcome such. Even when the baby is delivered and the baby is not well, and the baby is taken to nursery, remember you have not planned for that. The health card will always help you in that way to cover also the baby's bills. You not be on tension.
If a parent has a child with chronic illness, it becomes expensive. But if I have a card, I don't have to get worried. So if I have this health card, all vaccines will be catered. Children, they fall sick so frequently. If I have this health card, I just carry my baby to the hospital in case of emergencies, and the baby gets treatment.
Radiology is diverse. It has multiple modalities where we have CT, MRI, ultrasound, X-ray and mammography. Being that it requires a lot of money, it would be so important that a patient who has a health card in our environment is able to access these services without fear.
With accidents and emergencies, no one knows when it will happen. They are just so sudden. They never give you time to prepare or plan, even look for money. Having a Nakasero Hospital health card will ease your access to our emergency services in such difficult times.
The health card scheme will supplement the current staff medical scheme by providing cover for areas that the scheme has not currently covered, like dental and optical, as well as major procedures.
This health card scheme helps patients to cater for these unplanned eventualities. They're not anxious about the bills of the hospital because that has already been catered for by this scheme.
We've put in place strong checks and balances to make sure the cards are not abused. So you can rest assured that the funds that you've deposited will always be available until you are being served by the hospital.
Come, let's discover how you can plan for your healthcare for tomorrow and beyond.
With the recent technological advancements, healthcare is more accessible, convenient, and affordable. This means that one can be able to access healthcare services easily from the comfort of their homes. There are easy and convenient ways of accessing professional medical advice from Nakasero Hospital. We offer consultations at home where you can have a healthcare professional visit you. Also via phone, where you can call in and consult on any medical related issues, or via a secure one-on-one video call with a healthcare professional. We also offer a wide range of telehealth services such as home doctor visits, prescriptions, sample collection and testing, and drug delivery services. All our telehealth services offer you the same level of privacy and quality healthcare as our in-person consultations. For more information on how you can access these services, call us on 0706 346 222. For emergencies, please contact us on our emergency helpline on 039 322 4681. Nakasero Hospital. Quality healthcare with compassion.
The health of a nation is the foundation on which the wealth of a nation is built. This is the roadmap to universal health coverage in Uganda. The Uganda Ministry of Health, with support from USAID, IFC World Bank, and the World Health Organization, spearheaded the development of a universal health coverage roadmap to move Uganda towards UHC by 2030. UHC is defined as all persons having equitable access to comprehensive, quality health and related services without financial constraints, and all delivered through a multi-sectoral approach. The roadmap is a critical path to UHC. It outlines the strategic actions needed to achieve universal health coverage. It indicates the sequencing required for the main interventions, and it lists the milestones that need to be achieved in this journey. Equity in UHC means giving all residents of Uganda equal access to healthcare. Sector participation includes all ministries, departments, and agencies of government, together with households, communities, civil society, the private sector, including private industry working at both district and the national level. Essentially, everyone has an important role to play. 6 strategic actions have been identified to support the rapid realization of UHC in Uganda. Strategic action number 1 is to expand community-level health promotion and prevention programs. Strategic action number 2 is to develop and operationalize intersector government programs to reduce the prevalence of disease. Strategic action number 3 is to improve the quality and availability of essential and specialized healthcare services. Strategic action number 4 is to improve health system governance, infrastructure, medicines, supplies and vaccines, health workforce absorption, health information capture, and the use of research and technology. Strategic action number 5 is to develop the right mix of budget financing sources to increase public expenditures on health. Strategic action number 6 is to strengthen the decentralized delivery of health services in districts and communities. Working together, we can achieve universal health coverage by 2030. Developed with support from USAID through the African Collaborative for Health Financing Solutions, implemented through the Uganda Healthcare Federation. of a nation is the foundation on which the wealth of a nation is built. This is the roadmap to universal health coverage in Uganda. The Uganda Ministry of Health, with support from USAID, IFC World Bank, and the World Health Organization, spearheaded the development of a universal health coverage roadmap to move Uganda towards UHC by 2030. UHC is defined as all persons having equitable access to comprehensive, quality health and related services without financial constraints, and all delivered through a multi-sectoral approach. The roadmap is a critical path to UHC. It outlines the strategic actions needed to achieve universal health coverage. It indicates the sequencing required for the main interventions, and it lists the milestones that need to be achieved in this journey. Equity in UHC means giving all residents of Uganda equal access to healthcare. Sector participation includes all ministries, departments and agencies of government, together with households, communities, civil society, the private sector, including private industry working at both district and the national level. Essentially, everyone has an important role to play. 6 strategic actions have been identified to support the rapid realization of UHC in Uganda. Strategic action number 1 is to expand community-level health promotion and prevention programs. Strategic action number 2 is to develop and operationalize inter-sector government programs to reduce the prevalence of disease. Strategic action number 3 is to improve the quality and availability of essential and specialized healthcare services. Strategic action number 4 is to improve health system governance, infrastructure, medicines, supplies and vaccines, health workforce absorption, health information capture, and the use of research and technology. Strategic action number 5 is to develop the right mix of budget financing source to increase public expenditures on health. Strategic action number 6 is to strengthen the decentralized delivery of health services in districts and communities. Working together, we can achieve universal health coverage by 2030. Developed with support from USAID through the African Collaborative for Health Financing Solutions, implemented through the Uganda Healthcare Federation.
Okay, good afternoon, everyone. We have two more very interesting sessions. One is the role of partnerships and multi-sectoral approach in strengthening health financing to achieve universal health coverage, sponsored by Roche. This is actually just about the role that the private sector, not the private health sector, but that the private sector can play in terms of moving forward the health agenda of a country. We have Simon Kahiru from Coca-Cola will be here sometime. He's there, good man. And then we've got Emma Mugisha, the executive director from Stanbic Bank, our biggest bank in Uganda. Coca-Cola is a beverage company, by the way, if anybody doesn't know that. Yeah. And then we've got R4D Department of Health, Agnes Gatome Munua. But I think what provoked this session, why we wanted to have it, was because during the COVID epidemic, the private sector was very, very engaged, and Simon Kahiru was all over the place. You'd have thought he was a doctor. and Stanbic Bank. These large organization corporations were very willing to help. And in fact, I was on the COVID fundraising committee for Uganda, and we raised, I don't even remember how much we raised, 20 billion shillings or something like that. It was a significant amount of money. Because and that was as well as gifts in kind, that was actually cash. Because normal citizens, the private sector, corporations, really wanted to help in this health emergency. So it really showed such a willingness sometimes, and I wonder how we can tap into that. When I contacted Anne, the managing director of Stanbic Bank, she was very willing to participate because they're quite engaged in that. So I want to invite Professor Camargo to come and facilitate this session. I think it would be quite interesting, Professor.
I'm on my own. Could we have the panelists come up, please? Thank you very much. I'm going to facilitate an interesting session on the role of partnership and multisectoral approach in strengthening health financing to achieve universal health coverage. So the bottom line here is UHC. The bottom line here is financing. The bottom line is partnership. And the bottom line is multi-sectoral. So I have a mixed group here that consists of the Stanbic Bank, with Emma here, with Coca-Cola, and Simon is here, with Research for Development, and Agnes is here, and with Farm Access Foundation, where we have Nicole. We want to, in the next half an hour, give you a sense of what is capable when we go multi-sectoral and what is achievable if we focus on UHC. So let me start by asking and giving them 3 minutes each one of them, to give you a sense of their background, where they're coming from as an organization, and what role they see that they could play in making help available to everybody, irrespective of socioeconomic condition. And I will start with the bank. I will start with the bank.
Okay. Obviously not very technological. Good afternoon, ladies and gentlemen. We hope that money will keep you awake after a long morning. I'm work for Stanbic Bank, and we see ourselves as a responsible citizen, and therefore healthcare is a big part of our corporate responsibility, and we really support anything that we can in the health space. But beyond CSR, and this year our theme, last year obviously was COVID, this year our theme has been maternal health, and we have been supporting the hospital in Kawempe, but we're also supporting all the Center 3s and 4s in near our branches. So each branch adopts a health unit that we support. But beyond CSR, we also finance the health industry. We have several of my customers here. We used to fear hospitals because you cannot sell a hospital. It's a public good. But we found innovative ways to finance the healthcare, looking at assets, for example, equipment that you may be looking to procure. We work with the large suppliers or manufacturers to ensure that we have the right level of financing for this equipment. Beyond that, we also work with health workers. We have a special client CVP for health workers. This came out of COVID again to say they've worked through very tough situations and how can we support them, lower interest rates, better transactional kind of accounts. And this is more on our personal market side. We've also financed several initiatives that are cross-sectional or partnerships. And we do rely a lot because, again, government seems to be the biggest player in this sector. We do rely again on government support to the people that to the organizations that we support. So, for example, in the earlier session, Brian talked about having government contracts as a way to be able to get financing from the bank, because we need to be sure that there'll be offtake for your product. So that is one of the ways we are able to finance beyond the usual collateral that we look for, just to make sure that we have that collateral. A more recent innovation has been that we have an innovation center, or rather an incubator, and we do training. So we discovered, or we found out, that doctors that have businesses are not necessarily good businessmen or businesswomen for that matter. So we also have a health sector program that we take health workers and health business people through to make sure that their business side of their establishment works, that they have a sound business plan, they have to the T know how many patients I need to treat at what price level to be able to break even. Because sometimes we are good at treating people, but not necessarily knowing the numbers that will make you break even as a business. So our business incubator did one particular cohort for health owners of health facilities, and that's something we'd like to continue doing as well. I don't know if that kind of covers what we do.
Excellent. The only thing is that tomorrow morning, the headline in the Monitor will be Stanbic fears hospitals.
No, that will be a wrong one.
Okay.
That will be a wrong
Fine.
one.
Let's go to Coca-Cola. And Simon, you have a product called Coca-Cola in a bottle or a can, and it seems to reach every village. Cold one. We have a product called vaccine, and we can't even get it outside the outskirts of Kampala. Tell us what we must do differently.
Thank you, Prof, and good afternoon, everybody. I'll actually end on that point of, call it last mile access. Coca-Cola, I don't think I need to introduce Coca-Cola to anybody in the room. Do I? Anybody who needs to understand what that drink is about? But
just explain to Ian. Ian doesn't know Coca-Cola is Irish, so he knows Guinness.
Yeah, and Guinness and Coke, and I've told certain people it works. Yeah, but I'll talk about the company instead. I work with Coca-Cola Beverages Africa, which is Africa's #1 bottler of Coca-Cola products. Coca-Cola, of course, is the iconic brand and the classic drink that most of us grew up loving and still do. But we bottle a lot more than just Coke. Besides the CSDs, carbonated soft drinks, we also bottle a lot of fruit juices, water, and in Uganda, we branched out into milk, drinking yogurt, and even cereal-based drinks like Bushera. And there's more coming. And that's very important, especially for the composition of the people in the room here, because it's all about increasing healthy options for a demographic that's more and more health conscious. But enough about the company. What Prof here would like me to talk about is why is this corporate body in a room with all these health professionals and some business people, according to Emma, talking about health and partnerships. And there are 3 C's that came to mind when I was invited. One was Coca-Cola, we've ticked that box. The second one is communities. And for us, that's a key component of what we do. Communities, our existence in the communities where we operate. Of course, Coke exists in every country in the world, but our presence in the communities has got to be felt by the people in the communities. So we do our business the right way so that we benefit the communities. And number one benefit is by us ensuring we pay our taxes in full and our taxes right. And in any environment where Prof asks that question, how come Coke gets to that last point and vaccines and other medicines don't? We'd all turn to anybody here from the Ministry of Health, anyone? Yeah, we'd all turn to them. Why? Because when taxes are paid, they are paid specifically for the social good. And whenever we talk about social services, we talk about health, education, and then roads, So our number one objective is always ensure you are the right corporate citizen, paying your taxes in full to enable the governments where we operate to serve the communities. Now, that said, and later on, if we have time, we'll break down the nature of taxation and all that. That said, we always go a step further. And that's why Emma used the term corporate social responsibility, because the corporate world realized long ago, paying taxes and going to bed is just not enough. It's not good enough, not just in Africa, Latin America, and the countries that we can always speak of in these terms, but wherever we exist. And that's why we always aim to do a lot more. And the last 2.5 years gave us all the opportunity to see that at work. During the COVID-19 pandemic, I'm sure you all remember the jokes that run around about jerry cans coming from Coke and how everybody found that to be fun. But many companies brought in a lot more to get together to save the people in the communities. And many of us called it corporate social responsibility, but many others simply did not. We just got up and did what needed to be done. And we did it in the first stage of COVID-19. And when vaccination came up, we went on doing it. And in fact, I remember when Ian called me, Dr. Clark, about ramping up vaccination, we did that with the Rotary Foundation to very great effect. But we then worked on the 3rd C, which is convening power. For us as Coke, and by the way, I'll tell you something you may not know, the number 2 most recognizable word in the world is Coca-Cola. Does anybody know what number 1 is? It's okay. Number 1 is okay, number 2 is Coca-Cola. In any language you can think of. Now, we are the most recognized brand in the world. That logo, the Coke logo, wherever you go, even young children will say Coca-Cola. But that is not for us to push the brand and product. What we've done is turn that into convening power. And that 3rd C is very important because we brought it to bear, especially in this sector, but also in others. Like for instance, when you talk about plastic recycling, we brought it to bear by bringing more people on board to get certain things done better, done right. And Stanbic is one of our very key partners when it comes to plastic recycling. For instance, you'll ask yourself, what's a bank doing recycling plastic? But they have the same ethos. They're the biggest bank branch in Uganda, so they pick up the biggest causes and run with them. So we do the same and bring that convening power to bear. But we bring that convening power together with the resources that we've got on ground, the real resources. And today I'd like to introduce you to a project called Project Last Mile. Project Last Mile answers Prof's question here very squarely. It's an initiative that has been funded by the Coca-Cola Company for many years now. I believe it's 8 years running. And Project Last Mile seeks to answer that question actively. If we can get a Coca-Cola into the farthest corner of any country in the world, why not vaccines? Why not posters providing information for people to be safe in the event of a pandemic? Why not syringes? Our Coca-Cola will get to the last corner of Uganda. I was in Karenga last year in March. Karenga is up here above Kabong. And I did not find a single warm Coca-Cola. Cold all the time. We have coolers over there. How do we run those coolers? We have solar coolers. Those solar coolers are managed by Ugandan cooler technicians. Why do we have Ugandan cooler technicians ready to work for Coke, but they are not available to work for the Ministry of Health? Why do our trucks never break down? How come we know at any one point in time where every single truck and carton of soda is, day or night, and government of Uganda cannot do that for life-saving medicines? So what Project Last Mile does is come in and work with the ministries of health in every country in the world to provide the solutions that we use in our business for you, free of charge. Yes, free of charge. Don't clap until Ministry of Health has signed a contract. Because all I'm saying is that it exists, it's there. Ministry of Health is here. But the conversation needs to close. And I'll end here, Prof, because I know you gave me only 3 minutes, by saying, at the very beginning of this COVID-19 pandemic, when we stood up and offered hand wash jerry cans, that became a big story because the president is a funny guy. Please tell him I said that. But we also offered to carry posters, to print actually with graphic systems, and that's a partnership, and carry posters all around the country for people in every corner of Uganda to understand how to avoid contracting COVID-19. I am still very ashamed that that was never taken up. However much I chased my friends, colleagues, and relatives at the Ministry of Health. So I had to come here and have this conversation today because I felt it was important for us to face reality and sign along the dotted line when we need to. Because, guys, I'll never send somebody a Coke in Yumbe to save their lives, no. But I have relatives who keep on getting snuffed out because of small things like, and I really mean it when I say small things, like lack of oxygen. And Grace Chiwanuka, Executive Director, Uganda Health Federation, where are you? She will tell you how many sleepless nights we had in conversations with Ministry of Health professionals trying to get oxygen into this country, oxygen tanks into this country. And the challenge is here with all of us.
Thank you.
Thank you.
Guys, you've heard it. Coca-Cola is willing to deliver vaccines for us free of charge. But nobody wants to take it up. Stanbic has training program for business people, but health people have never gone. Free of charge. So talk of opportunity, talk of low-hanging fruit, I don't know. Later on, of course, I will challenge Simon on the NCD area, where diabetes is a problem for us. Drinking Coca-Cola has its, but we'll discuss that. So let's go on to R&D, Emma, and give us a sense from research, from results, from development. What do you see as the gaps in financing of UIC and the ideas that can innovatively help us?
Yeah, thank you. And I'm very pleased to be on this panel. That everyone can hear. Okay, my name is Agnes Munywa, and I'm an Associate Director at Results for Development. And at Results for Development, we're very passionate about bringing everyone together to co-create solutions that address challenges related to health, nutrition, and education. And when I was invited here, I was asked to just give a broad overview of universal health coverage and what that means for health financing. And so I thought I'd share just a few numbers just to get the conversation going. I'll start by saying that when we talk about UHC, universal health coverage, it's making sure that we have access to quality health services with financial protection, meaning that no one suffers financial consequences because of needing to access care. And what that means is that as much as we have a lot of commitment from governance, we have the Africa Health Strategy, many Ministry of Health strategies on the continent talk about achieving UHC, the business of UHC is actually very big and maybe too big to go it alone. It doesn't need just the public sector, they actually need support from the private sector. And why do I say this? Achieving UHC requires adequate resourcing. And we talk about increasing public resources, but we know what the facts are if we look at the continent or other low middle income countries. I know that if you look at spending for health and you look at what governments are putting into health, and you look at it in terms of share of GDP, it remains quite low on this continent at less than 5%. And you might argue that other areas benefit a lot more than health does. And yet there is a real need to increase spending for health, because if you look at how people pay for healthcare, we find that more than 44% of costs in low-income countries come from out-of-pocket spending. And we know what that does. Everyone here has probably had to contribute for someone's medical expenses somewhere. And that, you know, healthcare is one of the reasons that we had for defaulting debt. One of the many reasons I think another speaker spoke about, you know, earlier, for people not being able to achieve their family goals, society goals, and this vicious cycle of high spending for health that takes people into poverty. And so facing this need that we can't continue to rely on out-of-pocket spending for health, and we know that we need to increase public spending, but fiscal space is low, meaning that the opportunity, the ability of governments to increase spending for health is actually quite limited. Those are actually where the opportunities for the private sector come in. And we know that COVID actually made it a lot more precarious. So we might say that we didn't bear as much of a burden as we thought we would, but it exposed such big deficits within the government service delivery systems, supply chain systems. And we also saw how the private sector stepped up. And you've just heard it here, how private sector was able to mobilize resources, whether financial or in kind, to plug those gaps. And so I'll say that, you know, the opportunities for private sector are not just in terms of service delivery, because that's what we hear a lot about. We need to contract them, they have this infrastructure, but we're hearing it in training of health workers, we're hearing it in terms of supply chain and learning from where Coca-Cola is able to get soda, cold soda, where we cannot get vaccines or amoxicillin or other basic essential commodities. And we're seeing it even in the innovation of how the private sector is able to develop new technologies in managing new disease conditions, conditions that, you know, we're beginning to see as our disease profile changes on the continent. Whereas before we used to talk about communicable disease a lot, we know that the burden of disease is also shifting. And so we're beginning to see more and more non-communicable diseases beginning to rise and beginning to be a bigger burden. And, you know, I might be speaking to the choir here, but 3 in 4 deaths globally are because of non-communicable disease. I actually didn't know that until I looked it up. And in 2017, they postulated that 37% of deaths in Africa were due to NCDs. And so we're seeing a shifting disease profile. And so where can we leverage on the private sector on new innovative ways of managing these conditions, leveraging on primary healthcare, for example, in order to prevent rather than wait for later on when it's needed to be treated, or having better health outcomes in how we manage disease conditions. And I think there's a lot of innovation from the private sector in treatment that could be borrowed by the public sector. And then finally, to be able to use our resources better, to be able to understand the value that comes from health systems, we need data. And only through data do we know what we're doing right and what we're not doing right. And so this research or learning agenda to be able to understand, what's a disease profile in a certain area? What are we supposed to be thinking of in terms of shifting for different levels of the health system, primary healthcare, curative healthcare, in terms of commodities that are needed, making sure that we're getting supplies where they're needed, and being able to build on, beyond the DHIS that we use for information systems, and having systems that actually allow us to have those evidence-based decisions so that we use our resources better, because they are limited and they're not growing as fast as we hope them to be. And so, if you think about it in the tech space, it's mostly private sector that continues to innovate. So many opportunities for such innovation to come to bear and support the health sector. And so, just some reflections for the group.
Thank you very much, Agnes. So the three speakers have already put several offers on the table: training and business, delivery of vaccines, analysis to get the data out there to show that it's working. I hope that East African Healthcare Federation is already drafting an agreement so that by the end of this session, we can sign with these people so that it works. Let's go over to Nicole. Nicole, UHC has 3 planks: access, quality, and removal of the impoverishing effects of ill health. How does Farm Access Foundation approach UHC, and what can you offer East Africans in that context?
Thank you very much, Kama. I think a lot, but I actually wanted to start by saying I actually had a Coca-Cola for lunch, which I guess is not very good for my NCD outlook. But I want to start with something else positive to say about it, because it's not just the last mile delivery. I think Coca-Cola is doing very well. There's another thing that I realized as I was drinking my Coca-Cola, that you manage to keep it tasting exactly the same no matter where you are in the world. It always tastes the same. And as I was listening to Emma about the challenges of Stanbic to invest in healthcare facilities, we have to realize that it's probably easier for a bank to invest in a Coca-Cola factory because you can actually taste it and immediately know if it's good or not. Everyone will recognize a Coca-Cola that is good or not. But when it comes to healthcare and UHC, and you go to a healthcare facility, how would you know if that is good treatment? Because you don't know if the medication is right. You don't know if it's real. And then if it is real, you don't know if the diagnosis you got was right and if the prescription and the treatment protocol is right. And in fact, if there's one challenge that we're still facing, is that healthcare delivery is very diversified and is difficult to measure. And let's be realistic. Sometimes doctors can be magicians and they do fabulous and amazing things, but it's difficult to predict. And that makes it very difficult to invest in that model. So one of the things we've done as Farm Access is, first of all, help create a trust. How do we create trust between the private sector that may not understand healthcare delivery, such as the bank, and a healthcare delivery system that is quite complex, and you need to have gone to school, medical school, to understand what it is. So one of the things we've done as Farm Access is we developed a system called SafeCare. Now, SafeCare measures and rates healthcare facility delivery. And what we've seen a lot in quality programs that are rolled out throughout the African continent is that most of the time they have a pass or fail system. So governments or NGOs or other partners will go to the healthcare facilities, measure against a set of standards, and you either complied or you didn't. But the reality is that many of the facilities will not reach the standards that are needed to offer that good quality care, but are still on a journey of getting there. And that's why they need investments. That's why it's so important that the banks come in, that they don't just invest in the healthcare facilities that are good, but they're also offering financial solutions for the healthcare facilities that need investments to go on the journey. So the SafeCare methodology that we offered, rather than a pass or fail system, offers a scale from 1 to 5. We don't like to say bad to good. We like to say high risk to low risk healthcare facilities that are managing their medical, but also their business protocols very well, recognizing how they are in that system. Now, you'll probably hear me say from a level to 1 to 5. That's not by coincidence. Banks will understand rating because that's already what works. So what we've been creating is a common language that allows banks and medical professionals to interact with each other quite well without having to know all the details. Very similar to, I'm a medical professional, I don't understand how bank rating works, but intuitively, I know that probably putting my money in a AAA status bank is much better than a lower rating stance. So intuitively, it tells you to do a right thing. It creates trust with you. And as a result, you're able to transact and do business between service delivery that may not naturally understand each other. So I think that's an important role that FemAccess likes to play in creating these systems that increases trust and as a result increases transactions and business and service delivery between the different partners. I think a second example of this, and we already throughout this conference, we talked a lot about the use of technology. And as we think about hospitals, we can have public and private hospitals. We have a lot of private hospital representatives in the room today, but we also have the government represented. But when it comes to technology solutions, we can all agree that these will probably, if not very likely already, always take place by the private sector. It will be private tech companies coming in and offering these solutions that are definitely the future of healthcare when it comes to telemedicine, when it comes to remote care, when it comes to the sort of data support that we've been talking about and the learning platforms. And I think that's a solution where as FarmAccess, we bring in blended financing to start these type of initiatives, but also to see how do we bring them in. So in public-private partnerships, they can contribute to universal healthcare coverage, creating better access and better solutions, but again, also a trusted partnership with the government so that they are not afraid in these contracting to monopolize the services that they are offering. So that's in a nutshell our role. We really aim to create trust between all partners, transparency and accountability, and start the health system to work.
Thank you very much, Nicole. Emma, the backbone to private health sector service delivery in health is a small provider. Banks talk a lot about SMEs, but when we in the health sector hear about SMEs, we don't think that you recognize us there. How does lending to this sector rank in your Stanbic portfolio? Would you miss us if we weren't there? Are we important? Two, my colleagues from South Sudan, right now with their challenges to provide healthcare, their interest rates, I think, are 30%, going 40%. How do we deliver services to people affordably, universally, when interest rates are 40%?
When a professor wants to fail you on an exam. I'll start with the SMEs, and my unit in the bank looks after SMEs. What we've done is so there's two types of lending. There's lending for capital investments, which is more of term lending, and there's lending for working capital, which is more short term. What we've done with the working capital bit is to move away from asking for security for short-term lending, because we realize that over time with data that we have and models that we have, we can actually assess an SME's capability to pay from their bankings. So what we're doing is encouraging SMEs to bank their whatever proceeds. So if you're a clinic, on a daily basis, all your proceeds before you pay out, because what happens is, as a small business, you collect your cash, then you pay out suppliers. By the time you get to anything to bank, there's nothing to bank. So the bank doesn't have a visibility of your business because you're not banking. So two things. One, digitize your collections so that we can see them. We have a product we call FlexiPay. We create you as a merchant, and people can pay electronically to you. So we have a visibility of your transactions. And on the basis of that data, both your banking and your transactions as a merchant, we can score you, and back to scoring, we can score you and afford you a working capital loan that does not need a lot of sign here, what is your mother's maiden name, and all those things that banks are accused of doing. So what we've realized with SMEs is that we can, from the data that we collect, be able to lend you without necessarily looking for security and asking too many questions. So what would then encourage our customers is to be transparent with your transactions. They should be visible to the bank, either by being a merchant and we can see your transactions, or banking your cash on a daily basis, so that we can kind of create a profile for you as an SME. When it comes to term or to money that you need for longer term investments, you need to build, you need to expand, you need to buy an asset or a machine, then we'll get into proper assessment on whether you have the capability to pay, and therefore what collateral you give to us. So that's how we are tackling SMEs, and we don't have a demarcation to say SMEs except health. It's all SMEs. That's one part. Secondly, on interest rates, for the last like 5 years, Uganda interest rates have been quite low and stable. At Stanbic, we have the lowest. We pride ourselves to have the lowest rates. However, at the moment, our rate is 18% because rates have gone up. So rates going up is not a bank decision; it's a government decision. So until our governments are able to borrow much lower, rates will always be high. So the question is always, can you afford that financing? And is bank financing the only financing? What we found out during COVID, again, is that there's a lot of partnerships we can do. There's a lot of development organizations that have money, but over time, they have not, the data shows that the impact of their money is not very strong. So we've partnered with a number of development organizations where we, by getting their money, lending it out at a much cheaper rate, and being able to use that money over time, as opposed for it to being a grant, a one-time grant. So again, just like Coca-Cola is using its distribution, we've got a distribution network. We have 70 branches across the country. If you're a development organization interested in a certain group of SMEs, we're happy to work with you to say, how do we use our distribution network to deliver that funding and to make it sustainable and revolving over 5 years, as opposed to a one-time grant that probably pays school fees instead of building your business.
So for Uganda Healthcare Federation, Grace Sally, the MOU to be signed with Stanbic and Coca-Cola, I think would be ready. As I ask Simon this question, Simon, where do you see a role for Coca-Cola on the non-communicable disease area? And I'm asking this specifically because when it comes to the area of cancer, the global community has moved the tobacco companies to put a sign on every packet that this thing is dangerous to your health. Would you think that, given the possible link between the sweet drinks and diabetes. And you can see my sister, even at lunchtime, can't keep away from Coca-Cola. Would that kind of signage be useful in our environment before people drink your very popular stuff?
Thanks, Prof. And you can hear the excitement here in the audience around this. Make sure you're recording for social media. Let's not restrict the options. And I'll say that again, let's not restrict the options to a specific solution, considering that you said possible link. And let's also look at what's been done so far, because this is a journey. And as a company, we like I said, communities, we take leadership, we take responsibility ahead of what you call headwinds. We've been having these conversations for very many years. And it's because of those conversations that I, for instance, who does not have any problem with any of the non-communicable diseases that you will speak of, I only drink zeros. Coke Zero, Stony Zero, Sprite Zero. Okay? I didn't have one at lunchtime. I drink mine at night for reasons that I won't discuss with doctors. But I also, many years ago, and this is a story that I'm happy to tell you guys, in 2016, I underwent a wellness program that saw me dropping 30 kilos. 30 kilos. I was 126 kilos, and I came down to 90 something. Today I'm 90. I'll be 89 by December. But, and I will. Thank you. Thank you. The first step that I took, which was inadvertent, I've written this story before, was I stopped consuming sugar. No, sugar. I took raw sugar, brown sugar, out of my personal diet. But I drink, and this the doctors might complain about, I drink upwards of 1.5 liters of coffee a day. So think about how much sugar I used to consume in my coffee back then. By just dropping sugar for that time, I think it was 4 months, with all that coffee, I made a change to my weight, my metabolism, and so on and so forth. So there's merit in looking at everything in one circle. If she said she drank 6 bottles of Coke at lunchtime, thank God we have medical professionals here, because there'd be a quick response in case of anything. But if she said she had 1 Coke, and I don't know what your exercise was this morning, just before I came here, I did 7 kilometers on my hill, then there's a difference. Now, as a company, one of the things that we've done, introduce zeros, zero sugar options. Why? Because there are people out there who need a certain taste, but may not require the possible result you've spoken about. Besides that, like I mentioned earlier, we've provided those non-sugary drinks that are not even carbonated, and we continue to promote those. We've also moved into what you'd call non-nutritive sweetener-based drinks, or lower, let's say less sugary drinks, because you present more and more options for people to decrease that possibility that we've spoken about. And even when it comes to signage, unfortunately for most of you guys, you don't have any bottles on the table that you would look at, but I urge you to look at those bottles, because step 1 in communication is begin providing information that people will understand. And when you look at especially our PET bottles, you will see the information there that guides a consumer as to what they're taking and what they should be careful about, mindful of. Now, here, because you're medical professionals and the internet is what it is, I'm not going to go into all the other sources that people have for some of these issues. especially on this continent where we all know how much disposable income goes to what. But the conversation has got to be a much wider one than just with one brand or one company or even one segment of society. And I say this also because the reason we pay heavy excise duties, and I mentioned that I would talk about taxation. The reason we pay heavy excise duties is for the government to extract certain revenues that should be put to use to forestall and fix. Forestall and fix. That money is supposed to be invested in certain things that will stop possibilities of XYZ happening, which includes financing. And I think you mentioned the primary healthcare interventions, right? From the get-go. And there's a lot more that I can go into, but this being a very exciting topic, I'll leave it to the floor. Thank you.
Thank you very much for a comprehensive answer. I think that the key thing here is broadening the conversation. And this is where the Federation can broaden the conversation. We are not pinpointing the product Coca-Cola. We are talking about sugar. So we can broaden that and see how it goes. I have some questions, but before that, I wanted to see if anybody in the audience has any question, because we will not take more than 3. 1, 2, and 3. Please give them the mic. Your name, quick comment or question, and we move on.
Thank you, Professor. My name is Robert Waswa, working with Country and Mad Purpose Initiative in the capacity of program coordinator. The implementation of an activity necessitates the mobilization of resources. If you fall short of resources, then implementation becomes a difficult thing altogether. To the best of my understanding, health financing is a core function of health systems that can enable progress towards universal health coverage in a way of improving effective service coverage and financial protection. I'm working with an organization that implements activities in rural communities. Communities that are so vulnerable, where people face the worst of conditions, where people live in perpetual vulnerability and are swimming in the hemorrhage of poverty. A person sleeping in a ramshackled house, the head sleeps in the house and the legs sleep outside, cannot even afford to meet costs of health. We are with Coca-Cola, Stanbic, and other institutions in terms of corporate social responsibility by such institutions, so carefully designed and implemented financing policies can enable to address these issues. What do they also say about working with them so that institutions can benefit from this corporation responsibility to support people of this kind? Thank you.
Thank you very much. Agnes, later on, I'll want you to contribute to that. What does research say about the role of corporate social responsibilities in sustainable financing of health? Next question.
Yes, thank you. My name is Nancy from Management Sciences for Health. And my question goes to Coca-Cola, or my appeal for that matter. So we have a group of social entrepreneurs who take commodity down to the community. And also there are other organizations who are working, supporting the Ministry of Health to make sure that the supply chain for pharmaceuticals and diagnostics reach up to the community level. I'm just wondering whether you can also explore partnering with these entrepreneurs to make sure that products get to the ground. Thank you.
Especially since the ministries are not using that offer, you will get the answer soon. Yes. The third one? Yes.
Thank you very much. My name is Edward Kalyasubula from Access Dental Care. And my question is to Agnes. access to information or to data is one of the challenges that we still have in this country. And it's a big hindrance to planning and analyzing the data of disease, of population metrics, and the like. What innovations does R4D have for the health sector that can be, as people are talking about last mile, the small facility out there that may not be able to have a practice management software accessible to it? What kind of innovations can be accessed by such facilities to be able to put their data together and be able to present information that can be accessed by people like Stanbic to be able to assess them for financial eligibility and many other things, including planning and management.
Thank you very much. And as you answer that question, Agnes, I'll ask Nicole to give us an idea of the innovative ways in which we can fund small providers. Is there an option there for small providers? Dr. Gakombe, I thought your last question. Okay.
I'm not sure about Uganda, but in Kenya, we are paid by insurance companies and corporates by EFT, as opposed to checks that used to be given before. But we still are unable to get funding against those cash flows that are guaranteed to come through a bank account by a banker. So my question to Stanbic and to bankers in the house and to the NHIFs of the world, why can't we be funded against sure cash flows that we cannot divert to other banks? And they are coming from well-regarded organizations in terms of their financial capabilities.
A very good question to Stanbic. Doctors and nurses and laboratory people, respected and ethical citizens of our countries, doing good business. They are owed money, and you know the money is coming through your bank, but you'll not advance them anything. Is it because you don't like us? So let's get the answer, starting with the question that went to Simon. Are you able to work with non-governmental organizations that want to get the goods out there and use your excellent logistics?
Nancy, the quick answer is yes. But like I said, through the Ministry of Health, if it's Project Last Mile. And the reason for that is really one of governance, and to ensure that the coverage is what the communities most need. As you can imagine, it's very easy to find a Coca-Cola person. We're everywhere. We receive hundreds of thousands of requests every single day. So we need to create clear governance that ensures, an equitable level of distribution. And that's why Project Last Mile will work through the Ministry of Health. So we need together to go to the Ministry of Health and say, guys, let's take up this opportunity, because there's a need somewhere that will be covered that will relieve resources to go and deal with another part of Uganda. Besides that, I'd urge you to visit the Coca-Cola Foundation website. And my email address is with the team over here, so I could guide you to them as well. The Coca-Cola Foundation is a global foundation. It's not Uganda-based. And it receives applications from all manner of organizations that are filtered through, and many of them will get very good responses, of course, depending on the themes, the issue that's being handled. I can tell you, Uganda has performed pretty well in delivering on projects, community-based projects. So you'd have a very good likelihood of getting a response, getting consideration. And that goes for everybody and everybody in here, except if it's something of a commercial nature.
Thank you very much. That's a very good answer. Maybe UHF could also make sure that you are a critical part of this last mile program, so that if there's any bureaucratic delays from the ministry, you can help make this happen quickly and promptly. Nicole?
Thank you. Great question about the last mile healthcare providers. I guess we all know where they are. The small, the Dukaladawas, the small healthcare facilities that are right there in the community that struggle to issue the collateral or the ownership papers that are needed to get the loan through the banks, that understandably still need some administrative processes to issue the loans on. So one of the things we've done as PharmAccess Medical Credit Funds is a few years ago, we developed actually a digital lending product called Cash Advance. Now, how Cash Advance works is that we partner with healthcare facilities that accept mobile money payments, M-Pesa or other mobile money payments that are there, and that most patients, in fact, will use very frequently to pay for their healthcare services. The system recognizes Cash Advance, taps into the system and looks at what your financial transactions are on the digital payment platform. And based on that, you can lend a certain amount of money. So obviously, if your transactions are higher, then the amount of money that you can lend is higher. And this is actually a solution that is available through your mobile phone. So you don't need to go to the bank, you don't need to issue all these papers. Through the mobile phone, you register and you can access that loan through the mobile phone. Now, in that same agreement, there is also an automatic deduction of the loan again from your future payments. So one of the worries is once you have a loan and you're busy, you forget about repayment every month, you need to worry about. These things automatically deducts, but maybe if you have a month where you are issuing some challenges because there's less patients than you expected, you can adjust the amount of money that you pay back. So it's really tailored to the needs. We introduced this lending product in the Kenyan market a few years ago, and it's been so successful that I'm sorry to say for Stanbic, it's overtaking a lot of the bank lending products, especially in the lower end of the market. So the higher end is still, let's say, the higher lending products that is still banks are very important, but we can go as low as, let's say, $100 US, $200 US, which is especially in the aim of working capital. So small healthcare providers going to the city, buying some basic medication, buying some basic supplies, commodities is a very useful way of getting some working capital in that they need while they are paying off. And then the second comment I'd like to make, and please go and seek out our East Africa director from the Medical Credit Fund, Kennedy. I'm not sure if he's somewhere and he can stand up, and he might be preparing for the next session where he's in. Go seek him out, because we also have financing solutions for this issue that you're raising about being owned, waiting for future payments from insurance companies, and we're ready to finance against that. So solutions are available, and let's work together on this. Thanks.
Thank you very much, Nicole. Over to Emma.
Okay. We do fund, in Uganda, we do fund medical practitioners. So I'm not sure whether there's a potentially a Kenyan issue, but happy to have a chat with you and introduce you to my colleague, and I'll also check with them if there's a specific criteria around medical practitioners. But in Uganda, we have been funding them, and from the smaller dukas, most of them are part of SACCOs. We recently got some very good funding for SACCOs, so that we don't have to get into the assessment of the SACCO members. We just lend to the SACCO, and the SACCO then lends to the last mile, if I can call it that. So again, partnerships have been very good. We're able to lend to farmer SACCOs at 10%, non-farmer SACCOs, trader SACCOs at 12.5%, which is even better than our lending to your MTNs and the big corporates. So the partnerships have worked very well in terms of mitigating risk for us, but also delivering better pricing from an interest rate perspective.
an important point there, because all over East Africa, we find that farmers who work at the community level, just like our community health workers and nurses, have been able to structure less expensive lending, but not on the health sector. So there's something we are missing here, because just like they produce food, we also produce good health. And I think there's a gap there that we need to fill to find out why that's there. Agnes, maybe in your comments, you'll address that.
Okay. Well, maybe I'll start with a comment I wanted to make that was made earlier about, about sugar and soda. And it's not just about Coca-Cola. If you think about it, it's also fat. So if you think of the KFCs proliferating everywhere, if you think of alcohol, tobacco, there are many products in which affect the health sector adversely and impact health outcomes. And the question is, are we doing enough to tackle some of those consumption of some of those goods? And that is why really we have excise taxes, right? As you rightly said, to be able to counter those negative externalities, that negative effect or consequences that might happen in society. And I just wanted to bring up an example from the Philippines, where they introduced a sugar tax, which was addressing dental caries and obesity in children. And so, just in terms of thinking of how we can raise resources for health, because that goes directly to the Department of Health in the Philippines to be able to address childhood obesity and dental health issues. So just interesting ways, things that we can learn from others. But I did get some questions. And I think the question you raised on how to reach the most vulnerable populations is one that we're struggling with. And I think when policymakers try and look at this, they're thinking, where is the best place for these individuals to be able to access care in those remote areas? And that's why you'll see, as in many East African countries, this focus on primary healthcare, because these primary healthcare centers, probably the first point of formal access to care, might also be the closest place, so reducing the transport costs to traveling to these centers. And if we equip them, staff them properly, then they can be able to manage most of the conditions. And if you think of it from an NCD perspective, a lot of the prevention measures that can happen also at the primary healthcare level. So I think really that's where focus should be. And then, because not everything can be managed there, making sure that we have clear linkages of referral to higher level care for those that require them. So I think they are complex. And I think they're always trade-offs. What do you cover? What do you not cover? Who do you cover? Who do you not cover? And I think it's very painful, but it's making sure that at least for the most broad range of issues that are being experienced by the population, that those are included as a priority. I also got a question on data systems for better evidence-based decision-making and what innovations we're seeing. And I think Nicole spoke to some of those, in farm access. And I'd say that East Africa, and where I come from, Kenya, is really a hub for innovation in the tech space. And we're seeing that as much as DHIS2 is the backbone for our data collection systems, that we have seen a huge number of apps, both mobile, web-based apps that are being used up to the community level. And the question is, and I think a challenge the Ministry of Health was having is, how interoperable are these systems? Do they talk to each other? So starting with the backbone infrastructure and defining what the requirements that everyone should meet as a minimum, so that everyone can be able to plug in and have these systems begin to talk to each other. And as much as we talk about innovation, tech, mobile, I think we need to also realize that even our paper-based systems, we need to start from there, because that's what we have most. And then from paper moving to mobile, and then from mobile, more web-based solutions. So adapting to the context and trying as much as possible to build a culture, not just of data collection, because data collection is boring and tiring. I have done a lot of it. but how are we using that data? How does that plug back to the facility manager? If they knew why they should collect the data, see, for example, because of how I am able to deliver certain services, for example, vaccination in my area, because of our high vaccination rates, we're actually seeing lower incidence of childhood pneumonia as an example. Then it begins to create a link to why I should collect data, because it informs our learning and how we deliver services and improve the health outcomes overall. Thanks.
Thank you very much. Ladies and gentlemen, in the last 30 minutes, we've been able to demonstrate clearly that UHC is not possible without partnership. And that partnership is not so difficult. And there are people outside the sector and in the sector who are willing to work with us. If we just picked on one or two of these, yesterday and tomorrow, a child who would have died will survive just because we are taking the offer from Coca-Cola. If we just picked one of these, a woman will be alive because the clinic she is going to is being managed better because of the offer from Stanbic Bank to do the training in business management. A guy would survive tomorrow if the clinic or the provider looked at the loans, small online digital phone loans that Nicole is talking about. Data, as Agnes says, it's possible if we are willing to use that data. So I see lots of low-hanging fruit that we can take individually or corporately. And it's my wish that at the end of today, East African Healthcare Federation, UHF, strengthens the partnerships that are sitting here already. Please join me in giving a big clap to this brilliant group. Thank you very much.
I always knew there was a difference between African time and Mzungu time. Because for Kama, he was only here for 30 minutes, but on my watch, he was here for an hour. But really, that was a very interesting panels. Thanks so much. And thank you too for the audience for really being with us. And we're coming to the last panel. Before that panel, just want to remind people of the 4:30 matchmaking session downstairs on the ground floor for people who are looking for innovative finance and for their businesses. There is technical advice and there is investors. So make your way down there if you are looking for a financial solution for your business. And then also we also have a dinner this evening. To really wind things up, and we'll have the Minister of State for Foreign Affairs, Ori Makello, will join us for that dinner. So that brings us to our final, not our final session. We have our closing, but this session is domestic resource mobilization through the private sector, and this is sponsored by Farm Access. Could we get Millicent from Farm Access, please? Who is the coordinator of this session, and we need Dr. Kezra, please, if you come up, and Edward Misati, please, and Johnson and Dinda, and Kennedy, please. And I'll leave it to Millicent to make the proper introductions. Thank you so much.
Not Kenya.
Not Kenya.
Good evening. Ladies and gentlemen, I just want to request us to stand up. Somebody once told me sitting is the next smoking. Just stand up and stretch. And I'm just requesting that you bear with us. The session will be good. It's a very important session. My name is Millicent Tolulo. As I introduce myself, please stretch and make sure you're really energetic. You're able to avoid the non-communicable diseases that we're talking about. Yes, thank you very much. Once you have stretched, you can actually sit down. I'm the Regional Director for Advocacy and Partnership at Farm Access. The topic on domestic resource mobilization through private sector is quite interesting because traditionally, resource mobilization was more of a government assignment, was left to governments as a primary stakeholder to be able to raise these funds. But one of the things that we can see that given that there are uncertainties in terms of funding, there's also a push towards countries to be self-sufficient. There's also an increase in terms of demand for healthcare, which is very important, that we are seeing even the emergence of diseases, a lot of needs really coming. It is inevitable that the private sector also has to contribute in terms of healthcare investment. I also stand here speaking as a consumer of healthcare. And I want us to make this session very interesting because all of us are consumers of healthcare. So we'll really throw back quite a lot of questions to you also as our audience. So welcome to my panelists. I have able panelists and I would like to introduce them one by one. With us, we have Johnson Adinda. Johnson works as a program manager for the USAID Connect Girls Center activity implemented by health partners. He provides strategic direction and support to care providers implementing cooperative health insurance. Johnson? Thank you very much. We have Dr. Kizra Said from the government. Dr. Kizra is an accomplished health system specialist within the public health sector, currently working in Kisumu County in Kenya, with over 8 years experience in health system strengthening, public healthcare management, health insurance, and health financing. Dr. Kizra, wherever the audience, thank you. We have Edward Misati from Rubik Health Africa, and he's in corporate financing with experience in leading both buying and selling acquisitions. And I actually know that recently you're able to purchase one of the facilities in Nakuru in Kenya, which is very good. And I believe from the audience here, there are quite some potentials. So wave to the group. With us, we also have Kennedy Okongo. Kennedy is the East African Director for Medical Credit Fund. This is really revolutionary and has been very catalytic in terms of healthcare financing and funding. And Kennedy is actually a seasoned banker, not only a banker, but recently I just learned that Kennedy is an author. Kennedy? Please clap for the team because we are going to really engage with us. So one of the things is that we saw that Health in Africa initiative, which was launched in 2009 by World Bank and was funded by the Gates Foundation. One of its key main objectives was to ensure that the private sector can mobilize up to USD 1 billion in terms of investment, in terms of creating efficiencies and even social impact within the health sector. And the big question as I've introduced my panelists is to find out what is their role in terms of doing this. So to begin with, Johnson, what has been your role as a private sector partner in terms of raising this capital and contributing?
Thank you, Millicent. Good evening, everyone in the room. I would like to add on the introductions that she has given about myself, but I also want to talk about the organization where I work and what we do, and then how the capital bit comes in. Thank you. My name is Johnson. I work as a program manager at the USAID Connect Girls Center activity, funded from Washington. And we try to create opportunities for vulnerable girls aged 10 to 24 and boys in the communities by accessing or meeting their healthcare needs through the cooperative health insurance model that is our signature project in the whole country. How does the health cooperative model work? It is another form of community health insurance financing, but it works based on the concept of shared risk because these are health cooperatives that operate like any other cooperatives whose values are solidarity, self-help, equality, really working for the community, concern for the community. So people think cooperatives are there for farmers, they are there for maybe fishermen, they are there for coffee producers or dairy cooperatives, but they can also be done in the health sector. And Health Partners has been doing this work in Uganda since 1997. And the work was mainly being done in the southwest part of this country. But since 2019, we scaled up in the whole country, and we are working from the south tip up to the northern tip. And we have supported 9 health cooperatives so far under the project since over the years. And in those cooperatives, more than 100,000 people have benefited through paying low premiums. And this model works between private healthcare facilities and the communities that are already organized. So you find that the private sector has a lot to benefit from here because they are running facilities, but under challenges, one of them being the debt burden. I don't know those who are running facilities here, whether you have debtors books where people come, you treat them, they go without paying, and then maybe you start arresting them because we have seen those instances where care providers arrest people because they have not paid. And so the health cooperative model was introduced by Health Partners, one, to overcome the challenge of the debt burden, but also low access because people fall sick and because they can't fund their services, they stay home or do self-medicate, and that creates a whole range of problems. And so Health Partners brought up this model so that those challenges can be overcome. But you cannot overcome them as an individual or in a family. All you need is to work together. We have many sayings that say when you're together, strength is unity. There are so many in our local areas where we come from. And so in a cooperative, people basically come together to overcome a challenge at hand. And we have people doing all this sort of work together in other areas. I heard in Kenya, they have the last expense account where people really have to contribute some money for sending off somebody. And it happens here in Uganda. We contribute for weddings, we contribute for burials, we contribute for meat and rice on Christmas in the communities out there, but health was being neglected. And so we come in with this innovative solution. As Health Partners, we do not put in premiums.
Thank you.
We do not put in treatment cost, but the capital that the people contribute in low premiums is the one that helps them to access. How much are these premiums? We see facilities which are charging as low as 5,000 Uganda shillings. When you put in Kenyan money, maybe it's around 300, 370. We see in the Northeast and Central, they are charging 10,000 Uganda shillings per member per quarter. And once this pooled account, once these resources are many, they are pulled into one account, so many people will be able to access the services. And so this is a business opportunity for private healthcare providers, because in the government, services are said to be free. I don't know how far that works, but this helps those people who are in the private sector to make sure that they can work with the clients they already have without having to pull ropes. Thank you.
Thank you very much. And maybe just a reminder to the panelists, please make it precise and don't reintroduce yourself. Thank you very much. Let's go to Edward, please.
Okay, thank you. Just a quick introduction about Rubik Health Africa. First of all, it stems from the Rubik's Cube. I don't know by a show of hands how many of you have solved the Rubik's Cube.
Have seen? They're
Oh, let's start with seen.
They have seen.
Well, I think as our logo shows there, it's shaped in the form of Rubik's Cube. Maybe they can show the next slide. So that, the cube. So how many have seen that?
We have seen, we have solved.
And have solved? All right, great. So the reason why we named it after the Rubik's Cube is because we figured out early on that healthcare indeed is a Rubik's Cube. In this room today, we have people in pharma, service delivery, which means hospitals, with people who operate labs and so on and so forth, distributors and whatnot. So when we looked at healthcare, we figured what areas can we focus on? Which colors can we focus on to align so that we can focus on those areas and create efficiencies in the facilities we operate to extend those efficiencies to affordable care. And just maybe he just shows the last slide.
And which color did you identify?
Well, green, red, and a bit of gray. So just in a nutshell, what you see on the slide there is our value creation philosophy. And so we focus on three main areas: healthcare management, healthcare infrastructure, and technology. So when you look at healthcare historically, things like infrastructure, for instance, we now stand in a building that's a marvel of architecture and construction. That's not the case with hospitals. A lot of the times, founders are grappling with, funding their businesses to just provide good care. And so they neglect certain aspects of investment. And so that's the reason why we created this firm, to partner with investors, and we invest alongside those investors ourselves to sort of make sure these three parts are actually performing very well to deliver care. So I'll just stop there.
Thank you. Thank you very much. Dr. Kisra, over to you.
Thank you, ladies and gentlemen, and good afternoon once again. Or I think we are switching to evening. I think myself and Dr. Thomas may be the only government employees in this room. And we took a beating from Mr. Kahure from Cork. But I think there's something we need to be very real with ourselves, and also very livid, that government cannot do everything. We have only a specific capacity to a certain limit. Beyond that, that's where PPPs come in. And I think since we began yesterday, that has been the spirit of this conference and the discussion around it, that as much as government does up to so far, and that's where private organizations come in, that's where partnerships start to grow. So I think the biggest role that government plays in resource mobilization is actually, for me, I would say HRH, that's Human Resource for Health, and infrastructure. By the time an organization is coming in to put in resources or to put in any form of support for county governments, please excuse me, I'm speaking county governments because of how the Kenya's structure is devolved. You come in when you find half the building already done. Your infrastructure is set, you have human resource in place, you have your quantifiable capital in place. So what the private sector plows in is actually, it's more or less the icing on the cake. So I think the government puts in quite a bit, and the private sector just comes in and fills the gaps and the nooks and crannies where we feel we need some strengthening.
Thank you very much. Maybe just a question to you from yesterday's session. there was a comment that the government is really, most of the funding or resources for the government goes into paying the human resource for health, as you have actually confirmed now, and infrastructure. So I'm just keen to know how exactly, as the government, how are you attracting investors in the private sector and ensuring that we are there on the table and adding the resources and working together?
Thank you. I know we said we're not introducing ourselves again, but allow me to say this. I come from the great county of Kisumu, and Professor Kama is my village mate from Kenya. Kisumu County has been known to be a trailblazer. And if you're keen on the news and social media, Kisumu County has been the first of many, especially when it comes to innovations and tech savvy. We have a very tech savvy governor, His Excellency Professor Nyong'o. And every time he goes for conferences and he goes for these platforms where he's on a world stage, he comes back with friends, we call them friends of the county. And before we know it, most of them are usually geared towards health. So I think that's number one for Kisumu County. We enjoy a very big support from the governor himself. And he puts a lot of weight on innovations, on technology and digitization. I think that's one. We have a very warm environment for investment. And then I think Kisumu County recently, after the review of the PPP Act, where counties were allowed to engage with the private sector, Kisumu County last year in December issued an expression of interest for partners to come and join us, strengthen our health systems. And I think we got an overwhelming response. If you gave me more time, I would tell you how else we've engaged, but I think that is one of our strengths. We opened up our doors to the private sector. And then I think another one that comes very quickly to mind is our health budget. Kisumu County allocates, currently it's allocated 33% of its budget to the Department of Health. I think that's a big thing for most county governments. Yes, thank you. That has gone up. Initially, we started at about 26% and we've risen almost every financial year. We're currently at 33%. For those who are conversant with the health system in Kenya, we have what we call a facility improvement fund. Kisumu was one of the pilot counties for UHC in Kenya, so it took away the liberty of facilities to charge patients. But after the pilot phase, Kisumu County has been leading once again in enabling the FIF Act. It was recently passed, and we've also printed our regulations. So our facilities are now able to charge and use that money to better themselves. So again, like I said, sometimes investment is not just brick and mortar. There's a lot of what I call software that goes into establishing health systems. So I think for Kisumu, a lot of that is already there. It's just now to have that bridge between county government, in particular Kisumu, and the private sector, and have that link between the two.
Thank you. Thank you very much. Clap for her and clap for the other panelists as well. Just good to mention, Kennedy, seeing Stanbic Bank here, for me is a ripple effect of the work that Medical Credit Fund has done over years within the East African community. I know the first lending that Medical Credit Fund did took quite a long while, and there was no trust in the system. What's your story in regarding to the journey of the Medical Credit Fund?
Thank you, Millicent, and good evening, everyone. From a Medical Credit Fund perspective, and looking at what we can do to the UHC angle to enable private health players also join in this bandwagon without being left behind. We come in at an angle where we provide access to credit to the health players. That's anybody operating in the field of health, being a healthcare provider, being a pharmaceutical provider, being a medical equipment provider, being nursing school, anything in that ecosystem of health. It's been a difficult journey, having been in operation for the last 10 years, now going into 11 years, coming into this market and trying to convince people that healthcare providers are actually bankable. A perception that has always been picked in this market that doctors are very good people, but when it comes to credit, they are people that you really don't want to associate with. In a period of 10 years, deploying around 150 going to $160 million in debt capital in the health space only. It's a niche specific lending that's not looking at any other space, but just looking at healthcare providers. Leveraging on technology just to ensure that we are able to make this debt capital available to everyone in all the corners of East Africa where they are. We try to really work, what I can call work smart, not compete with everyone. We know banks already exist and are doing this, just trying to prove the point to them. And to the bankers that are in the building today, to the investors that are in the building today, I can actually tell you one thing that I've learned over 5-6 years of just dealing with the doctors. If you do an industry analysis in terms of the repayment, they're the best repairs of debt.
Sorry, thank you very much. I would just like to throw one question and then allow us to be able to ask questions so that it's an interactive session and discussion in the interest of time. When we talk of domestic resource mobilization, it's not only about really putting in money into the system, but it's about efficient use of resources. It's about how do we have more help for the monies available, and about capacity building and all these other elements. I'm just keen to understand from your perspective as panelists in terms of how can we both as private and public sector empower the communities more to play a critical role in accountability of these resources, since they stand to benefit the most. So that is one question. And as I ask that question, I would like to give us an opportunity as the audience to ask questions. I would like to see a raise of hands based on the topic. Yes, please. I've seen your hand. So I've seen 3 questions. The last one will be Dr. Gakombe. We address, then we get back again.
Okay, thank you. My name is Odoro Tieno, and I'm also based in Kisumu. So we are village mates with Dr. Kizra and Professor Kama there. And I run a consultancy firm around health system strengthening. In the morning during the breakfast meeting, I threw around 3 key numbers that we need to be keeping focus on. In the global north, they keep them 60, 30, 10. So for this context, I want to speak to the 30. And the 30 usually refers to the wastages that we see. For example, 60% of healthcare that we have is based on some evidence, 30% is wastage, and 10% is harm. Why am I bringing this? I've listened to Dr. Kizra as much as we are village mates. Unfortunately, now we're having this conversation here. And I would gladly quote Professor Rogo. In May this year, when we were at Strathmore, Professor reminded us that whatever is coming down as investments or as budget allocations in the health sector is already sufficient. We are not basically doing enough in terms of investments. Now, I'm listening to Kisumu County already doing 33% towards the health department. If Kisumu County was a country by the WHO standards towards UHC, which requires just 5% allocation, then it therefore means that Kisumu County would be on its way up there when it comes to UHC. So as we talk of domestic resource mobilization, the resources are there, but what are we doing to seal the leaking taps where wastages comes in and improve efficiencies? Thank you.
Thank you very much. Dr. Kizra will take that. Let's go to the next question. Dr. Gakombe, you had a question. I want to take 3 or 4 questions at least. The people with the microphones, please be swift.
Mine is actually not a question, it's 2 comments. The first one is a word of advice to anyone in this room who may be looking to get investors into your business, please get yourself a good transaction advisor and lawyer. The man sitting up there was my transaction advisor when I got invested 5 years ago. Number two, I'm not advertising him, I'm simply stating a fact. If you don't get one, you are likely to get a bad deal, because remember, the people who do investment, that's what they do for a living. When you are providing healthcare, there is a chance you will undervalue your business unless you get a good transaction advisor. Number two is the question of money. I think we need to admit that we simply don't have enough of it. Kisumu is spending 33% of X amount. Now, 15% of zero is still zero. 15% of a million. It is important that we develop our economy concurrently as we allocate more money in healthcare. If we don't, then if we spend the 15%, it's simply not going to be enough to go through. We have an economy to build, and more money to allocate to healthcare.
Thank you very much. Let's clap. And Edward, just good to ask, are you willing to support the team at the audience in terms of transaction advisory? So you will answer that. Thank you. Yes, please.
Yeah, thank you very much. And thank you very much, the panelists. I work in the public sector. We are guilty of saying one of the biggest lies in healthcare, that healthcare services are free. That's the biggest lie in healthcare that all governments give. Because whatever we do, someone pays for it. What we forget to tell people is that it is the private sector through taxation, right? For what they call free health services. And I've always been thinking, I'm also an academic, but maybe the way we are framing finance, we keep on talking about financing sources. We change the narrative and talk about financing solutions. Maybe we may change the way that we think about.
Let's actually clap for him for being very honest. I always believe there's nothing like free healthcare. Somebody is actually picking the bill. So Kennedy, you'll be able to answer that. Thank you. Let's go back to the panelists for them to address those questions before we take the second round of questions. My brother, you'll take the one on the community. How do we engage them in terms of accountability? Be very precise. Thank you.
Thank you. What we've seen communities do in the work that we support is for them to really base their work on principles and values that govern them in their cooperatives. And because they are regulated by the Ministry of Trade, Industry and Cooperatives, when you want to misuse their money, the law catches up with you. And so I think there should be a good legal framework to protect, let's say, members' premiums if they have paid them in a health cooperative. There should be good leadership because everything begins with good leadership. And we have seen these communities start up small initiatives, especially in the area of financial cooperatives, the SACCOs, people who never really attained a higher education. They start these small initiatives and they grow billions of capital. And so I think because they depend on their ethical values as cooperative members, as community members, it really helps them to grow and support each other and be able to access basic care that they need at the village level where they are. And maybe I should say, it's Professor who has been saying, what about this small clinic out there? What about this small clinic out there? Those people are being supported by the private providers that are there, but definitely sometimes they might not give them they might not meet their big needs, but at least there are some people who are doing some work to support the communities and they are working together. Thank you.
Thank you. Edward?
So the short answer to whether we're willing to offer transaction advisory services is yes. But I'd like to give context to that. So after Dr. Gakombe and I worked together, we noticed it was the one transaction large enough either side of the last almost, I think, 10 years back then, to be done in, hospital acquisitions. And so the idea was to find out why this is happening. Why are there no acquisitions? Why is there no investment, and what's going on? The truth is, to most investors, hospitals are invisible businesses. They don't understand how they operate. They don't understand how they make money. They don't understand what goes into, offering care. And so this meant an education to investors, and also an education to some entrepreneurs around what investors need, and also to the investors how businesses operate, which culminated in us partnering with one of the largest, I'd say, private equity firms in East Africa, Ascent Capital, where we're going to embark on investing in more hospitals as we go along. So I just wanted to give that comment.
Thank you. Thank you very much. I would like Kennedy to go next. Kennedy?
Thank you, Millicent. Just speaking on financing solutions that actually work in health. And at this point, just allow me to brag slightly on what we do and what has managed the Medical Credit Fund to be very successful over a period of time, is that our financing is actually tied to what we call technical assistance. It goes just beyond availing the money to you for you to be able to do what you want to do. It goes over and above that. You are a medic, you are a medical practitioner. There are so many other things that are actually required in your health space, in the space that you're actually operating on. Just like Dr. Gakombe is saying, being tied to the right advisor for the transactions that you're doing. You could look at it, credit, as something very tiny. But if you don't tie it to something else that adds value to your facility, then it's just money that has come in and has gone out, and tomorrow you are left with this lender that actually needs their money, but there was no value that was acquired from it. While Nicole was on stage, she alluded to something called SafeCare. This is a quality accreditation model. All the loans at the Medical Credit Fund are tied to what we call a technical assistance. Part of that technical assistance is SafeCare. So we have to ensure that not only are we giving you money, but we are trying to improve the quality of healthcare that you're providing, irrespective of where you are. Such that if I mention that my hospital is a level 3, probably in the rural area, and somebody else says their hospital is a level 3 in the urban area, the level of service is actually identical. By virtue of that, you avoid this influx of everybody trying to move from the rural area to come seek for facilities in the urban areas. So financing solutions that we offer are very critical. Thank you.
Thank you very much, Kennedy. Could we go to Dr. Kizra?
Thank you to my village mates from Kisumu. And I'm glad you're in the health system strengthening space. So you know the challenges that Kisumu and maybe Kenya as a country have had to endeavor to achieve health system strengthening. Something that we need to understand is UHC is not a destination. UHC is a journey. So simply because we are saying that there's free healthcare today doesn't mean that that's the end of our road. It's a journey, and the systems we are putting in place today may not even benefit us or our children. It might benefit those who will come after us in another 10 or 20 years. So as long as we know that, and we know that we're working towards a goal, I think we're headed somewhere. And to answer you more specifically, you asked, how do we seal the leaking taps? I may shy away from commenting much about what other counties are doing, and I will stick closer to my village in Kisumu, where I think currently our health facilities are being, it's more of a mindset change, where we are empowering facilities to own their facilities and their services. We've had a fairly warm relationship with NHIF, and I don't know if you're aware, but Kisumu has its own solidarity health insurance scheme called Marwa that is supporting vulnerable households. So we are encouraging communities to enroll. The vulnerable households are being paid for currently by the county government of Kisumu fully. So they have one responsibility, and that is to seek services. Now, of course, that may not be sustainable in the long run. So how do we ensure sustainability? Encourage people to pay into the scheme. Now, the more you encourage people to pay, the higher your reimbursements for capitation. So if as a facility, you only have encouraged 2 people to enroll in your facility, then your capitation will be based on the 2 lives that are attached to that facility. But if my facility has encouraged 100 people, then my capitation reimbursements are based on the 100 lives that I've registered. So I deal with my 100, my capitation for the 100 lives, you deal with the 2. It's a way of strengthening health facilities to think for themselves, to empower themselves, and to stop depending on the government in the counties to keep giving. So if as a facility you've collected your fee for service, your capitation, your reimbursement, and you're at 100,000, then that's what you will be allowed to spend by the department. But if as a facility you have only, let me put collected in quotes at 50,000, then that is what you're allowed to spend. That encourages more of an output-based system of reimbursements. Kennedy mentioned something about Safe Care, and in Kisumu, we've partnered with Farm Access Foundation, who are assisting us in doing a verification of quality based on the Safe Care standards. So if you're a Safe Care standard of 1 or 2 stars, of course, your quality is not as good as a 3-star or a 4-star. So your reimbursements also come in terms of how well you're improving in your quality of services. So if you've done a Safe Care assessment and we give you feedback, for example, that your waste disposal is not on point, maybe your HR has a gap, maybe the facility, the staff in your facility are not up to date with the recent training, for example, in the lab or in the pharmacy, the next time we come for a Safe Care assessment, we expect that to have been done. If that has been, it's a ripple effect, it's like a domino. If that has been done, of course, the quality of services will improve. You'll see higher numbers in your facilities. You'll have more people benefiting from capitation. It's a wheel that keeps spinning. It's a snowball effect. So I would not say there are specific answers of how to stop leaking taps. It's not just plugging, what do they plug? Cement in taps and stop the leaking. No, it's a process. And the small stopgap measures that we put in place, one day we'll be able to say, finally, the taps have stopped leaking. But I have no one answer to tell you it's 1, 2, 3.
Thank you. Thank you very much, Dr. Kizra. There's no single bullet, but one thing is that quality introduces efficiencies within the system so that we get more health for the money that is available. So I will go to my next question. Then I give you an opportunity for 2 last questions. Then we close the session. So my next question is to Robic Health. You're working with investors who traditionally expect a profitable return. How do you balance this by creating, how do you balance the profits as well as creating the social impact? How do you ensure this is balanced? So the last 2 questions? Yes, Diana? Then one more, then we close the session.
Thank you very much to the panelists. I think during COVID-19, the world almost literally came to a stop. So, and we're saying that health is a whole of society challenge. So my question is, if health is truly a whole of society issue or challenge, shouldn't we have the whole of society represented in these discussions? Because, for example, one of the industries that was very hard hit was the hospitality and tourism industry. When we talk about mobilizing domestic resources, why are we not looking at all those other players and bringing them together to look at how do we mobilize these resources? That's my question to the panel. Thank you.
Thank you very much. I see another hand at the end. Who will pick that question? Yes, Dr. Kizra will pick that question. Then we have a last question now.
Yeah, thank you so much. My name is Patrick Edet from Uganda Cancer Society. Now, I'm going to give an example of Uganda Cancer Institute. For the past 2 months, the CT scanner machine has been down. Therefore, the patient suffered a blow. What am I talking about? The issues of harmonizing costs that we levy to these services that you give the clients. For example, Uganda Cancer Institute has a waiver for the patients who come from upcountry marginalized communities. You write an ED or executive director, then they waive some costs from you. Now, when you go to Mulago Hospital, they charge a little bit higher than what Cancer Institute charges. And for them, because you're an outside patient, you are not considered for a waiver. Now, when you go to Ruby, when you go to Nakasere, when you go to Case Clinic, prices differ. How are we going to harmonize this issue of prices? Please, people are suffering. Thank you. I work with cancer patients.
Thank you very much. Quite an interesting question in terms of prices differing. I want to know who will take it from the panel. Yes, Kennedy will take that. And let's start with Edward. We have closed the question session. Please.
Okay, thank you very much for that question. I think first and foremost, just by the fact that we are in the healthcare industry and we run hospitals, there's a social impact already. But I want to go forward and say, investors just don't think about making profit for profit's sake. They look at particularly ESG, which is environmental and social governance, which is a very important facet in terms of—
Please make sure the person at the back can hear you. Thank you.
Okay, which is a very important facet of how you run, social public goods in any society. So what do we mean by ESG? In a nutshell, ESG is looking at the environment, looking at the social side of your operations. Are your employees in good working conditions? Is the community at large benefiting from your existence, not just through purchase of services, but also through other means? And the way we've demonstrated this, recently in the month of June, we went on a CSR program and donated drugs to schools and prisons that were nearby, so that we can be able to now benefit those communities and not just exist for profit's sake. The other thing I'd like to mention is when you look at the structure of how private equity funds operate, the idea behind them is to use public funds that are from other countries to benefit other people. And so the challenge here is, are there public funds in East Africa that can do the same? Which is a conversation that we are having as we go along. Lastly, there are many hospitals in Kenya, for instance, that don't see NHIF patients. Now, this is a social insurer in our country. We choose not to go that way. We say we are going to see these patients, and we'd rather, through the federations, have that conversation with NHIF on what are the good rates to be reimbursed, so that we can continue serving the larger communities. Thank you.
Thank you very much. I think that's very clear. Dr. Kizra?
Do I answer the question, or you have something specific?
Answer the question from Diana.
All right. So your question was about involving, let me say, non-health.
Yes, more multi-sectoral collaboration.
So if you look at the current primary healthcare strategy, the national government in Kenya is trying to revitalize it and to bring it back to community-based. Now, a component of that is to have what we call multidisciplinary teams. Again, Kisumu was one of the counties that started the PHC strategy. And out of the 7 sub-counties are like districts. So out of the 7, we have successfully trained and sensitized 4 of the sub-counties. Now, in every sub-county, there's a multidisciplinary team where you have somebody from the Department of Health, which is usually the, if I can call them, the district medical officer of health. And then we have somebody from roads, we have somebody from water, we have somebody from education, we have somebody from the security forces, we have somebody from the administration arm of government. Now, when we sit with them on a round table, for example, you'll find there's a part of Kisumu that gets very heavily flooded during the rains like now, and facilities get cut off. When these non-health departments are present on our table, and we actually take photos, and we have photos of healthcare workers who the facility may be between here and where the window is, but it's completely inaccessible, and you have to take a boat. And when he asks us, I think there's a road here, and we say, but this road has been cut off because it's logging so much water, it actually comes as a surprise to them. The next commitment we get from them is, I'm going to ensure that in this district, the grader clears that road and they make the road slightly better, so that the next time there's a flooding, it may not be tarmac, yes, but the next time there's a flooding, the road will not be affected. That's just an example. Closer to what you asked about COVID, I know there are a lot of non-health partners that came in even at national level. For example, if you remember Java And in Kisumu, we have United Millers who do bread and pastries and bread-like things. They were giving staff in our hospitals lunches. Even Java was doing it. Safaricom had a system where they were called, I can't remember what it was called exactly, but you were able to buy food from supermarkets using Bonga points. Now, it may seem like it's not health related, but the end game is health related. These people lost their jobs, they lost their sources of income, but they were still able to eat. They were still able to provide for their children. So maybe, and I'm sure in this space also, for example, the panel that was here before, there was somebody from Coke. And when I looked at it, honest to say, I was like, I wonder what his contribution would be, but it came out so beautifully. So I think health is opening up to more non-health actors, and we are becoming more cognizant of the fact that we need help from every other department that is non-health.
Thank you. Thank you very much. Last response from Kennedy.
Thank you, Millicent. I'll try digging in a harmonization of cost in the health sector, though it's a field that I'm not very conversant with. I'll just pick it and borrow it from my banking experience. If today I put money in Bank X, they'll pay me for the deposit that I've given to them. But if today I want to take money from the same bank, they'll pay me something different from what they are paying me for holding my money. So there's a fee that my deposits will attract to the bank, and there's a fee that if I was to borrow a loan, I will attract that from the bank. Why don't we turn that again and use the same in the health sector, for example? Look at it on this angle. What is it that we've done into our health sector that can make us demand for this service? In Kenya, if we can borrow from there, the National Health Insurance Scheme is there and it's working. People pay a premium on a monthly basis that you deducted. And then, by virtue of this, hospitals are graded. If I go to Kenyatta Natural Hospital, for example, for a dialysis, NHIF will be in a position to reimburse that hospital X amount of money. If I go to this other hospital, the fee structure is already calculated and put there. This is what the insurance scheme will be able to do, to reimburse the hospital. Same works in private insurance. If, for example, today you bought insurance from Jubilee, depending on your ability and on the package that you buy, if I go to, for example, Mulago Hospital with my AAR insurance, this is what Mulago Hospital will be able to do for X, Y, Z. Meaning I have the right as the patient or as the payer to demand for the service that I'm getting, and I have to know it beforehand. Why don't we turn that around again to the rest of us so that we know we are the ones who are seeking this health service. We are the people, the population that needs to be treated in these hospitals. So at the beginning of the month, by the time I'm getting to this hospital, I need to know these are the structures that are there. Just the same way, in the banking industry, I can decide to go for a bank, I can decide to go for a SACCO, I can decide to go for a CHAMA, because I know at the SACCO level, this is what is available to me. At the CHAMA level, this is what is available to me. And at the bank level, probably this is what they'll charge me. And this is what they'll pay me if I give my money to them. Why don't we turn the same and utilize it in health? It could be tied to quality. I don't know whether there's a standard quality system that applies across board in Uganda, for example, that the private players can come in together and say, let's subscribe to this quality system and then be guided by this level of quality to do our pricing that is open and transparent in the market. Thank you.
Thank you. Thank you very much. And a round of applause for these panelists. This is a very, very interesting discussion. The only thing is we did not have much time. So in summary, one of the things I want to say is that healthcare is a business like any other business. So if you look at it as a business, then the private sector must invest in healthcare. One of the things I like what my colleague from the government has said is that there's nothing like free healthcare. It has some costs, but someone has to pick and bear the cost of the healthcare. Someone has to raise the funds, both from the public and from the private sector. And if managed efficiently, we can get a lot of gains and get more monies for health and more health for the monies available. Thank you very much for being the audience and being the co-moderators. In the interest of time, another round of applause. We've just done a scratch to the topic. Thank you all for being a very good audience. Asanteni sana.
So this brings us really essentially to the final session before dinner. I think really before I get into thanking people and so on, I've just asked Kama if he would come up maybe and, you know, say a few words. The poor guy, I've been working him really hard this conference, so he's tired. But Kama, maybe you could come and just give us a couple of closing remarks. You know, you always have good insights and give us thoughts to take back with us.
Thank you very much, Ian. Ladies and gentlemen, we are at the end of yet another regional conference of the private sector. For those who are there at the beginning, it's just amazing to see this board here full. And I believe that the next meeting, which I think is Dar es Salaam, will have 2 more, because I believe DRC will be here and Somalia should be here. When that happens, we'll be talking about 500 million human beings that will be your market. The US market is only 300 million. So you'll be a bigger market than the US. And you'll actually be a market that covers almost half of African population. I do not know if there will be a bigger opportunity than that for inspired private sector. That market is rapidly moving into social health insurance. That should make it possible for you to have more steady payment and transaction. Just imagine what is happening here and the possibilities that are there. I'm always encouraged when I see the public sector coming in friendly and smiling the way Timothy Musila is doing, because it shows a movement that has taken place in the relationship between the public and the private sector. Yes, we must still point at our weaknesses, but we must work on those weaknesses. When we started this movement, some of our countries were completely socialist. Ethiopia was one of them. And then, of course, there's Tanzania. It's been an amazing journey. That's probably some of the biggest strides that have been made in the private sector have been in those 2 countries. Amazing what Ethiopia has been able to do. Amazing what Tanzania with AfTA has been able to do. In fact, I would say that Kenya, which at that time was ahead, could even have slowed down. Now, with DRC coming on board, we are going to face the challenge of language, which shouldn't worry us, because we thought we would have the same with Rwanda. But Rwanda now speaks better English, and of course, better Swahili than most of us. And DRC Congo is a Swahili-speaking country. So sharpen your Swahili, if nothing else. Now, what does that mean? What this will mean is that we need to open up to the bigger horizon. And that horizon must, as we have emphasized here, look at all the subsectors of health. DRC will need big investment in service delivery, big investment in infrastructure, huge investment in human resource development and retention, and then the pharmaceutical area. Just imagine that. What I would urge the federations to do is to stop being in the domain of your capital cities. It is now time that you decentralized. I'd like to see a situation where if we went to Arusha, we would meet the after branch in Arusha. If we came to Uganda and went to the west, we would meet your branch out there because our countries are also decentralizing. Kenya, every county should have a branch of KHF because you are dealing with counties that are governments on their own. That is where the growth is going to be, and that is where the potential is going to be. But most important is this. Remember the three things that I mentioned at the beginning. Please continue strengthening engagement, both within the sector and within the private sector and between the private sector and public sector. That one is a moving target. It is never done business. 2, look at your policies and regulations. Any new policy that comes up must be more clear on what the private sector is supposed to deliver. The days when the private sector is a footnote are gone. Challenge the laws and make sure that the laws make it possible for you to make a difference to your own people. Thirdly, is the area of investment. I believe that we can make that major leap to have social health insurance across all our countries. But beyond that, I also believe of the very many possibilities on PPPs. We touched on that yesterday, but we have not really believed that these things can work. It's taking too long for transactions to be done. We've got to get our East African ways of getting these things done. And countries that have PPPs of whatever nature going on, we should invite them to come and share the experience with us, because this is new, but this is a big possibility. Mention was made today about the CT scan or imaging that's not working at Kampala Cancer Institute. That wouldn't happen if you went on a lease agreement with the maker of that particular thing. This old system of buying machines that you can't maintain must go. The rest of the world doesn't sell machines anymore. They lease them and you guarantee that they are repaired. And if they're not repaired, they give you a new one. We've got to go out there. And finally, is the issue of digitalization. I hope that by the time we meet in Dar es Salaam, there'll be good news or progress made in this area. I think there's more talk on digitalization than there is action. A lot of facilities, you still go there, you still find people are using papers and the old newspapers on the back of things. This should be the thing of the first. We've seen here, as PharmAccess showed us, that it is actually even possible now to handle small loans through the telephone. You don't have to go to banks for 20,000, 50,000 Kenya shillings. It can be done on your cell phone. This is where we ought to be as we move forward. And finally, let us look at the area of pharmaceutical. 500 million people is a big challenge for any pharmaceutical producer. It's a big market for them. For the ones who are here already, we want you to expand. For the ones that are not in Kenya, we want you in East Africa. We want you to come into East Africa. But let us work with the East African community to realize some of the low-hanging fruits that we discussed yesterday. One of them is that the medicines we produce in East Africa must be the ones that we buy first and foremost by our governments before we buy from everywhere else. Number 2, that if social health insurance is going to take root, then it should be portable, so that your insurance in Kenya, when I come here and fall sick, Ugandan should be able to take care of me because I'm already insurance. And finally, the training. Something was mentioned today about specialist training and bringing these people from India to do short courses and so on. East Africa already has the basics that would allow specialist training to happen under the collegiate system. Under the collegiate system, private institutions can be qualified as training institutions and can offer the necessary degrees or certificates or diplomas that are there. So we already have a framework of training that is recognized across our borders. The university degree MEd programs we had agreed were limiting. The collegiate system is the entry point for private institutions to get into training. We can train nurses in renal nurses, oncology nurses, psychiatric nurses, and so on. It can be done. Similarly, we can train specialists in this area using the facilities that we already have in our countries. Ian, my last comment, because we didn't have enough time to talk about medical tourism. Medical tourism is two words, medical and tourism. So everything that makes a tourist go into a country applies to medical tourism too. So the country must be a country that is welcoming and not threatening. So peace is first and foremost. A country at war will not attract very many tourists. Two, tourists do not just come because they have natural resources. Somalia has beautiful sandy beaches, but people would rather go to Mombasa than go to Mogadishu. Why is that so? This is something that we ought to consider for medical tourism. Medical tourism is based on all the aspects of tourism that are needed, including infrastructure, travel, ease of passport and everything, but on something else, trust. People must trust that in that country, they have good standards and they have good regulation. So that if you go there for your left leg to be removed and they amputate the right one, you can sue and they'll give you back the leg that you amputated. If people do not trust us as professionals, as countries, as ethical people, they will not come here because they have options to go elsewhere. So if we want to compete with the rest of the world, let us clean our act. The first point in cleaning that act is not to ask people from another country to come to your country. It is to serve your own people well. You have enough population to fill the few beds that you have. You don't need Nigerians to come there. Just do it well and do it affordably. So we need to start looking at the cost of care and the businesses that we have. People go to India not because Indian doctors are better than us, but because it is cheaper to buy a ticket and carry your relative with you and go to Bangalore than it is to go to Nairobi on your own and be in hospital in Nairobi. Let us start asking ourselves why we have created hospitals and institutions which we ourselves cannot afford to be admitted in. We cannot afford to be admitted in the hospitals we own and run. That's a fundamental question that must be asked. Because many of you and many of us, as many friends, when we are admitted, we come for Harambee and ask you to contribute before I'm discharged from a hospital. This should not be the case at all. And it is within us to examine the way we cost healthcare and the reasons why healthcare must be where it is. Each one of us right now is afraid of the day that you fall sick in Kampala or in Nairobi, in Addis Ababa, because you cannot afford to be sick, even as a member of this august federation. These are issues that I hope you'll be taking into account. I wish you well as you go back home, but most important, we look forward to meeting in Dar es Salaam with the delegation from DRC. Thank you very, very much.
Thank you, Professor Rogo. Could I ask the board members of EHF to come forward? Nevin, we've got Uganda. The only one that's not here is Tanzania. Tanzania and Burundi are not here. Ethiopia, Uganda, Rwanda, Kenya. Dr. Gakombi. And Walter, thank you. Nevin, yes. So these are, I don't know, is anyone online from Tanzania? Can you, Sam is on. We have the executive secretary from Tanzania. Sam, can you hear us?
Yes, I can hear you very well.
Excellent, thank you. So sorry about the gender balance. Could we maybe get the executive director of Uganda Healthcare Federation and the conference director, Rita, our membership secretary and conference director? Yes, please. See Grace, Rita. Thank you, Rita. Yeah. I want to take this opportunity while we're assembling here just to thank. Yeah, I think you make room for the ladies in the middle so that it looks better. Do you notice how the guys are the board members and the women do the work? That's how it is in Africa. No, this, as I say, is really representation of EHF. I think I will confess that something happened since COVID, and I think this year we had a virtual conference in Rwanda about this time last year, and I can't believe how fast that this year 2022 is gone. And I'm looking at what we have achieved as the EHF. And I'm thinking that we have achieved to running a conference, a good conference. It's been great to see people. I think it's just been very stimulating. But in terms of what I've done as chairman during this term, I really can't point to much else. And I confess my sins of omission because I think we can do better. But during the conference, we have certainly been stimulated. And we have some definite, as Kama would say, low-hanging fruits. But in terms of the legislation for the East Africa community, but including the whole of our East Africa Federation, there is stuff that we can do and we can get involved in. There's already been movement. There's already been things that are being done in the EAC in terms of harmonizing education for medical professionals and movement, some stuff that's been done on pharmaceuticals as well. And I think that EHF has got more work to do on that front. And so that I would like to see that when we meet in Arusha again, that we will be able to report of some of the things that we have achieved as far as EAC is concerned. And the other aspect, of course, is that with the the involvement of the State Department and the willingness of some outside donors to really help to precipitate innovation in the health sector, then we see that the various federations, both country federations and EHF, need to be moving on that initiative as well. And Sam and the Tanzanian Healthcare Federation is well placed to move on that that Jeff Landers has introduced. So I just want to thank actually I want to say one thing at least. During this COVID thing, it has been a learning curve for us all in terms of what we're bad at, what we're good at, what things have worked, what things haven't worked. As a country federation, we certainly have worked in the COVID emergency, And there's been a lot that UHF has done, and I'm sure I can say the same for each federation here, because somehow that galvanized us. And earlier today, we were talking about trying to get oxygen into the country. We certainly were involved with vaccination campaigns, both as providers and also working with voluntary organizations such as Rotary. So I think what I believe is that we can do more. But I'm very glad for the formation of this East Africa Healthcare, the country federations and East Africa Healthcare Federation. It's been a journey now of 11 years, and I've been privileged to be part of that. I was here when we signed our agreement for the formation of the EHF in Kampala. I was here, I think, again in 2016 when we had a conference, and here we are again in 2022. And so I look forward to a future when we as the private sector, in collaboration with government, and we ourselves and initiatives we can take to provide healthcare, that we have seen many things happen, and that we will see more happening. One of the things that I think that I realize is that some of us have started private hospitals, but we're concentrated, understandably, at the top of the pyramid where people can pay. And no one has cracked that nut of how you get to the base of the pyramid with UHC. And yet there are going to be answers to that. The answers will lie in digitalization. They lie in what we've been talking about today, harmonization. They lie in platforms of smartphones. They lie in things like task shifting with medical professionals, harmonizing training, and so on. And we want to be part of all that. We want to see the changes that really are making a difference to healthcare. And that's when I first came and I started my little clinic in Kampala, my motto was making a difference to healthcare in Uganda. And then it changed to making a difference to healthcare in East Africa. But I'm very proud to be part of these federations and this federation, which I believe we are making a difference. So thank you so much to all the board members. And I just want to say now, thank you so much to Rita. Rita, stand out there and take a bow, huh? This is our conference director, who has really worked to put this thing together. This was a more difficult, it's okay, you can go back now. This was a more difficult conference to finance because we didn't have the big World Bank program that was always backstopped us. But thank you so much to all the donors, the sponsors, the exhibitors, the people who've made it possible. It's been from, I mean, no amount of money is a small amount, but there's been from relatively small amounts to quite big amounts that have allowed us to really be fed well here, to be able to fly in speakers, to have the members of the executive fly in and so on. So thank you so much to the sponsors and Grace. We don't know what we'd do without Grace. Grace, you can come on here. Yeah. This is our very able executive director of Uganda Healthcare Federation. Grace is what you would call a busybody. I don't mean that in a bad sense. She is a person who is, as we say here, is ever busy. And she attends so many meetings and has cultivated so many relationships, both in the government side and in the private side and the donor side. And we're very proud of the work that you guys do. There's another team there, but I don't know, can they come in at all? Are they there? Can the rest of the team please come quickly? Because I want to thank the whole UHF team that has, I'll not say it has worked like a well-oiled machine. Sometimes we've got a flat tire here and there, but yeah, we've got there, and we're very happy to be here today. Organizing these conferences, it's a bit like you really have no idea, will 6 people turn up or 10 people or, so but I really feel excited. Or as the Kenyans would say, excited. Is that the right pronunciation? Excited by this conference, and we're not over yet. We're still having networking dinner. So thank you. We see that the team. Thank you to the sound men Thanks to the speakers themselves, and thanks to the people who have been here virtually, and thanks to the hotel, because I think we've had a wonderful service. So thanks to Mestel Hotel. It's a lovely conference center. And then finally, thank you to the audience. You've been amazing. You're still here. That's amazing. Give yourselves a clap. So I think now we can take this plaque, which I don't know what Rwanda Healthcare Federation have been doing with it, but it's a bit the worse for the wear. And I don't know, how do we do this? How do you virtually throw it at this television or something? I can see Sam on my monitor here. You can see him there. As I say, we were here in Uganda 2012, 2016, and again 22. And we're really looking forward to being there with you in Dar es Salaam this time next year, and having actually achieved some low-hanging fruit. Sam, so what do I do? Is there any Tanzanian person here? Jeff, who's Jeff? Yes, Jeff Blanders, you're an honorary Tanzanian. Come on up to the front.
Let my Kenyan colleague take it. I'll take it from them in Nairobi next week.
I'm not going to give it to those Kenyans. I might just keep it. We want to give it to some.
I'll be in Nairobi next
Jeff,
week.
come on down here. Okay, apparently I can trust the Kenyans. So we're not done yet, but we can now feel free to relax, to network. They'll just clear up the room a bit, and we will have some drinks outside. I think the deal room is still going on down below. Any other announcements? Housekeeping? The dinner will probably get going it's now 6:05, around 7, I think.
Can you hear me?
Yes, please, Sam, say something.
Yes, thank you very much, Uganda Healthcare Federation. We have had a great time preparing for this conference. It's very unfortunate that none of us would come in due to reasons that were beyond our control. Yesterday, I was with the minister in the morning. She really wanted to talk to you. She called me in our office. Unfortunately, the open session took long and she had to rush to another meeting in Dodoma. But she really wanted to be there with us. And she told me to tell you this. We look forward to welcoming all of you in Tanzania next year. And our government has been informed, and they're really excited to seeing you. And on behalf of the chairman, who just got to get connected due to doing something out of town, he told me to inform everyone that our preparation for next year's conference is starting now. And therefore, we look forward to a great conference next year in Tanzania. Karibu sana. We'll disclose the city where it will take place in the near future. Welcome very much, and really appreciating the great work done by the Uganda team. And we look forward to doing the same or better. Thank you.
Thank you so much, Sam. Thank you so much. Thank you, team. Enjoy the evening. Just to reiterate, people, the dinner is at 7. Okay, so if you're going out, come back by 7. Otherwise, have some drinks in the foyer. Yeah, there are drinks there.
The maternity services provided at Nakasero Hospital include antenatal care, labor and delivery, as well as postnatal care services. The care is provided by a group of obstetricians and gynecologists, as well as midwives, pediatricians, and other support staff necessary to make your delivery process a pleasurable experience.
The importance of the antenatal clinic is, one, if a mother, for example, has an issue, it can be captured early, any potential concern early enough, and any risk can be mitigated in good time. During the visits, there are quite a number of investigations which are done on this mother. For example, we need to know the blood group of the mother. We need to know the hemoglobin level, that is the HB. We need to run tests like malaria test. We need to run hepatitis test. We need to do a syphilis test. And these are very important in preparation for the mother and the newborn baby.
Expectant mothers, we encourage them to come for antenatal first before they come to labor suit, because there are so many things that happen in antenatal, and the antenatal care means taking care of those mothers, educating them on what will happen during their time or their pregnancy and even labor, plus delivery and even after delivery. So we expect mothers to come for antenatal classes before they come for delivery.
During the antenatal classes are very, very important.
The maternity services provided at Nakasero Hospital include antenatal care, labor and delivery, as well as postnatal care services. The care is provided by a group of obstetricians and gynecologists, as well as midwives, pediatricians, and other support staff necessary to make your delivery process a pleasurable experience.
The importance of the antenatal clinic is, one, if a mother, for example, has an issue,
It can be captured early, any potential concern early enough, and any risk can be mitigated in good time. During the visits, there are quite a number of investigations which are done on this mother. For example, we need to know the blood group of the mother. We need to know the hemoglobin level, that is the HB. We need to run tests like malaria test. We need to run hepatitis test. We need to do a syphilis test. And these are very important in preparation for the mother and the newborn baby.
Expectant mothers, we encourage them to come for antenatal first before they come to labor suit, because there are so many things that happen in antenatal, and the antenatal care means taking care of those mothers, educating them on what will happen during their time or their pregnancy and even labor plus delivery and even after delivery. So we expect mothers to come for antenatal classes before they come for delivery.
During the antenatal classes are very, very important, and in other words, these are birthing or parenting classes. The mother is prepared with the partner on the arrival of the newborn babies. Different topics are given at different trimesters, depending on the gestation. For example, in the first trimester, we take mothers through how to handle minor disorders of pregnancy. Mothers who are having morning sickness, headache, they are taken through that. We take them through breastfeeding classes. We take them through labor and delivery, so that by the time the mother is getting ready for delivery, they understand what is going to happen, what they are going to go through. And in the event the mother is told that you are not able to deliver normally, you need to be taken for a cesarean section, they really understand what is happening.
For you to achieve the maximum benefit from your antenatal care, you need to start attending the antenatal clinics as soon as you realize you're pregnant.
Labor suit is where we offer the labor and delivery or the intrapartum period. This is whereby the mother will be in labor, the mother will be supported until delivery happens. After delivery, the mother now gets in immediately, the placenta is delivered, the mother starts what we call the postnatal period.